Okay. Understood, right? لازم كده عشان so good morning, everyone. Good afternoon. Program related to infertility, discussing various issues. We are going to start by different aspects, and I think you received the agenda. So I will have a quick revision for what we are going to do over that day, because we have many presentations, which is very strong and filled with multiple information and very strong information related to fertility in general. So we are expecting to start now and expecting to end by 7 p.m. We are going to start by Dr. Mohandes, who is going to address us regarding to what's called American Association and the activity. It gives me a great pleasure to present her first to give us an idea about the various activity of the American Association, which gives us this chance to meet together and to present this wonderful meeting. After that, we are going to start our meeting by general consideration for infertility, and this will include general information related to infertility, which will help everyone for general counseling, followed by male factor of infertility, and we are going to discuss 2 issues, followed by ovulation induction, 3 issues, and frozen cycle management, 2 issues, and surgical management from England. Professor Hassan Mosh is going to address us regarding the management of extensive endometriosis. And lastly, would be fertility preservation. And at the end of the day, we are going to collect all the information in the form of 2 lectures. One of them, I'm going to present the evidence-based in infertility in general. And Professor Al-Nashar is going to present the new issue recommendation related to conference issue in year 2022. Let's start by okay. So may I give the lead to Professor Hassan Abdul Ghaffar. He is the head of the Saudi Society of Obstetrics and Gynecology, and is one of the pioneers in the field of infertility, and as well is one of the biggest colleagues in this presenting issue. He's going to present some sort of information and present himself. And afterwards, we are going to introduce Dr. Nagwal Mohandes, the director of the organization that is responsible for this meeting. So, Dr. Hassan, how are you? Dr. Abdul Ghaffar, are you there? Dr. Hassan.
أيوة
You hear
السلام
me?
عليكم.
عليكم
أيوة
السلام ورحمة الله وبركاته. Okay.
Yes. بسم الله والحمد لله والصلاة والسلام على رسول الله. Today I'm really happy to join this very important, I would like to call it course. It's a course of IVF and infertility. When I saw the program and we sat together and we choose eminent speakers, very good topics, and it will be a very good day, repeated lecture with a lot of knowledge. I would like to thank Dr. Yasser for his contribution and his effort in this. I'd like to thank the American Association, and I'm very happy to be with you. And I'm sure all the speakers, they are happy also. And the audience will be, and the candidate will be happy regarding what is going to be presented today. I think Dr. Yasser, he can start the meeting now, and we will join together and we will see a lot of knowledge and information. Thank you very much.
Thank you, Professor Hassan. It's my great pleasure to meet you. And I would like to see you very soon in Egypt. So we're going to share together the introducing every member who is going to present sessions. First, allow me to introduce Ms. Nagwa Al-Muhandis, who is the director of the American Association. She is going to address us regarding what's American Association, and it gives me a great honor and a pleasure as well to thank her very much to sponsor this meeting. Thank you very much, and I'm going to let her to present herself.
Thank you, Professor. Thank you, Professor Yasser Abu Talib, and thank you, Professor Hassan Jabbar, and thank you all for attending this event and wishing you all the best. Okay, I'm fine now. Proceed. Okay. Hello, welcome all. Dear all, thank you for attending our event today, the second hub for infertility and VRT, and wishing you all the best. And we are hoping to get the full benefits you are searching for. Just give me 5 minutes to talk about American Association and what the role we do in our healthcare community. Actually, American Association have 4 offices, in one in Delaware, and second one in San Francisco, and Egypt, Cairo, and UAE and Dubai. And this part of registration paper for American Association for Continuous Medical Education. And we want to tell you why American Association was created. American Association created for healthcare professionals' continuous development because that we are caring and your developments are concerned. American Association providing quality-based learning programs that are geared toward helping physicians to achieve their professional career goals. With up-to-date knowledge, techniques and technical support, enhanced learner competencies, and practical practice performance and patient satisfaction. Actually, we are working with different organizations, different places in the world to guarantee the quality which we provide to our healthcare professionals. As we fully accredited by American Association of Continuing Medical Education in San Francisco, and we are considering as a regional office for them in the MENA region, which consists of Middle East and North Africa, And also we have full accreditation from Dubai Health Authority and the American Accreditation Council for Continuing Medical Education, which accredits the full, accredits most of world healthcares. And from Egypt, we have National Quality Institute accreditation, and we are considered one of the 5 training organizations in the Middle East, which we got the ISO 21. ISO 21, it means the ISO industry training, okay? And ISO 29001, it means that we have a very good program, management program system. Actually, we have a good relationship with Jordanian Medical Association and Jordanian Society for Obstetric and Gynecology, Sharjah University, and different places, and Dubai Health Authority, of course, and different places in the world. Actually, our vision, we are nationally and we are aiming to be nationally and internationally acclaimed as leader to continuous medical education. So we are doing our best by getting information, by getting accreditation from different places in the world. And the word of accreditation not means just taking a certificate or just paper. We have in this whole organization a scientific committee, in high standard scientific committee. They are revising and approved our curriculum and our programs. In continuous medical education, we are following the healthcare, the World Health Organization standard in continuous medical education, which American Association said, which WHO said that continuous medical education must meet the local community. And we here in American Association, we are trying to meet the medical and the local community needs by developing programs which suitable for these post communities. Okay. By providing a professional practical medical training and a professional academic medical training. For our corporate social responsibility, and we are believing that we have to support all healthcare professionals, and we starting to do something like something called gynecological hub, and also we have a dermatological hub and the internal medicine hub and pediatric hub. In this hub, we aiming this year, inshallah, to provide 5 programs, successful programs. We start in May, endoscopic surgeries, and by Professor Dr. Amr Husseini. And today we are starting infertility and ERT with our Professor Yasser Abu Talib and Professor Hassan Abdul Jabbar, and a lot of professors who are great professors. They have a very good ideas and they have very good international experience, and they will provide you by academic and practical knowledge related to infertility and IVF, and with us in ultrasound and aesthetic gynecology and urogynecology hub. Thank you for listening to me, and I wish to get the full benefits you need from this hub, and waiting your question. And all this.
So again, welcome with everyone. I think we're approaching now 400 persons. Welcome everyone again. And I hope to enjoy this day. By the way, we received, as we see here, lots of questions. It's loads, actually, I cannot count it, but it seems that it's maybe 50, 100 questions, something like that. So it will be me and Professor Hassan Abdul Jabbar that is going to take the lead for answering most of these questions. Hope to be supportive for your information and to increase your information, and hope to reply and to answer all the questions as well. Okay, let's start our presentation. So the first part of the day will be general information, just as an introduction for what we're going to say afterwards. So may I introduce Professor Dr. Ahmed Abdelhamid. He's a professor of obstetrics and gynecology and the director of the psychiatry hospital of Adel Sadeh Hospital. He is going to address us regarding to the complex relationship between infertility and psychological distress. Let's begin. He's going to address us regarding to the complex.
Good afternoon, everyone, and welcome to my presentation. First of all, let me thank you all for being time today attending my presentation. Our title is the complex relationship between infertility and psychological distress. Infertility is defined as the inability to procreate or carry or deliver a baby naturally. The World Health Organization definition of infertility is referred to as failure of conception following a trial period of 24 months. Women who can get pregnant but have recurrent miscarriage are also considered to be infertile. Infertility affects an estimated 10 to 15% of reproductive age couples worldwide. The increase in couples seeking fertility treatment is due to one of the three, or all of the three. First of all, postponement of childbearing in women. Second thing, newer, more successful techniques for treatment. Third thing, increased publicity of these techniques. The relationship between infertility and psychological stress is considered very complex issue, as multiple studies indicates that infertile couples are subject to greater stress and have an increased risk of developing psychological disorders compared with healthy couples. On the other hand, high levels of psychological distress have been revealed to increase infertility. Let us discuss stress of infertility. Infertility can cause either one or all of the following: psychological distress, emotional distress, financial difficulties for both partners. Typical reaction to infertility include shock, sadness, depression, anger, and frustration, loss of self-esteem, loss of self-confidence, and a general loss of sense of control. The high stress of infertility might be attributed to the fact having a child is considered to be important. Couples often conceal their emotions, ideas, and beliefs because infertility is still considered to be a private subject, resulting in exposure to social pressure. Society may provide views and suggestions that may cause further distress. Therefore, couples with infertility problem may reduce social interaction, especially with pregnant women and friends who have already children. Infertility may negatively impair an individual's self-esteem, as female reactions to infertility may include submission and docility, self-isolation, and internalization of anger and sadness. Women with infertility were revealed to have a negative perception about themselves and their sexuality. Psychological stress is also perceived as a potential clinical risk factor that may reduce male fertility and sadness. Numerous studies succeed in demonstrating that an inverse relationship exists between psychological stress and semen parameters. These studies demonstrate that men from couples who fail to achieve pregnancy despite treatment will experience negative feelings such as frustration and disappointment due to prolonged effort and expensive costs. In addition to the psychological side effects that may occur from infertility itself, a range of other side effects can be caused by hormones and drugs used to treat infertility, as it may trigger anxiety, disruptions of sleep and depression, mania, inability, and difficulty in concentrating. For example, some drugs we are, as a gynecologist, use letrozole, which is an estrogen receptor blocker, may cause severe headaches, dizziness, fatigue, breast pain, or an abnormal cycles. Logron, used in the treatment of infertility, has been indicated to cause mood swing, depression, and anxiety symptoms, vaginal dryness, acne, joint pain, and decreased sex drive. Clomid, which is estrogen receptor blocker, can cause abnormal discomfort, weight gain, abnormal menstrual bleeding. Gonadotropins, which is injectable hormones, can cause respiratory tract infection, mood swings, acne, weight gain, injection site soreness, and redness. The oral contraceptives, which is used in IVF treatment, can cause depression, weight gain. Now, what's the psychological factors as a reason for infertility? Women's emotional stress can be led to tubal spasm, anovulations, and vaginismus. In men, impotence is caused by psychological triggers as previous psychological traumas, eating disorders, and overprotective and affectionate mothers, whom indicated to be among the main psychological causes of impotence. Correlation between psychological disorders and infertility. In a study on 112 females with infertility, some types of psychiatric disorders, for example, anxiety and depression, were indicated to be present in 40% of the participants. Furthermore, the most prevalent diagnosis in women with infertility in Japan was an anxiety disorder, 23%, mild depressive disorder, 17%, and dysthymic disorder, 9.8%. In an 11,000-person study conducted in an American community, generalized anxiety disorder was also found to be significantly associated with infertility. The prevalence of anxiety among the infertile groups was higher compared with patient diagnosed with HIV, cancer, heart disease. In addition, previous studies have indicated that alcohol, drug addiction are relevant among individuals with infertility. In the same studies, it was also disclosed that there was a greater level of depression and anxiety in infertility patients, and a lower level of mental composure linked to personality traits. Variables that may mediate the correlation between psychological disorders and infertility. First of all, insufficient psychological assistance, ineffective therapy, low socioeconomic status, lack of partner assistance. Also, it has been reported that unexplained infertility is associated not only with elevated levels of anxiety, but also with high levels of stress, while genetic infertility is indicated to be more associated with depression. Furthermore, previous studies stated that the period of infertility was more dependent on depression level rather than the duration of the period. It was noted that as the duration of infertility increases, depression, anxiety, or other psychological disorder may also increase. What are the psychological therapies that may help? First of all, relaxation techniques, which is very important. Second thing, meditation and yoga. Yes. Third thing, psychotherapy. What's the psychotherapy that can treat or help in that cases? Psychotherapy should be recommended for couples suffering from any form of infertility. Counseling should ideally begin before patients start any medical intervention to help with infertility. Studies have indicated that interpersonal treatment, which focus on enhancing relationships or resolving disputes with others, and CBT, cognitive behavior therapy, can help patients with infertility, with depression, and anxiety. Psychotherapy help both coping strategies or assist in decision-making during treatment. We reach the conclusion that the diagnosis of infertility can be an overwhelming burden for couples. This diagnosis may lead to major psychiatric disorder such as depression, anxiety, and low self-esteem. Couples should be offered counseling and support as they undergo infertility treatment. Psychological intervention for couples with infertility have the capacity to reduce symptoms of anxiety and depression and significantly increase pregnancy rate. Therefore, although the psychological effects of infertility can be significant, the majority of patients can be helped with the proper intervention to achieve some type of resolution, where individuals become parents to be biological kids, adopt kids, or decide not have children. Thank you. I hope the presentation can be of value to all of you. Thank you.
Professor, do you want me to present the next speaker? Yeah. Professor, can you hear me? Maybe I should present the next speaker then. The next speaker is Professor Adil Shafiq Salahuddin. He's going to talk about something very interesting. Are they different? The IVF baby, are they normal? Are they different? Are they smarter than the normal baby? Are they? So we can hear from Professor Adil about IVF babies. Please, Prof. Adil.
It's my pleasure and honor to be here with you today in this extremely important and distinguished scientific day with the American Association. I would like to express my deep gratitude and thanks to the American Association for their continuous effort in continuous medical education. To start with, I am Professor Adil Shafiq, Professor of Gynecology at Shams University. Our topic today is about IVF babies. Are they different or not? كلنا نفتكر اول طفله اطفال انابيب اتولدت في العالم الحقيقه كانت سويت براون. كلنا عارفين انها اتولدت 25/7/1978. فتره طويله فاتت الحقيقه، وكانت احتفلت بعيد ميلادها ال40 عندنا في مصر في مؤتمر امراض النساء بتاعنا سنه 2018. من بعدها ابتدت وتختفي، يعني استغربوا ان الدوله الثانيه اللي في العالم اللي بعد انجلترا اللي ابتدى يبقى فيها IVF بيبيز كانت استراليا، مش امريكا. اتولدت في استراليا كاندي 3 سنه 1980. تلاها السنه اللي بعدها على طول اليزابيث جوردن كار، في اول IVF بيبي اتولدت في الستيت في امريكا، اتولدت سنه 1981. من بعدها بقى ابتدى العالم كله ابتدى يزيد في حالات IVF وورلد وايد. اعتقد ان مفيش دوله في العالم دلوقتي حوالي 8 مليون طفل في العالم اتولدوا عن طريق الاسيستد ريبرودكشن. كل سنه وورلد وايد في حوالي 2 مليون تريتمنت سايكل بري، وحوالي هاف مليون بيبيز ار ناو بورن ايتش يير. 2 مليون سايكل وحوالي نص مليون. ده يقول لنا برضو معلومه ان ارقام IVF في العالم كله تيك هوم بيبي نسبه ان انا اخد اطفال من الحقن المجهري تكون حوالي 25 الى 30%، لكن الرقم ملفت للانتباه 2 مليون دوره حقن مجهري في العالم، معنى كده اعداد كبيره جدا وبتزيد. يا ترى ايه الاوتكم ميجرز بتاعت IVF؟ انا لما ابتدي اعمل IVF سايكل او ابتدي اعمل IVF بروجرام، هعمل مركز اطفال انابيب، اقيم نتائجه ازاي او اقيم النجاح ازاي؟ في عندنا الحقيقه كذا معيار. اول حاجه البايوكيميكال بريجنسي ريت، مجرد ان السيده تعمل اختبار الحمل ويطلع بريجنسي ريت بتاعها. ده الحقيقه مؤشر، لكنه مش مؤشر الدقيق. كل ست عايزه مش مجرد بس انها تحمل، لا كمان انها تكمل حملها. وبالتالي يبقى في عندنا حاجه اسمها كلينيكال بريجنسي ريت. كلينيكال بريجنسي ريت انا مش بس اعمل فيتا سابيليتي يطلع بوزيتيف، لا كمان الاقي الترا ساوند بيكتشر الاقي فيها ساك مثل. وبرده الحقيقه مش ده الاتموست امبورتنت او ده الاتموست سكسس، لا احنا عايزين يبقى في اون جوينج بريجنسي ريت، يعني الحمل يكون مكمل معدي ال 10 اسابيع او معدي الثيرد ترايمستر، وصل كمان للسكند ترايمستر. لكن بكل تاكيد اهم حاجه عندنا في IVF هو التيك هوم بيبي. الحقيقه في ناس كتير جدا بتبتدي سايكل ممكن ما تحملش او ممكن تحمل ويحصل ابورت في الاخر عند البيشنت سيان، او سواء هي في الاخر ما وصلتش الاوتكم بتاعها. عشان كده دلوقتي احنا لما بنيجي نقارن اي ستادي مثلا بستادي او اقارن مركز بمركز او بلد ببلد، مش بقارن خالص البايوكيميكال بريجنسي ريت ولا الكلينيكال بريجنسي ريت، انا بقارن التيك هوم بيبي. كام معانا ستارت الIVF سايكل وكام معانا خرجت بطفل او خرجت بيبي. هي ده الاهم، وهو ده البروسيس بتاعنا كلنا. الحقيقه ده البروسيس ستوري بتاعنا كلنا اللي احنا في المجال بتاعنا بنحاول نوصل لها. عنوان المحاضره بتاعتنا IVF بيبي which of which، هل هم مونستر ولا هل هم انجل؟ في ناس الحقيقه بتتخيل ان IVF بيبيز دولت هيبقوا دايما معرضين لمشاكل كثيره جدا ومشاكلهم اكثر كثيرا من الناتشرال كونسبشن، وكلهم هينزلوا مشوهين. وفعلا في عيانين يجوا يسالنا هو يعني الطفل ده هينزل سليم او هينزل عادي؟ عندهم دايما كونسبت ان الطفل ده هينزل كله تشوهات. والعكس بالعكس، بعض البيشنتس وبعض زمايلنا عندهم اعتقاد ان انا طالما هعمل IVF بيبي فانا منقي احسن الاطفال ومنقي احسن الاجنه، فالطفل لازم هينزل سليم تماما 100% غير معرض لاي امراض. الحقيقه في النص ما بين الاثنين لا ده ولا ده. هو ده عنوان المحاضره بتاعتنا اللي احنا هنقدر نكلمه وندرسه دلوقتي ان شاء الله. احنا دلوقتي ابتدى يبقى في 8 مليون اي في اف بيبيز، ابتدى يبقى في ستاديز وستاتستكس قويه عكس زمان تقدر تقارن الاي في اف بيبيز بالناتشرال كونسيف بيبيز. الحقيقه المعلومات بتاعتنا كلها ابديتد من اب تو ديت. اول حاجه في الاي ار تي اوت كم، الانسنس اوف سبونتينيوس ابورشن، هل الابورشن اكثر ولا اقل في العيانين اللي حملوا بالكونسبشن؟ الحقيقه الابورشن ريت فيهم حوالي 16%. 16%. الحقيقه الاستاذ بتقول ان هو تقريبا نفس النسبه اللي في ناتشرال كونسيف. يبقى الاي في اف مش بيزود الاي بتاعت الابورشن. لكن في بعض الاستاذ قالت ان لو احنا الحمل ده حصل عن طريق الفروزن امبريز ممكن يبقى فيه نسبه اعلى بسيطه جدا من السبونتينيوس ابورشن. لكن ان جنرال هي نفس البرسنتج، اولموست 16%. الميزه بتاعت الاكتوبيك بريجننت، في ناس بتتخيل انا طالما عامل اي في اف انا حاطط البيبي داخل تجويف في الرحم اتس امبوسيبل ان هو يحصل اكتوبيك بريجننت. الحقيقه لا، هي نفس البرسنتج بالظبط، هي 0.7% بير سايكل يحصل اكتوبيك بريجننت. اللي اعلى بكتير جدا الحقيقه في الاكتوبيك الدسكشن هي الانسنس اوف هيتيروتوبيك بريجننت. الناتشرالي كونسيف واحده من 100 كل اكتوبيك بتطلع هيتيروتوبيك بريجننت في الاسيست كونسبشن، انما في الناتشرال كونسبشن واحد كل 30,000. فكان نسبه الهيتيروتوبيك بريجننت اعلى بكتير جدا في الاي في اف بيبيز او في ار تي اوت. المالتيبل جيستيشن دي مش محتاجه ان احنا نتكلم فيها طبعا، بكل تاكيد نسبه التوينز اعلى بكتير جدا في الاي في اف. احنا لما بنيجي نعمل ايمج ترانسفير احنا بنحط اجينا عدد اكثر من واحد، ممكن 2 أو 3، وكده ده بيزود جدا الانسيدنس بتاعت المالتيبل جيستيشن وخصوصا التوينز. في اليونايتد ستيتس 2014 حوالي 40% of ART infants were part of multiple births as compared to 3.5% of naturally conceived infants. فرق كبير جدا، وفعلا اي في اف بيزود الانسيدنس بتاعت التويننج والهاي اوردر بريجنسي كمان. الحقيقه في الستيت دي الاستادي او دي الجراف اللي بيبين لنا البرسنتج بتاع التوين بريجنسي، وكان بيبتدي يزيد لحد ما وصل للبيك بتاعته في 2010. التريبل بريجنسي وصلت للبيك بتاعتها في سنه 2000 وابتدت تقل. ليه ابتدت تقل؟ الحقيقه الحاجتين. اول حاجه ان يبقى في رول ان احنا ما نحطش عدد اجنه كتير زي ما هنتكلم بعد كده في المحاضره. والحاجه الثانيه ابتدى يبقى في عمليه زي كتير ان هي اسمها الفيتا ريدكشن او سلكتيف فيتا ريدكشن، ما بقوش يسمحوا للتريبل ان هم يكملوا ويعملوا فيتا ريدكشن ونكمل باثنين، فده ساهم جدا في ان الريت بتاع التريبل ابتدى يقل. دي الامريكان سوسايتي اوف ريبرودكتيف ميديسن جايد لاينز 2021 اللي بتقول عدد الاجنه اللي احنا المفروض نزرعها. مش هندخل في التفاصيل لان السلايد دي لوحدها محتاجه محاضره كامله، لكن ان جنرال لو احنا عاملين جينيتك تيستنج سي جي تي اي في جينيتك تيستنج اوف انيبلويدي ومتاكدين ان احنا هنحط انيبلويد امبريو ما نزرعش اكتر من جنين واحد ريجاردلس عن الايدج بتاع السن. لو العينه لها فيفربل اوتكم برضه بنزرع جنين واحد بس في السن الصغير، لو السن اكتر من كده بنزرع اثنين فقط. هذا يمكن مش ماشي مع البراكتس بتاعتنا في مصر قوي، لان العيانين في مصر لو زرعت لها جنين واحد او اثنين هتحس ان احنا قصرنا في حقها وان ده قلل فرصها في الحمل لكن دي الامريكان جايد لاينز المفروض تبقى ستاندرد عشان نقلل الانسنس بتاعت التويننج والمالتيبل بريجنسي. في الاي ار تي اوتكم كمان البروبورشن اوف مونوزايجوتيك توينز، الحقيقه الفريكونسي اوف مونوزايجوتيك توينز is also increased from 0.4 to 1 to 5% of pregnancy. The increase in monozygotic twinning has been attributed to the in vitro culture to the extended duration of culture، يعني البلاستوسيست ستيج. وبالتالي proportion of monozygotic twins اعلى بكل تاكيد في الاي في اس. الحقيقه نقطه مهمه وخطيره جدا وكروشال هي الفري تيرم ليبر. ده الرعب الرئيسي بتاع اي دكتور بيشتغل اسيست بعد ما العينه تحمل هتكمل ولا مش هتكمل. الحقيقه كلنا عارفين ان التين بريجنسي عندهم برسنتج او نسبه اعلى من حدوث الولاده المبكره اكثر من الناتشرال كونسيفد توينز. الاي في اف توينز اكثر من سنجل، الاي في اف توينز بقى اكثر حوالي 25%. يعني اي في اف توينز نسبه الفري تيرم ليبر فيهم حوالي 25% اكثر من السبونتينيوس توينز. الحقيقه غريب، وكان غريب بالنسبه لي جدا لما قريته ان ايفن الاي في اف سنجل بيبي عندهم 2 فولد برسنتج انكريز في الفري تيرم ليبر. يعني حتى لو الست حامل في بيبي واحد وهي حامل عن طريق الاي في اف برسنتج بتاعت الفري تيرم ليبر 2 فولد عن لو كانت حامل سبونتينيوس. الحقيقه اجين سنجل اي في اف بيبي still demonstrate increased risk of low birth weight compared to naturally conceived singles. السبب الرئيسي لحد دلوقتي الحقيقه ما حدش عارف ليه الاي في اف لوحده او العين الكونسيفد الاي في اف عندهم انسلنس اعلى للبريتيرم ليبر مش معروف. الناس بتقول ده نتيجه الاي ار تي بروسيدور نفسها، نتيجه عمليه الحقن المجهري نفسها. الناس بتقول ده تريتمنت انجزايتي بايرس، الست بتبقى قلقانه جدا، جوزها قلقان جدا، الدكتور بتاعهم قلقان جدا، وبالتالي مع اي مشكله بسيطه بنضطر نولد بدري. يعني الست ضغطها ابتدى يعلى شويه، ديكريس كيكال الحاجات اللي ممكن تعدي في الحمل العادي ونستنى الدكتور مش قادر يستنى عليها عشان خاطر في فريكونت مونيتورنج وانترفنشن، ايرلي انترفنشن، فده ممكن يسبب بنسبه كبيره في بري تيرم ليبر. في ناس بتقول لا هي بري تيرم ليبر اعلى عشان خاطر السب فيرتيليتي بيرسي، عشان خاطر المشاكل اللي عامله اصلا تاخير الحمل سواء البي تي او او الاوبيسيتي او لكن ساينتفكلي ما حدش قادر يحدد ليه سبب البري تيرم ليبر اعلى، لكن بكل تاكيد هي اعلى سواء في السنجل او في التوين بريجنسي. الحقيقه مشكله البري تيرم ليبر في مصر عندنا اكبر بكتير، ان احنا ما عندناش ريجليشنز النمبر اوف امبري ترانسفير مع الاسف. الحقيقه في مراكز بتزرع 3 و4 و5 وشفناها. الحقيقه كمان الريلاتيفلي لو كوست اوف اي في اف سيرفيس، وما نستغربش الحكايه دي. والاي في اف ممكن يبقى غالي بالنسبه لبعض المرضى في مصر، لكن الحقيقه لو قارناه ببعض الدول العربيه او بعض دول العالم كمان هنلاقي ان الاي في اف سايكل في مصر تعتبر من ارخص السايكلز في العالم. What adds to our problem is the absence of sufficient neonatal ICU service all over Egypt. زي ما احنا عارفين في جهود كبيره جدا بتبذل، لكن لحد دلوقتي في مشكله في الحضانات في مصر نتعشى منها تتحل بسرعه ان شاء الله. والحقيقه universal absence of proper strategy to prevent preterm labor in twin pregnancy. احنا عارفين ان الطريقتين الرئيسيتين عشان نقلل نسبه الولاده المبكره، يا اما نعمل cervical fertilization او ندي progesterone supplementation progesterone therapy. الحقيقه الاثنين proved to be not efficient in twin pregnancy. لا السيرفيلاج بيجيب نتيجه ولا البروجستيرون بيجيب نتيجه. فالحقيقه الاثنين اللي هي الطرق الرئيسيه بروف نوت تو بي بينيفيشال في التوين بريجنسي، وبالتالي دي كلها بتزود مشاكل البريتيرم ليبر في الاي في اف. Frozen embryo transfer are associated with decrease in small gestational age, low birth weight, and preterm birth. في ستادز قالت ان frozen embryo transfer الاوتكم بتاعهم احسن شويه، اقل شويه في البريتيرم ليبر، ويقال ان ده نتيجه ان more natural uterine preparation tied to frozen embryo transfer. ان ده possibly allowing more natural presentation زي اللي بيحصل في السيميليتر سايكل او في الفريش سايكل. وبالتالي فروزن امبريو ترانسفير في بعض الاحيان ممكن تقلل الانسنس بتاعت البريتيرم ليبر وديكريس فورس جيستيشنال ايج. What about other outcomes? neurodevelopmental issues. ناس كتير حاجه جدا بتقلق ان اي في اس بيبيز يكونوا مختلفين، يكون عندهم سايكوموتر كوجنيتيف اور بيهيفيرال اور ايموشنال ديفلوبمنت اور اذر منتال ديسوردرز. الحقيقه معظم الاستادز لقيت ان هم نفس البرسنتج مع الناتشرال كونسيف، وكمان الريسك اوف اوتيزم هو نفس البرسنتج. لكن نحط في دماغنا ان التوين بريجنسي اعلى بكتير جدا في الاي في اف، والبريتيرم ليبر اعلى، وبالتالي النيورو ديفلوبمنتال ديسوردرز اللي موجوده مع التوينز ومع البريتيرم ليبر بتبقى اعلى نتيجه البريتيرم ليبر مش نتيجه الاي في اف لوحدها بس. الكونجنتال انوماليز دي حاجه مهمه جدا، ودي الرعب الاساسي للعيان. الحقيقه البوبوليشن بيز لاين ريسك من 2 ل 4%. Its potential increased by 1/3 by 1/3 with ART. يعني لو كان النورمال ريسك 3% فالنورمال ريسك في الاي اف ال 4%. The exact cause is not known, but it might be related to infertility itself or to factors related to a procedure or both. كلنا عارفين كمان ان vanishing twins و other differences between patients and control may also play a role. لكن الستادز بتقول ان الكونجنتال انوماليز اعلى بنسبه 1/3 في البيشنت اللي conceived by ART. Chromosomal and genetic abnormalities. Studies have not shown a higher prevalence of karyotype abnormalities, including mosaicism, in offspring of IVF conceived pregnancy than in naturally conceived pregnancy. Cancer risk and very striking even to me. In 2013, a systematic review and meta-analysis, including 25 case-controlled and 4 studies, reported an association between fertility treatment and cancer in offspring. ومن بعدها ابتدى يبقى في ستاديز كتيره جدا، اتعملت في النرويج، لقوا ان في بعض specific types of cancer are increased in medical assisted reproduction, especially leukemia, neuroblastomas, and retinoblastomas. Regarding to obstetric complications اللي احنا بنقابلها بقى كل يوم وبنشوفها كل يوم، حتى الناس اللي شغاله اي في اف بتقابلها كل يوم. فIVF has been associated with increased risk of pregnancy complications such as placenta previa, placenta abruption, gestational diabetes, preeclampsia, and cesarean delivery. زي ما احنا كلنا عارفين وبنشوف متاكدين ان الكومبليكيشن دي كلها اعلى في العيانين اللي conceived by ART عن البيشنت اللي not conceived by ART. Regarding the perinatal mortality, stillbirth and perinatal mortality rates appear to be increased as much as 4-fold due to at least in part to obstetric complications اللي احنا لسه قايلينها نتيجه low birth weight ونتيجه multiple gestation. في اليونايتد ستيتس مثلا stillbirth rate after IVF is almost 0.6%، وده اعلى من الناتشرال conceived pregnancy. very astonishing الحقيقه ان السكس ريشيو ات بيرث. طب كتير جدا لقيت ان الاي في اف بيقلل او بيغير السكس ريشيو. يعني ART procedure appears to have small but statistically significant effects. The male to female ratio is approximately 10% lower after XD than after IVF. Long-term issues, some studies have reported an increased risk of asthma in children conceived by ART. My take-home message for you is that pregnancies conceived by ART are associated with increased risk of multiple gestation, congenital anomalies, preterm delivery, low birth weight, and the complications associated with these outcomes. ART per se doesn't affect neurodevelopmental disorders. ART is associated with a slight increase in some specific childhood malignancies and bronchial asthma. Apart from the increased incidence of prematurity, all other increased risks are minor. To conclude الحقيقه انا بحب دايما اعمل حضرتك او افكر حضرتك في مؤتمر جامعه عين شمس الاسوزك ده هيبقى موجود يوم 26 27 2022. اتمنى من حضرتك كل الساده المشاركين او المشاهدين يشرفونا طبعا في المؤتمر بتاعنا باذن الله. وجزيل الشكر طبعا للامريكان اسوسيشن على اليوم العلمي الجميل ده. and thank you very much.
Okay, thank you very much. Maybe some persons or some of our colleagues cannot understand Arabic well. So we are so sorry for that, but I think the presentation was crystal clear. And if you want to have any questions, please put it down and we'll have a special session to discuss in details all the questions and the answers as well. May I introduce the coming speaker? Is Professor Mahmoud Suleiman. Professor Mahmoud Suleiman is Professor of Obstetrics and Gynecology in Cairo University, and he is going to present a very nice presentation regarding to the relation between the age and the XE. Is advanced maternal age has an effect on XE or not? Let's start the presentation. Okay, so if you have any questions, tell Professor Mahmoud Suleiman prepare himself. If you want to have any questions for the time being, I think the first session was wonderful regarding to the counseling as regard to the medication that you are going to use. So I think it's very important to discuss with the side effects of the medication before starting the assisted reproduction course. خلينا نبتدي بدكتور حسن شاكر. Okay, so any question for the time being? Dr. Mahmoud is preparing himself. So any question from any colleague? Okay, so can you hear me well? I think that many of you mentioned that we have a sort of problem with the voice. Okay, so I have received a question here regarding to treatment of patient with primary amenorrhea with infantile uterus. And her TSH, prolactin is normal, but FSH is low. Okay. Let me to be crystal clear. So I think I forgot to introduce myself. I am Professor Yasser Abu Talib and the Professor of Obstetrics and Gynecology at Shams University and the Armed Force College of Medicine. I am examiner back in the Royal College of Obstetrics and Gynecology. My specialty is assisted reproduction and pelvic floor surgery. So let me be very crystal clear. There is nothing called infantile uterus at all. Forget about it. If we have infantile uterus, mean that it's small size uterus. It means that there is no enough estrogen and progesterone affecting the uterus. So it has not the capability to increase in size. So you have to check. We have two things. If the ultrasound said that it's infantile and cannot see the uterus, you must be sure that if there are uterus or not, because sometimes we might imagine that there is a womb there and there are no uterus. It's Mullerian agenesis, so we have to confirm this situation by MRI. If no uterus at all, or what's called uterine knob, so it's Mullerian agenesis or testicular feminization syndrome. You have to do chromosomal study. If it's XY, you have to check for the testis and remove. Meanwhile, if it's XX, so it's Mullerian agenesis, the problem that she will never become pregnant, she will never have menstruation, and as well, she will have a very short vagina. The only thing that we can offer her is artificial vagina. We have many things, many. William operation, but can do anything. If we have a small size womb, it means that for a long time, she has not enough estrogen and progesterone, and the cause will be one of two things. Either the FSH and LH coming from the pituitary is very low, so it's hypogonadotrophic hypogonadism. So in this case, you just give her, if you want to prepare for conception, give her regular estrogen progesterone. So it's cyclic estrogen progesterone. Here in Egypt, it's called cyclopreginova. So it's estrogen followed by progesterone for 3 to 4 months. Afterwards, it starts to induce ovulation to become pregnant. How would that? By giving her FSH and LH, human menopausal gonadotropins. Okay? So she will become pregnant and forget about infantile uterus. The other cause might be menopausal, means that FSH and LH is very high, means that there is no follicle at all. So there is no estrogen and progesterone as well. In that case, you have to give her hormonal replacement therapy. So there is no infantile uterus. Infantile uterus due to hypogonadotrophic hypogonadism means that she is in need to induce ovulation. How can you induce? If the FSH and LH is low, by human menopausal gonadotropins. It's not allowed to use purified FSH alone, but you must have equal amount of FSH and LH. Okay, thank you very much. And let's go now for the presentation, and we will discuss all your questions afterwards, okay, in details. So it gives me a pleasure to introduce my colleague. It's Mahmoud Suleiman. Professor Mahmoud Suleiman is Professor of Obstetrics and Gynecology in Cairo University, and he is going to address us regarding to the relation between the advanced maternal age and ICSI. Let's go for this presentation. Mahmoud.
Thanks a lot, Dr. Yasser Abu Talib, for this presentation and introduction. For me, I am Mahmoud Suleiman. I'm assistant professor in Cairo University. I would like to discuss today for the advanced maternal age in ICSI procedures. It's a very important topic for me and for all of us in our daily practice, because we are discussing a daily cases facing us having a poor responder, and we cannot manage or how to deal with the poor response and the low ovarian reserve that we have facing these patients, and facing the optimum protocol, or what are the recommendations that we must follow during management of these cases. So far, I will open the presentation to discuss with us the advanced maternal age. So we are talking about the advanced maternal age in ICSI procedures, the updates in this issue. Our agenda is about the advanced maternal age or maternal age and the poor ovarian reserve criteria, how to enhance ovarian response. This is the agenda of us, and how to enhance the embryo selection, and what about the future. All of us knowing that the advanced maternal age is the age of the maternal woman above 35 years, because it's associated with a decline in both ovarian reserve and oocyte competence. Nothing available nowadays, age-related fertility. However, different therapeutic approach can be offered for all women older than 35 undergoing ICSI procedures. But first, why above 35 is considered as advanced maternal age؟ ليه السن ده الوحيد الكات فاليو هو الكات فاليو بتاعنا في الادفانسد maternal age؟ Why we are not saying about 32, 30, 40? Why we choose the 35? Because statistically, the ovarian reserve fertility of the woman is decreasing in different parameters. Concerning the quantity, it decreased by age. Above this age, it decreased dramatically. Quality, because of some mitochondrial dysfunction, some shortening of the telomeres, that chromosomes, and even the embryo informed from this mother above 35, it has the increased miscarriage rate and the increase of the chromosomal abnormalities. So the cut value of 35 is chosen because statistically above 35, the quantity and the quality and the embryo quality is decreased above this age. So when the woman comes to your clinic, what will be your targets? Your targets either to prevent, to compensate, and to solve the problem. To prevent, try to make cryopreservation if she is not married, or she's a single, or she's not planning for doing now an ICSI procedure, or she postponing the fertility or something like that. Try to cryopreserve before this age. To compensate, to enhance ovarian response, how to enhance if some women come at 35, 38 years old, how to enhance ovarian response and how to enhance your embryo selection. Remember, 35, we are having a decrease in the quantity and the quality and the embryo. So to compensate that, if the woman is going to having an ICSI procedure, we must enhance these responses. And to solve, if we come to a woman with very poor responder, it's oocyte donation, and it have an ethical concerns. So to prevent, try to have a cryopreservation for this age. If the woman coming after this age, try to compensate the problems you will face during ICSI procedure. And to solve the problem is the only solution is oocyte donation, which have an ethical concerns. To deal with the advanced maternal age through ICSI procedure, we must know something, some important issues, that maternal age is among the strongest predictors of success. We must have this agreed. Maternal age is among the strongest predictor of the success. However, in ISRI, the prediction of ovarian response categorized by age alone is not sufficiently reliable. So although the age is the strongest predictor for your success, the age alone is not sufficiently reliable. So for our prediction for the high and low response to the controlled ovarian stimulation, we use the anterior follicle count and the anti-mullerian hormone. All the patients must have the first ultrasound transvaginal to calculate the anterior follicle count, and to do anti-mullerian hormone is recommended over the ovarian reserve tests, and this is a strong recommendations from the ISRI 2019. To categorize the patients, we have the Polonia criteria is the old one, and it was at least two of the following three features must be presented to define the poor ovarian response. To predict this patient will have a poor ovarian response, either two of three: the advanced maternal age over 40, a previous poor ovarian response, that the patient have another trial and they get not more than 3 oocytes, or an abnormal ovarian reserve test like AFC 5 to 7 follicles, or AMH 0.5 to 1.1 nanogram per milliliter. However, Poseidon classification, this is the newest classification, and that's what we are using nowadays. And we don't use Bologna classifications. We are using now Poseidon classifications, which states for patient-oriented strategies encompassing individualized oocytes number. These Poseidon criteria stratify a low prognostic patients, that we are categorized the patients into 4 main categories for the low prognostic patients. For the suboptimal response, if she have a normal marker less than 35 years old, so it's group 1, more than 35, and have a normal ovarian markers, reserve markers, so she would categorize in group 2. If she have a low ovarian reserve from AFC and anti-malarial hormone, it's a group 3 if she less than 35. If she's 35 or more, she would categorize in for a group 4. In group 1 or 2, the prediction, يعني أنا جالي النهارده in the clinic, we come in the clinic, some patient and categorized as a suboptimal response. She is in group 1 or 2, increased in the next cycle the FSH dose with addition of some LH during the controlled ovarian stimulation, عشان to overcome the hypothesis of ovarian hyposensitivity to gonadotropins. That we are saying that she have a good reserve, she have a good markers, and she get a suboptimal response. So we are increasing the doses. However, in the groups of 3 and 4, oocyte and embryo accumulation with cryopreservation is a solution with DEU stimulation. Increasing the number of oocyte collected, because our target to compensate, we must think in 2 issues. How to increase the number of oocyte collected to increase the chance of success after IVF or ICSI, to compensate the quantity and to compensate the quality. Yani, if you think, if you get more than oocytes, so you have a chance to increase, how to increase the quantity and how to increase the quality. Plus the enhancement of embryo selection via pre-implantation genetic testing. So how to enhance our ovarian response? So we are now in advanced maternal age and poor ovarian response criteria. We are depending on what we call the Poseidon classification. This Poseidon classification categorizes the patient in 1 and 2 and categorize the patient in 3 and 4 according to the ovarian reserve markers. And according to these ovarian reserve markers, we are going to see if she is in group 1 or 2, we are increasing the doses of FSH and LH. And if it's not have a poor ovarian reserve, so we are thinking about embryo selection and embryo collection and the cryopreservation with dual stimulation. So how to enhance our ovarian response? Protocols. What are the protocols must be used for this patient advanced maternal age? So the protocol recommended is GnRH antagonists versus GnRH agonists are equally recommended for the predicted low responders. Conditional. This is from ICSI guidelines. So if the patient, you choose the protocol of GnRH antagonist versus GnRH agonist are equally recommended. What about doses? To use 150 international unit versus 300 international unit, or 300 international unit versus 400 or more than 450. Adding columine straight, adding aromatase inhibitors. These all are questions. What are the doses to be used? This is the recommendations that higher gonadotropins more than 300 is not recommended. Because we have some, it's very strong, by the way, strong recommendation from the ICSI, not more than 300, not more than 300 international unit is not recommended for the predicted low responders. It will make no difference between the pregnancy rate or oocytes retrieved. Higher gonadotropins dose of 300 international unit is probably not recommended over the confidential doses of 150 international units for the predicted low responder, and this is the conditions. However, don't increase more than 300 international units. Adding columine citrate or adding aromatase inhibitors, there is no are equally recommended. If you have a columine citrate cycle in combination with the gonadotropins or using gonadotropins alone are equally recommended. Also, are adding aromatase inhibitors probably not recommended for the predicted low responder. So there is no difference to add or not. Some tips in the doses. Systematic reviews and the meta-analysis found no significant improvement in adding recombinant LH. Some clinicians adding recombinant LH in their cycles, there is no significant improvement. However, adding recombinant LH to the stimulation protocol could be beneficial between the 36 and 39 years old, and it's not also having a strong significance or strong recommendation. Recombinant FSH may be suggested in Poseidon group 1 and 2. As we mentioned, in the group 1 and 2, there is a hypothesis that there is low response for the gonadotropin. So adding recombinant FSH maybe have effect in Poseidon 1 or 2. What about egg collection? A low response to controlled ovarian stimulation alone is not a reason to cancel a cycle. Yeah, if you have a protocol, putting a protocol and giving the proper dose, and you find that there is only one oocyte or two oocytes, is not a reason to cancel or shift for IUI or for normal fertility. However, the recommendation takes these oocytes because there is no chances to increase the oocytes, and don't predict that if you cancel this cycle and doing another cycle with higher doses, you will not get more than these two oocytes. So low response is not a reason to cancel a cycle as long as you are choosing the right protocol and the proper doses. What about dual stimulation or double stimulation? Here, ICSI recommendations was clear. It's for research only. Double stimulation in low responders should only use in the context of clinical research. What about dual stimulation? It's a matter of getting the normal cycle for antagonist protocol, and you are triggering by the GnRH trigger, and make the ovum pickup, and then stop for 4 days. And after you stopping the 4 days, we start another doses of induction for in the luteal phase and making another trigger. This is for research only. There is no clear recommendations if it will affect the success rate and the pregnancy rate or not. What about the adjuvant therapy? As a surprise, there is no evidence for any adjuvant therapy increasing or improving the advanced maternal age. What we are using in our clinics about the testosterone, about the growth hormones, about the vitamin D, every vitamins, there is no adjuvant therapy. And this is from the review presented by Cochrane. It was made in 2010, it clearly states that there is no specific therapeutic agent that offered an outright benefit in the management of poor ovarian responders. However, in the adjuvant therapy field, ICSI, aspirin and sildenafil is not recommended, and is a very strong recommendation. However, in a condition, some papers talking about growth hormone and Bardo probably not recommended with the testosterone and DACA. This is the adjuvant therapies that we are using in our clinics. It will not improve the evidence and the statistics and the Cochrane studies. Endometacine, there is no controlled studies about adding endometacine, and the addition of estradiol, also some clinicians using estradiol in the luteal phase, decrease the risk of cycle cancellation only, but not increase the chance of clinical pregnancy. There are some tips for the advanced maternal age. Maternal age are likely to have a pre-existing comorbidity. It's a very important issue to have a proper assessment for these patients. Proper assessment if she is diabetic, anemic, hypertensive, should receive a pre-IVF assessment preparation zone before you are going to do ICSI for these patients. If you have a patient 39, 38, 41, she must have a pre-existing comorbidities. Don't start ICSI before controlling this comorbidity condition. During some tips also, ovum pickup, follicular flushing has been proposed to increase the number of retrieved oocytes. However, studies on the flushing fail to show any benefits. We are having one oocyte, two oocytes, some clinicians being flushing for 2, 3, 4, 5 times. It's not failed to show any benefits to increase the pregnancy rate or oocyte retrieved. So, and this is recommendations from the good practice in ultrasound 2019, recommendation from the ICSI, there is no benefits from the flushing. And the freeze-all strategy compared with the fresh has no impact on IVF outcome among poor responder. So this is some tips: control the comorbidities, flushing the hypothesis that it increases the number of retrieved oocytes, it's not affecting the pregnancy rate or oocyte retrieve, and try to make a freeze-all strategy or fresh strategy, there is no impact on the outcome. There is a good evidence that assisted hatching slightly improves the clinical pregnancy rate, but not the live birth rate. How to enhance the embryo selection? We are know the BGD and BGS, pre-genetic implantation screening, to avoid the transfer of the aneuploidies. As I mentioned, why 35 considered advanced maternal age? Because of the chromosomal anomalies. So if you did BGD or BGS, we may have a chance to avoid the transfer of the aneuploidy, which it had its impact to increase the pregnancy rate per transfer, not the accumulative birth rate. What we are using is the now comprehensive chromosomal study. We are choosing the chromosomal study, and this is the most efficient workflow. And we are using now the next generation sequencing field comprehensive chromosomal study. This is what we are requesting from our lab to do to choose the good embryo and the aneuploidy to avoid to transfer aneuploidy embryo. But it must be cleared. It must be clear that increase the live birth rate per set, per the transfer, but not increasing the cumulative live birth rate. Yani, for example, if the patient have 4 embryos and I will make مثلا 2 cycles to transfer 2 and another 2, if I get this 4 embryos and make the BGD for it for comprehensive chromosomal study, I will choose only 1 embryo. So I will make 1 transfer. So the live birth rate per set increased. However, the cumulative birth rate, it will not increase because there is 1 embryo best I transfer, and the first condition, if I don't make BGD, I will make 2 transfer, and at the end she will get pregnant in 1 only. So is a BGD and BGS is a diagnostic tool, not a therapeutic tool. What are about the future for the advanced maternal age? We are talking about the minimal and non-invasive embryo selection through making the cumulus cells to see the genetics and the follicular fluid from the egg retrieved. All these are the future of the studies, and the blastocyst fluid in the inner cavity of the embryo after the formation of the blastocyst to see if there is any genetics abnormalities. This is very non-invasive because we will not take sample from the embryo. Also, germline engineering for replacement of the dysfunctional mitochondria, and they are working it from about 5 years or 6 years, or the transfer of unhealthy additional mitochondria to the unhealthy egg. Also, chromosomal study to correct meiotic aneuploidies in the oocyte after fertilization. What are home messages? What we are using now, what I want to transfer for you, use antagonist or short agonist protocol. Both have no significant difference, not more than 300 international unit. Egg collection dual stimulation to be further investigated. Adjuvant therapy is not evident. However, growth hormone may have a role. Consider BGD and chromosomal comprehensive study with new next generation sequencing for better live birth rate per set, not the cumulative birth rate. Also, no benefit from the follicular flushing, and counsel for cryopreservation for age less than 35 as a prophylactic from the advanced maternal age. Thank you, and these are references about the advanced maternal age. So it's very nice to say this presentation in front of you in this IVF hub for our professor, Dr. Yasser Abu Talib, under his supervision, and to see you in the next lectures, inshallah.
Okay, أنا خليك. Okay. So it's wonderful, Mahmoud. Okay, so thank you very much, Mahmoud. Okay, I'm impressed with your presentation. It's very nice. However, I'm going to kill you sooner or later. Do you know why? Because you burned most of the things that I'm going to say in my presentation, me and Abu Bakr Nashar. But anyway, don't be worried, because we are going to collect all the or together all the information and the recommendation afterwards. and we are going to present it lastly at the end of this day. Last two lectures would be one for Professor Abu Bakr Nashar. He's going to address us regarding to the most recent recommendation for the ISHRI, and me as well. I'm going to address you as regard to the evidence-based. So it means that we are going to, how can we use the different medication and which type of medication that we are going to use and effective as well. It's evidence-based. Thank you very much for your nice presentation. And Dr. Abdul Gabbar.
Yeah, I think the subject is very interesting and it's very important and it's very challenging. And this is why everybody wants to talk about it. We want to have a good outcome out of this meeting about this, an important subject for IVF patients, and for IVF doctor, practicing physician.
Despite all of that, Dr. Abdul Gabbar, I'm going to kill him anyway.
The next speaker is going to talk about something very interesting and very interesting for us as a gynecologist as well, sexual dysfunction and with male infertility. Professor Hassan Shakir is going to give us an update about sexual dysfunction and male infertility. Please, Professor Hassan.
By the way, Professor Hassan is a friend of mine, and he's the head of urology department. He's a urologist, but he's a specialist in erectile dysfunction. That's why I asked him if it's possible to have this presentation. I think it's very important because we used to forget the male factor in relation with sexuality. This is a very big issue. Okay, let's start.
I think he's ready, yeah.
Good afternoon, ladies and gentlemen. Today we'll be discussing erectile dysfunction. My name is Hassan Shakir. I'm professor of urology in Ain Shams University. Erectile dysfunction is really a devastating disease. It doesn't cause direct impact on infertility or infertility, but it can make it harder for couples to conceive. That's because it can cause stress between the couples and can, of course, cause low body image, leading to men refraining from sexual intercourse. And of course, this can cause some sort of relationship problems and indirectly can affect fertility. As you can see, it's very prevalent, more than you think. Even in younger individuals, younger than 40 years of age, you have an prevalence of 10%, and this increases with age to reach a frightening level of almost 100% in men over the age of 70. So that's why I'm saying that this is a very prevalent disease that needs our attention. And the other thing, that it affects the whole family, not just the man. It affects the both couples. That's why you gynecologists have a big share in dealing with this problem. There are many major risk factors that increases with increasing age. For example, diabetes, hypertension, cardiovascular disease, hyperlipidemia, BPH, obesity, decreased physical activity, and cigarette smoking. And of course, medications that are used very frequently as antihypertensives and antidepressants are actually the most important risk factors. We will be saying a lot about reversible cause of ED, and these are the most important two reversible causes. For example, if patient is taking antihypertensive that's affecting his erectile function, you can easily change that medication and the patient can gain again his erection. So for that reason, we have to inquire very carefully about the medication that the patients are on. The physiology and the pathophysiology at the same time for erectile dysfunction is a very complex thing. But as you can see, you're actually the source of the stimulus for erection is either adrenergic, cholinergic, or non-adrenergic, non-cholinergic, or maybe not neural at all, that the stimulus can come from endothelial cells. But most of the times, these players, they all interact to increase the cyclic AMP and guanylyl cyclase, and the end product here is actually decreased calcium level inside the cavernosal muscle cells, and then this causes smooth muscle relaxation, and of course smooth muscle relaxation here causes erection. As you can see, it is a very complex procedure, complex physiology, and any interruption in any of these pathways can cause erectile dysfunction. For that reason, the etiological classification or the functional classification of the erectile dysfunction is very actually multifactorial. Could be psychogenic, systemic disease are very important, like renal dysfunction, liver dysfunction, drugs as we discussed before, and of course, arterial, cavernosal, neurologic, and hormonal causes can all interact to cause erectile dysfunction. All patients with erectile dysfunction, to be managed correctly, have to go through the same pathway. Of course, we start first by medical and psychosexual history. There are many validated instruments that we can use. They are present, and actually they are translated into Arabic because these are self-administered and the patients have to do it themselves. So this quantify how big the problem is for the couple. And after doing that, we have to identify four things. We have to identify the problems that the patient has other than ED. For example, if we can discover that this ED patient has renal failure or liver cell failure, this is a major deal, a big deal actually, because this is a much more important thing to deal with compared to ED. And of course, we have to look for common causes of ED. Of course, as we said, there are reversible risk factors like antihypertensives, like antidepressants. Patients with hyperthyroidism can get ED. Correcting hyperthyroidism can reverse this ED. So we have to be looking for this reversible risk, and we don't jump right away to treatment of ED. And of course, we have to assess the psychosocial status of the patient. There's a word of warning here. Whenever you find patients with questionable psychosocial status, I personally would send him to a psychiatric colleague, because dealing with these patients can be very tricky. We have to have a physical examination, a focused physical examination. We look for penile deformities because this can affect erectile function deeply and significantly. Prostatic disease, very highly associated with ED. And of course, signs of hypogonadism, because we cannot treat erectile dysfunction without treating secondary hypogonadism that is frequently present in elderly patients with ED. Of course, cardiovascular status has to be assessed, and this has special place, and we'll discuss this later. We then can go for laboratory tests, and laboratory tests are not only directed to ED, but we have to do liver functions, renal functions, blood picture, because these can all contribute in the erectile dysfunction. Glucose lipid profile is actually very important to be done. As I have shown you that hyperlipidemia and diabetes are major risk factors for ED. If they are not done in the last year, then they have to be done. Don't forget total testosterone or better free testosterone. As I said, we have to look for secondary hypogonadism, because treating patients with secondary hypogonadism without correcting the testosterone problem won't be successful. We have to assess the cardiac risk. And of course, we don't have time here to discuss how to assess the cardiac risk, but this will put the patient into one of three categories: either low risk category, intermediate risk category, or high risk category. So when we classify the patient into low, intermediate, and high risk, we can treat accordingly. Low risk, you don't need to refer the patient to a cardiologist, and you can initiate or resume sexual activity, and you can treat these patients safely. If the patient is intermediate risk, then or high risk, of course, I send them to a cardiologist. The intermediate risk patient will come back from cardiologist, and the cardiologist will say, okay, he's a low risk patient and you can resume sexual activity or treatment. Or high risk patient, and then forget about sex now. We have to treat the cardiological condition first, and any sexual activity should be deferred until stabilization of the condition. In all cases, we have not to forget about the cardiac problem, and has to be treated simultaneously. Of course, not all patients will get specific diagnostic tests. These are actually reserved for some patients, like young patients with history of pelvic or perineal trauma, because these patients can benefit from vascular surgery. Patients with pedal deformity, I'll discuss this in a few minutes, and patients with psychiatric or psychosexual disorders, and as I said, better refer this patient to a psychiatrist. Patients with complex endocrine disorders, these patients can very much benefit from correcting these disorders. For example, hypogonadism, treating hypogonadism can per se reverse the ED. Patients with hyperthyroidism can be treated by treating this hyperthyroidism. So, as I said, you need to choose these tests for each patient separately. You can't do them for all patients. They include nocturnal penile tumescence, vascular studies, neurological studies, endocrinal studies, and of course, psychodiagnostic evaluation. Now, that will bring us to treatment. As I said, most important thing, if we can identify a curable cause, then we treat this cause first before giving the patient any specific medications for ED. Because in many of these cases, the condition can be reversed and ED can be treated. Don't forget about lifestyle changes. As I said, obesity can cause ED. Hyperlipidemia can cause ED, so if the patient can lose weight, if he can increase exercise, then this can benefit very much. And of course, you have to provide education and counseling, not only for the patient, but for the partner as well. Now, we have many choices, either the marvelous PDE5 inhibitors, or other things like intracavernous injection, intraurethral alpostadil, which is prostaglandin E2, or vacuum devices. Actually, the apomorphine is not present anymore. Most of us would refrain from the intraurethral alpostadil, and the only three things that are present at this stage are either the medication, intracavernous injections, and vacuum device. Now, it's not your choice. You have to look for the medical background of the patient and discuss this with the patient and his partner, and it has to be a shared decision making. In most of the cases, PDE5 inhibitors are actually the first line of treatment here in these patients after correcting the curable causes or the reversible causes and lifestyle modification, of course. But some patients, PDE5 inhibitors are contraindicated, like patients on nitroglycerin. Beware that you can kill this patient by giving him a PDE5 inhibitor if it happens that he's taking them at the same time with the nitroglycerins. At that time, we can discuss intracaverous injections and vacuum devices, which are good actually choices. And then you send the patient home with his, and he will come back in 2 to 4 weeks' time. And then at that time, you assess therapeutic outcome in the form of erectile response, side effects, and satisfaction. These are the 3 things that we'll be looking in the follow-up. There are actually the main 3 PDE5 inhibitors or the oral medications for erectile dysfunction. Actually, the group of sildenafil, tadalafil, alverdanafil. There are now other lines coming or other medications or PDE5 inhibitors, and many researches in this area just to increase the specificity to PDE5 receptors. The main difference actually in the Tmax, which actually reflects when is this medication going to start. As you can see, the sildenafil group and the vardenafil group, they reach their Tmax within 1 hour, but the tadalafil takes a longer time, 2 hours. But again, this is compensated in the T-half, which tells you how long does this medication work, how long for does this medication work. And as you can see, the sildenafil half-life is around 2.5 to 3.5 hours. Vardenafil is less than 4 hours, so meaning that these medications will wear off within 6 hours. Tadalafil actually half-life is 17.5, which means that this medication can stay in the system for 36 hours, and some patients will tell you 2 to 3 days still very active. The difference as well is actually in the adverse side effects, and as you can see, they all share headache, flushing, dyspepsia, nasal congestion, and dyspnea with different percentage, but the 2 specific things are actually abnormal visions. Sildenafil and vardenafil shares in that side effect. Back pain and myalgia, this is very specific for the tadalafil and can be annoying for the patient. Now, you have to understand that actually there is now a new group of medication, or it's not a group actually, it's tadalafil low dose 5 milligram. And this is not taken per need, it's taken daily and has many advantages, meaning that the sexual function is available at any time. This is one thing. Another thing, it increases the vascularity in the erectile tissue, which is on long term can be beneficial. Now, if we assess the condition and the patient come back, say it's inadequate treatment for any reason, at that time we may consider penile prosthesis implantation. And actually, penile prosthesis implantation is although it's the last resort, but it is a very important step in treating these patients, as it can be life-saving for this patient. I'm not saying life-saving, but I say marriage-saving, and as well relationship-saving. We have 2 types of penile prosthesis, either the semi-rigid or the inflatable. The semi-rigid is actually, it's a rigid penile prosthesis that is inserted into the cavernous tissue, but can be bent, as you can see, but stays erected. In other words, if the patient needs his erection, he just straightens the penis manually. If not, then he just bends his penis between his legs, but stays erect. This is very effective. It is low-tech in the sense of it doesn't get malfunction. Of course, there are malfunctions, but not that common. But it can be annoying for some patients. The one that mimics very much normal erection is the inflatable one. And this inflatable one is nothing more than a balloon, of course, a very high-tech balloon. It's inserted inside the cavernous tissue and it's connected to a reservoir that is implanted inside the abdomen, either retropubic or, as in this picture, subfacial. And there is a bump here that is usually implanted beside the testis. So if the patient needs erection, he just has to bump the fluid inside the erectile balloon, and he gets a very rigid erection. If he doesn't need erection, he presses a button and the penis becomes flaccid. So this mimics very much the normal erection. The only problem with this is that actually it needs long experience from the surgeon. Otherwise, you may lose a very expensive device that's almost 100,000 Egyptian pound now. This is one thing. Another thing, of course, because it is a very sophisticated system, you have almost 10% failures over time, and you have to warn your patient about this. Most of the companies would give you a lifetime warranty. Now, I have discussed penile deformities, and penile deformities can really be very hindering for sexual function, and of course, indirectly can cause infertility. This is what's called Peyronie's disease, and the penis can be bent almost 90 degrees or even more. Of course, most of the case it won't be that severe, but I'm showing you a severe form. Peyronie's disease is nothing more than fibrosis or fibrosis in a certain area in the cavernous tissue. We don't know exactly what is the cause or the etiology or the pathophysiology, but there are many theories. The end result is the formation of fibrotic plaque that causes this bend. If it is less than 30 degrees bent and the patient can perform sexually, we just leave the patient alone. But if not, there is a complex pathway. But it is very easy to understand, actually. If the erection is, first thing we need to know whether the erection is adequate or not. If it is adequate, then we have to discuss with the patient whether he can accept the risk of length loss. Because we can plicate the penis like this picture with a procedure called Nisbet plication. If the patient accepts this, then we can do the plication procedure. If he doesn't accept the length procedure, then we can do plaque incision and grafting. Another thing that we have to discuss with patients, if he can accept risk of erectile dysfunction, because sometimes when we do plaque incision and grafting, you can get erectile dysfunction. That's why if he accepts the risk of erectile dysfunction, then at that time we can do plaque excision and grafting. If not, then we have to consider penile prosthesis. From another types of patients that are not getting enough or adequate erection and penetration from the very beginning, then we have to consider penile prosthesis. Of course, implantation of penile prosthesis here is not that straightforward. We have to deal with the plaque, we have to straighten the penis. We either do at the same time what's called manual modeling, or sometimes we graft, we remove the plaque and we graft this area with graft material. Then I understand very well, and most of you would understand, that sexual dysfunction is not a direct cause of infertility, but it can hinder the sexual function. It can hinder actually the intercourse that may indirectly cause fertility problems and even sometimes can break the marriage. Thank you very much for your attendance.
Thank you very much. Very interesting, very interesting. And I really think that all gynecologists should know about this. We shouldn't interfere with your management, but we should know exactly what's going to happen with the male. Prof. Yasser, you want to present the next speaker, please?
Okay, just before going through the next speaker, I think Professor Hassan Chakr is there with us. Hi, Hassan, how are you doing? Do you hear me? Okay.
Yes, I can hear you very well. First,
Okay.
I would like to thank you very much for inviting me to give this lecture. I'm honored to be here among you.
Thank you, Professor Hassan, very much. If you want, it's wonderful, actually, and the picture is crystal clear. And I discovered that one of the most important thing is not sildenafil, but it's another preparation. It's called tadalafil. I think it's better than sildenafil because it might extend up to 3 days. Am I right or wrong?
Yes, actually, tadalafil is becoming now a very important medication, especially that we have a low dose tadalafil of 5 milligram. That can be taken daily and not only per need. And that has actually 2 pillars. If you take it daily, the patient can be ready for sexual intercourse at any time. In addition to that, it improves the oxygenation of the cavernous tissue, which is very important in some diseases like diabetes mellitus that can cause cavernous tissue injury over time. So yes, now there is a tendency to give daily reduced dose of 5 milligram of tadalafil for these patients. Actually, you can combine that with another PDE5 inhibitors at the time of intercourse if the tadalafil 5 milligram is not enough.
So can you use it during if you have heart problem? So is it safe?
Not at all. This is very important question, Dr. Yasser. Nitroglycerin, all heart problems shouldn't be a problem as long as it's a low-risk patient. Low risk, I mean cardiologically. But if he's a high risk, then we have to get the permission of the cardiologist to perform sex from the beginning. I mean, sex by itself can be dangerous for a patient with high risk problems in his heart. Another important factor would be the simultaneous use of PDE5 inhibitors with nitroglycerins. This combination is fatal. And I have to say it again, it is fatal. If you combine nitroglycerin with PDE5 inhibitors, this can cause severe hypotension and cardiac arrest. So yes, you have to first to assess the cardiac condition of the patient. If it's mild, go ahead. And most important, the patient shouldn't be getting any nitroglycerin.
Thank you very much, Dr. Hassan, for wonderful information. I think it's very important because some people might say that we would prefer to use nitroglycerin to have some sort of dilatation of the coronaries. And as well, we can use during sex these preparations. So it's very important. It's very important to announce that nitroglycerin is contraindication with this. And is it available in Egypt?
You mean the all different types of PDE5 inhibitors are present? Tadalafil 5 milligram and yes. 20 milligrams are present. Yes. Tadalafil, actually, there are 3 preparations and they are all produced by Egyptian manufacturers, so they are readily available. So yes, they are present.
Thank you very much, Hassan. Thank you very much. It's a wonderful presentation, and it's my pleasure actually to join the urology team for infertility problems. Thank you very much, sir, and hope to hear from you again. So let's go through the next speaker. Okay, so next speaker will be one of the eminent consultants in the field of IVF and ICSI. It's Professor Dr. Khaldoun Sharif. I think everyone knows Khaldoun Sharif. He has lots of books for MRSOG and as well lots of books discussing the issue of infertility. He is the clinical director of Fertility and Genetic Center back in Jordan Hospital, in Amman, and he is the international renowned IVF expert in IVF and ICSI. So he's going to address us regarding to modern management of azoospermia. Let's go for the presentation.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for inviting me to participate in this seminar. And today I'm going to discuss the state-of-the-art management of azoospermia. Let's get the slide going. Now, only one sperm is required to fertilize an egg. And we know that in humans, there are millions of sperm in almost all men. Yet, the incidence of male factor infertility seems to be extremely high. This is data from the WHO back in 1987 that was done in many countries in the world involving more than 7,000 couples. And it shows that male factor is either responsible alone or in combination with female factor for about 50% of cases of infertility. And more recent data from the Cleveland Clinic shows that the picture has not changed. In almost all countries of the world, the contribution of male factor is about 50%, but particularly in the Middle East, it's 60 to 70%. And this is echoed by our own data from Jordan, looking at 11,000 patients who had seminal fluid analysis in our unit over the last 10 years. And it showed that almost 70% of them have abnormal seminal fluid analysis. But the most severe form of male factor infertility is azoospermia. That's total absence of the sperm in the ejaculate. And the books will tell you it's present in 2 to 5% of investigated couples, but in our own data, we have about 8% of couples who present with azoospermia and infertility. And not so long ago, in 1993, the WHO manual told us that the outcome for these couples was useless or hopeless. But in less than 10 years, we have reported in recent advances in obstetrics and gynecology that the ART success rate of most of these men is similar to men with normal sperm. So how did we get from zero to hero, so to speak? We need today to talk about the classification of azoospermia, its current management, and future directions in treatment. Now, just some basic physiology. The pituitary produces FSH and LH. It stimulates the testicular tissue to produce sperm and testosterone, and the sperm comes to the outside. And traditionally, azoospermia has been classified as non-obstructive and obstructive. And that seems to be logical, yet there are some illogical parts of it. For example, in the non-obstructive type, this will include both cases easy to treat, such as hypogonadotropic hypogonadism and testicular failure, which are very difficult to treat. Also, in the obstructive type, you have obstructions such as previous vasectomy, and you also have retrograde ejaculation when there is no actual obstruction whatsoever. And in 2000, we published an opinion paper in Human Reproduction suggesting the reclassification of azoospermia. And that was to be into a pretesticular, testicular, and post-testicular causes, which will take the next 10 minutes or so to discuss them. But first of all, let's look at the incidence of each of these types, because they differ dramatically between different parts of the world. When I was working in the UK, back in 2000, we published, me and my group from Birmingham University, a paper in Human Reproduction describing our experience with azoospermia. And the classification there, or the distribution, I should say, was 60% testicular, almost 40% post-testicular, mainly due to previous vasectomy, and only 1% pretesticular. Moving to the Middle East later on, the picture is different. Yes, the 1% pretesticular remains as it is, but the post-testicular is only 5%. That's because it's easier to shoot a man in the Middle East rather than to offer him a vasectomy. Men will not take a vasectomy, come what may. Therefore, the biggest cause of post-testicular azoospermia, which is vasectomy, is not existent in the Middle East. So you find almost 95% of your cases are testicular. Pretesticular azoospermia, as we said, is present in 1 to 2% of cases, and actually it's the rarity of this diagnosis that makes most clinicians ignore it and probably miss it. It's called hypogonadotrophic hypogonadism. The pituitary is not producing FSH or LH, so you find these two hormones low, the testosterone low, and small size testes. Like any pituitary issue, you need pituitary imaging, and this is a hormone deficiency status treated by hormone replacement therapy. If the man doesn't desire to have children, then we should offer him testosterone replacement. But if he desires to have children, we should offer him gonadotropins in the form of FSH and LH and some human chorionic gonadotropin. And in almost all cases, this will lead to the production of sperm and the achievement of spontaneous pregnancy at home, not in the hospital. But you have to remember that the mean response time is about 18 months. That's a year and a half from the start of the injection to the production of sperm. Therefore, you have to be aware of that, and you have to make your patient aware of that. So otherwise, they will, after 3 months, not get anywhere, throw your treatment and your business card in the bin and move on to a different doctor and start the whole cycle again. It's very important to be aware of that. And of course, it's to remember that pre-testicular azoospermia is not an indication for surgical sperm retrieval. Next, we have testicular azoospermia. This is the commonest type, whether in the Middle East or in the Western world, and it involves about 60 to 90% of cases. There is high or normal FSH. So remember, the only reason why we measure FSH is not to diagnose testicular azoospermia, but to diagnose or exclude pre-testicular azoospermia. The testes may be small or of normal size. And of course, about 10 to 15% of these cases are associated with either Y chromosome deletion or karyotypic abnormality such as Klinefelter syndrome. Therefore, genetic counseling and screening is necessary. And let me tell you outrightly that there is no medical treatment for testicular azoospermia. Gonadotropins, antioxidants, carnitine, all this stuff is totally useless and will just waste the man's time and money. And at the same time, the wife will get older, and when she gets to the right treatment, her chance of pregnancy will be less. So please don't prescribe any medication for men with testicular azoospermia because nothing is proven to work. And the treatment here is surgical sperm retrieval, followed by intracytoplasmic sperm injection, and we find sperm in about 40 to 60% of sperm retrieval cases. And that's, by the way, is irrespective of FSH, testicular size, previous histology, or anything like that. So there is no way pre-operatively to predict who will and who will not have sperm in the testes. And just briefly, because surgical techniques should be seen and taught in theater rather than lectures, but we'll speak about the 3 ways of getting sperm from the testes, either by fine needle aspiration, TESA, by testicular sperm extraction, open biopsy, or by microtesy with the use of surgical microscope. This is TESA, this is the open biopsy, and these are the surgical microscopes that are usually present in every hospital because the neurosurgeons and the ENT surgeons and the ophthalmologists will be using them. And what you're trying to look for is not the sperm, but you look at the seminiferous tubule. This is one of my cases where you can see in this panel that the seminiferous tubule are engorged and distended, while in this side they are fine like hairs. So we are more likely to find sperm in the upper panel rather than the lower panel, and that's indeed what happened. And Bernie and colleagues looked at the chances of finding sperm using either of these techniques, and generally speaking, you have 20% chance in TESA, 40% in TESI, and 60% in microtesy. Moving on to the post-testicular azoospermia, this is present in about 5 to 40% of cases, depending, as we said, on the prevalence of vasectomy in the community. The FSH and the testicular size will be normal. And if you can do surgical correction, like with previous vasectomy, then that's fine. But if there's infection, or there are multiple sites of obstruction, or if it's congenital bilateral absence of the vase, where the absent part of the vase is too long to bridge, then you need to do surgical sperm retrieval. In cases of retrograde ejaculation, and you usually recognize them by the presence of azoospermia in addition to low volume ejaculate, defined as less than 1 milliliter. then that is retrograde ejaculation, and you suspect it that way. You diagnose it by asking during the next test for a post-ejaculatory urine specimen, and if you find sperm in the urine, then bingo, you've got the diagnosis. You get them from the bladder and use them. And the treatment, as we said, is surgical sperm retrieval and intracytoplasmic sperm injection. Now, a particular case is in congenital bilateral absence of the valves. All these men have cystic fibrosis, and that is the presentation of cystic fibrosis in their body, the congenital bilateral absence of the valves. They don't have any other manifestation of cystic fibrosis. Therefore, their genes are cystic fibrosis, and you need to screen the wife to make sure that if she is a carrier of cystic fibrosis, then before you do ICSI, or I mean in addition to ICSI, you need to do pre-implantation genetic testing for that. And of course, this is obstruction. You bypass it, you find sperm in almost 100% of the cases. This is the distended epididymis in obstructive cases. And the procedure we do to collect sperm is called PISA, percutaneous epididymal sperm aspiration. In some obstructive cases, the obstruction is pre-epididymal, and we need to go for a proper testicular biopsy, but with the needle, the TESA, we can do that. Ladies and gentlemen, only one sperm is required to fertilize the egg, as we know, but sometimes that sperm is hard to find. The developments in andrology and in urological surgery and in assisted conception has led to the majority of azoospermic men being able to have their own genetic children using these techniques that we described today. But still, there are a number of them that we cannot help, and we have to work hard with our research and development. We have to look at how can we predict who will and who will not be able to have a successful surgical sperm retrieval. Spermatid injection is an area that's emerging with very mixed results, and spermatogonial stem cell research is still in its infancy. But yet we have to do our best to help our patients. Thank you very much for your attention.
Okay, it's wonderful to have Khaldoon with us. Thank you very much for this nice presentation addressing the modern management of azoospermia. So we discussed two issues in male factor of infertility or subfertility, sexual or erectile dysfunction, and as well modern management of azoospermia. Let's have some sort of refreshment, because we give you all lots of information, and I think you are need to have a sort of relaxation now. So may I leave the screen for my colleague Mahmoud just to answer some of your questions, just to give you information which are I'm considering it as basic management of problem. It's problem solving management of cases that we have received questions regarding to yet. And we will have more discussion afterwards, and we will have more answering the question afterwards. So Mahmoud, hi, how are you?
How are you?
Okay, I promised all of you that I am going to kill Mahmoud because he burned my lecture, but so I forgive him anyway, because because he's my brother. Yeah. So he's still there, and I'm going to leave the place for him. He's going to answer questions for you.
Okay. Good evening once again. Good evening once again, dear colleagues, and thanks Dr. Yasser again for his nice introduction to kill me. And still alive. Alhamdulillah. There's a lot of questions come to here, and I can select some of them to answer it. What is the ideal time for insemination? There is no ideal time, because we are not waiting for the ovulation. What's meant by that? In making IVF or induction, we are in ICSI cycle. We want to make the oocyte treat before ovulation happens. So we are making the retrieval or pickup within 34 up to 36 hours after after triggering. However, in insemination, we are not indeed to wait the 36. We can do it after 40 hours, and this is the ideal time that I am doing it in practice, because I'm not waiting for oocyte to be inside its follicle. Maybe it release, it will live for 12 hours. So the best time for me, in my practice and my experience, is after 40 hours of the triggering, to be sure that the oocyte is getting out from its follicle. So this is Dr. Yasser is doing the same, I think.
That's wonderful. No one know that, by the way. It's wonderful. It's great, and it's right practice.
It's the right practice because we are not waiting the oocyte. We want the oocyte to release out. And I instruct the patient to make a relation, by the way, after 24 hours again, because the ideal to do IUI after 24 hours and after 48 hours. But for the cost benefit and not to decrease the cost on the patient, we are doing it in the 40 hours, and we can instruct the patient to have a relation after. It's very important question. Does BGT harm the embryo? I have some issues with the BGT and BGS in general, because BGT is not harming the embryo, but it's not a therapeutic procedure. All the patients, because of the doctors talks about BGT, think about it's a therapeutic. No, it's not a therapeutic. It's a diagnostic. It's a diagnostic to diagnose the good embryo and the bad embryo. But if you diagnose, we cannot treat. That's why it costs the patient a lot of money, and we cannot treat this condition. So in my opinion, BGD is for selected cases doctored by the routine practice, and it's not harming the embryo because there is something called mosaicism. What's meant by mosaicism? If you make a cell analysis, it's a day 3 of fertilization. When the embryo become 8 cells, 10 cells, we can take a cell and make investigation like chromosomal comprehensive study, but there is a mosaicism. What is by mosaicism? There is a difference between cells and each other. So we can diagnose it's a good cell, and there's a different cells in this embryo have a bad issue. Plus, the best to do it in day 4. Day 4, they are decreasing the mosaicism of this diagnostic tool. So it's not harming the embryo. However, it may be making triggering to this embryo to be a twin. By the way, it will make triggering it, and maybe diagnose the baby is good or the embryo is good, and you transfer a bad embryo because of the mosaicism. So the best time to do BGD in the day 4, and you have a rapid genetic lab to give you the answer before day 5 to transfer on day 5. Does COVID-19 infection or vaccinations affects women's infertility? There is no evidence. I am a professor in the university, and I believe in evidence-based. So there is no evidence, because we need years of studies to make sure that COVID infection and vaccinations affecting infertility. However, in the last 2 years, we observed that there is a decrease in semen analysis in some patients, maybe related to this infection or vaccinations in the semen parameters concerning count, motility, or abnormalities in morphology. For female, I don't recognize any changes, but we need a sample size, a good sample size, to make statistics clear and investigations clear, so there is no evidence. So when the patient comes to your clinic and ask about that, I am answering there is no evidence is it affected infertility or not. However, I do recommend to take vaccination. I do recommend to make a treatment. I do recommend to proceed, because to know the effect of these vaccines and infection of COVID-19, we need ages to make a clear study to have a good answer for this issue. Another one asked about what is the preferred method for the pregnancy when there is a fallopian tube obstruction? Actually, the preferred method for pregnancy is IVF, ICSI procedures. My professors, old professors in the old school, was using laparoscope for salvagostomy and making a visualizes for the fallopian and trying to inflate it. And the best ever in the new modern practice is IVF and ICSI. This is the best choice for the patient. Don't waste time, don't waste money for the patient to make a laparoscope, try to make a good fallopian tube. Maybe the ages ago, there is no option for the IVF egg cycles, but nowadays IVF egg cycle is the best method.
If we have both tubes, but if we have just one tube, you might
have, if you have one tube. But he told me about there is a fallopian tube obstruction.
Yes.
I not mentioned a post tube. If you have one tube, no. I want to clear something. If the patient is ectopic pregnancy, for example, and you remove an fallopian tube, this patient decreased its fertility power by 50%? No. It's not decreasing its fertility power by 50% because it's a bad opinion in some clinicians, by the way, and telling this for their patients that your 50% fertility power is decreased. No, it's not 50% as long as you have the two ovaries. Okay, one fallopian tube can compensate for another removed fallopian tube. It's decreasing 5 to 10% maximum, because we have two ovaries, so it's not decreasing by 50%. A lot of patients, I make it mindset for ectopic pregnancy and for laparoscopic and removing for one tube, and she get pregnant easily from the other tube. A lot of patients. So removing one fallopian tube, she can get pregnant from the other fallopian tube, and you cannot, and we can postpone the IVF decision for 1 year, 2 years, according to the parameters the patient has. However, if she failed to get pregnant after this period, we can offer her for IVF egg cycle. But if we remove one fallopian tube, gives the patient chance for normal pregnancy procedure, but don't rush for IVF. But if she doesn't have the both tube, she must have an IVF egg cycle. Dr. Yasser told me about the tubal disconnection. طبعا hydrosalpinx is the last school, old school, trying to make this what we call salpingostomy. What's meant by salpingostomy is that we are making an opening in the tube to remove this hydrosalpinx or whatever. So the function of the cilia inside the fallopian tube is distracted by this infection. So even in salpingostomy, it will not work. So far, tubal disconnection is the best choice before doing IVF. There are some studies, a debate about doing salpingectomy or just a disconnection. I prefer salpingectomy, by the way, because it's a septic focus and it's accessible to salpingectomy. If you cannot, make a tubal disconnection. However, you can do tubal disconnection either through laparoscope or hysteroscope by cautery the tubal orifices. However, cautery the tubal orifices may be reopened after 6 months or 9 months for maximum. However, don't try to get this patient to get pregnant through this hydrosalpinx, and don't make IVF cycle or egg cycle without this connection, either by clipping the both tubes or by removing, and this is a school what I follow. Maybe have some best investigations for check ovarian reserve. I think I mentioned in my lecture. The best ever by ESHRE recommendation 2019 in the booklet of this reserve is anterior follicle count and antimolar hormone is the best ever. And if you have a low antimolar or low AFC, we have a second step for FSH. Because FSH is high, you have no chance to get induction. And if the FSH is low, you may have some sort of infection. Like the best ever ovarian reserve routine in your clinic, which is transvaginal ultrasound in first week of the period to assess the anterior follicle count on each ovary and request anti-malarial hormone. What are the modern management of unexplained infertility? Unexplained infertility is a wide and broad topic. However, if you make the workup, the routine workup for the patient couples, and you are waiting for spontaneous pregnancy by induction, even protocol, or by follow-up for reclaimatory and make a timed intercourse, and there is no pregnancy, you must offer the patient for the IVF egg cycle, but according to the age of the mother and the age and the laboratory investigations for these couples, and the modern management not to wait more than 3 years if she is unexplained.
You have to start with IUI first to see if she can pregnant or not, and if it's not.
But IUI, I doing it once, but
except after 5 years.
After 5 years,
if you have infertility for 5 years, you might go
must work IVF.
But if it's less than that, you go to her, because if you have a sort of unexplained infertility, it's explained because you are checking by the investigation 3 things: ovulation, semen, and tubes pathway. If all of them are normal, so 2 factors are there. Either the cervix cannot allow the sperms to go through it, so IUI will be the answer. And if you do IUI and you are sure that sperms go through the pathway to the ovum and no pregnancy, so the only cause is the inability of the sperm to penetrate the ovum. So it's agree?
Yeah, I agree, but
agree.
I agree for IUI. I'm doing IUI once, okay? But the recommendation is to do IUI 3 times, okay? But for the cost, yeah, the coming pregnancy. I'm thinking about the cost. Always, I'm thinking about the cost with the patients. So I'm telling to wait. I'm just trying IUI for once. I don't know if you are trying more than once.
Yes, maybe, but this is according to the request of the patient.
The request of the patient.
But you have to try.
You must have a
once, twice, thrice.
As a patient, yeah. Okay. So the modern management of unexplained fertility, don't wait for ages. That's this is what must, yeah, to point in mind. She didn't have a clear cause for the infertility. However, there's hidden causes maybe appeared on the IVF cycle, like sick zona, like the ability of the head to penetrate the oocyte. Maybe you bypass it by IVF. So my recommendation, and Dr. Yasser, I think recommendation, don't wait more than 5 years, okay, for infertility. However, maybe 3 years if the patient have an old age because of the late age of marriage. Maybe if you have a lectures, or can I take another question? Okay. I need to know about the protocols for induction and how to avoid its risk. So the protocol of induction, it's clearly it's agonist or antagonist, okay? And there is a recent protocol which is progesterone prime protocol. The protocols of induction, the safest is the progesterone prime and antagonist protocol, because we have the option of if the patient enter with you some sort of ovarian hyperstimulation, you can trigger by agonist injection, which is like ticagrelor, diptofem, which is GnRH agonist. So we have the LH surge spontaneous from the pituitary. So antagonist and progesterone primed for the newly practiced doctors for IVF is the safest for them. And to avoid its risk, even if you enter in ovarian hyperstimulation and you don't choose the proper doses for this patient and enter ovarian hyperstimulation, you have the facility to trigger by agonist protocol, by agonist injection like GnRH agonist, and it almost not making ovarian hyperstimulation. It's a moderate or severe form, maybe have a mild form. In my practice, more than 10 years for antagonist protocol user, I think I don't have a severe or moderate ovarian hyperstimulation, even in the patient with PCOS. In literature, they are telling that antagonist is only for PCOS and poor responders, and long protocol for the confidential or traditional protocol. Long protocol is much more better than the short protocol. I don't like short protocol because the asynchronization between the oocytes and the quality of oocytes even affected by the short protocol. So the choices will be between 3 protocols, long or antagonist or progesterone prime. How to avoid this risk? To choose the proper dose. How to choose the proper dose? Just take a weight for the patient, the age of the patient, consider the weight, BMI, and the age, and consider the previous trials that you have to monitor the doses, under the umbrella of the antifertile count and the anti-malaria hormones, and give the maximum dose. And give the maximum dose, even the antagonist and progesterone. I don't care if the patient entering in a lot of retrieve, because I can have the maximum dose is. Maximum dose is 300 international unit. Not the recommendation. Not 450. Okay. There's no more recommendation.
Not thousands.
Not thousands. I found a patient that Dr. Yasser about 600 international units, and I'm surprised from these doses. You cost the patient a lot of money. The recommendation is clear. 300 international unit is the maximum dose to be used for any patient, even if you have a poor response. Don't use more than 300. It will not make any difference from oocyte retrieval or pregnancy rate. According to not studies, randomized control studies, it's according to the meta-analysis and according to Cochrane studies, happened in a lot of randomized control studies.
And if no response, you might repeat the cycle again with no more than 300, because the selection area is different between a month and a month. So you might have a selection area with poor ova. Maybe the coming months, the selection area in the ovary might have 3 or 4 follicles. It will be the same. So if you have no response with 300, it doesn't mean that if you raise Those
Do you
next
have
cycle.
another? It's very good point from Dr.
Yes.
Yasser, because every month we have another, like a mapping for the
Yes.
ovary. We are taking a part from this map to be stimulated, and you can find it in your patients in the clinic. You can give induction for a patient for just a soft induction for normal pregnancy, and you cannot find it pregnant in this month. However, in another month she can be pregnant spontaneous, and we can see it's a mapping of the outside. So far, thanks for this nice meeting, Dr. Yasser. You are handling in a very professional and very light way.
It's wonderful information.
Yeah, thank you.
Okay, thank you very much, Professor Mahmoud. So it was a very, very good decision not to kill you. So I decided from now and then just to keep you alive all the time and to ask you questions with difficult answers, actually, because it's, to be honest, wonderful information, crystal clear and direct to the point. We will have more and more area of discussions afterwards. From time to time, we are going to go through our presentation, and every 2 or 3 presentation, we will have a lobby of discussion regarding to your questions. If you have if you want any more questions, just put it on the break. May I introduce my colleague, Professor Dr. Abdelmajid Sarhan. Professor Dr. Abdelmajid Sarhan, he is the former head of Obstetrics and Gynecology Department, Faculty of Medicine, Zagazig University, and as well, it's given me the honor that just to announce that Dr. Abdelmajid was chosen as RCOG examiner, and he's going to participate in the first exam of the Royal College of Obstetrics and Gynecology, will be held next November in Egypt. So to be here, Dr. Abdelmajid. Dr. Abdelmajid is going to address us regarding to the premature ovarian insufficiency. Okay, let's go for the presentation. Dr. Abdelmajid. Dr. Abdelmajid. Alaykum assalam wa rahmatullahi wa barakatuh. Hi.
Thank you, Professor Yasser, for this nice presentation, and I would like to thank the American Association for allowing me to share this very big scientific meeting, actually, and very useful one, as I see till now. My talk today will be on premature ovarian insufficiency. What is premature ovarian insufficiency? Actually, many names have been given to the same condition, including premature ovarian failure, premature ovarian insufficiency, hypergonadotrophic hypogonadism, premature menopause, and early menopause. But the term premature ovarian insufficiency is the most commonly used one, and the one recommended to be used by scientific societies. And other names like premature ovarian failure may be used still, hypergonadotrophic hypergonadism also may be used still, but the term premature menopause and the early menopause are out of use nowadays. The problem of premature ovarian insufficiency is a big one, and this is why scientific societies, including ICSI, had produced very good guidelines dealing with the condition, how to diagnose and how to manage. And in this literature, I will try to stick to the solid points given by the ICSI in these guidelines. And when there is some area of controversy, I will stick to the management as advised by the ICSI. What's premature ovarian insufficiency? Is the decline in normal functioning of the ovaries in a woman younger than the age of 40. The premature ovarian insufficiency is characterized by 2 things. The first is menstrual disturbances in the form of amenorrhea or oligomenorrhea, and the second is the raised gonadotrophin and low estradiol. So one clinical item is the menstrual disturbance, is usually in the form of oligomenorrhea or amenorrhea, and the second is the chemical elevation of FSH.
Dr. Abmegid?
Yes.
Dr. Abmegid, excuse me.
Yes.
So actually, we cannot see your presentation. So would you mind to share the slide?
Okay. Hold on.
With us, please, because your presentation is not on the screen. Yes, please. Thank you very much.
I did screen sharing. Okay. I need you to allow me to screen share. Is my screen shown now? On,
Not yet. So I will ask Shahir just to support you. Yes.
Is it shown now?
Yes, it's just shown. Thank you very much. Thank you. It's clear now. Okay, you can start by clicking. Yes, it's clear now.
Okay. I'm just trying to review the
No problem at all. No problem at all.
So the topic is premature ovarian insufficiency, and the definitions given or the terms given are different, including premature ovarian failure, premature ovarian insufficiency, hypertrophic hypogonadism. These are the three names used currently. The most commonly used and the most recommended to be used is premature ovarian insufficiency. Other names like premature menopause or early menopause should not be used anymore. The problem is so big that the ICSI and other scientific societies had produced guidelines to deal with the lines of diagnosis and lines of management, and this literature actually will stick as much as I can to the points given by the ICSI. The definition is the decline in the normal function of the ovaries in a woman younger than the age of 40, and it's characterized by two items, one clinical in the form of menstrual disturbance, usually in the form of amenorrhea or oligomenorrhea more than 4 months, and chemical in the form of raised gonadotropin levels and low estradiol levels. The incidence about 1 in 100 above the age of 40, sticking to the definition, and below the age of 35, it has a prevalence of 1 in 250 women. So by a simple calculation, we can conclude that more than 60 of patients of who will develop premature ovarian insufficiency will develop so at the time gap between 35 and 40. There is no evidence that it's becoming more common nowadays, and certainly it's becoming more important due to tendency to delay first child. The age of menopause is around the age of 51, 52, and it's stable since very old ages, and no change had been produced in the age of menopause, either increase or decrease. The mechanism of this problem will arise from two aspects. The first is total follicle depletion, so that no follicles left in the ovary and no ability to produce more. The second mechanism is the follicle dysfunction. Some residual follicles are still there in the ovary, but they are not working properly. The first mechanism is responsible for the majority of cases, and the second one is rarely mentioned. As you all know, that the female is born having like 2 million primordial follicles, and at the age of puberty, this number will be around 300,000 to 500,000, and this number of follicles will undergo atresia or ovulation throughout the reproductive age till when menopause occurs. The follicles should be completely depleted from the ovaries. The total follicle depletion may occur because of there is originally low initial follicle number, like in case of pure gonadal genesis, thymic aplasia, or idiopathic, or there is an accelerated state of follicular atresia, like in X chromosome related, like Turner syndrome, or X chromosome deletions, or translocations, or galactosemia, fragile mental retardation, viral or arthritis, autoimmunity, environmental toxins, iatrogenic, or idiopathic. While the follicular dysfunction may occur due to different enzymatic defects or autoimmunity or specific genetic defects, or even also idiopathic. Regarding the etiology, among the different causes of etiology, the idiopathic or the unknown cause will sound for the majority of cases, followed by the environmental factors, including exposure to chemotherapy, radiation, surgery, and one important and famous surgery is the one we do ourselves, like for the treatment of endometriosis or for the treatment of PCO. Other factors may be autoimmune, and this will be associated with other autoimmune conditions in the body, like thyroid antibodies, diabetes, or cortical antibodies. Also, smoking, chemicals, and pesticides may contribute to the etiology of premature ovarian insufficiency. But again, the majority of cases will be having unknown etiology or idiopathic, and the most common are environmental toxins in the form of chemotherapy, radiation, and surgery. Very important questions that we need to ask is that, is induction of ovulation a cause of premature ovarian insufficiency? And the answer is a big no. Induction of ovulation does not affect the ovarian reserve or causes premature ovarian insufficiency. Whatever the amount of medication the patient receives, it will not affect the store of primordial ovarian follicles, because ovarian stimulation actually acts on the follicles that undergone the process of recruitment. What are the symptoms of premature ovarian insufficiency? The most common first symptoms are irregular periods and infertility. All again similar symptoms similar to menopause, in the form of hot flushes, night sweats, irritability, poor concentration, decreased libido, vaginal dryness, etc. So when we have a patient having estrogen deficiency symptoms, we need to ask about regularity of the cycle. And on the other hand, when the patient comes to us complaining of a irregular cycle, especially in the form of oligoamenorrhea or amenorrhea, we have to inquire about estrogen deficiency symptoms. So the signs also will be signs of hypoestrogenism. The ovaries usually small in size, difficult to be felt, difficult to be seen on the ultrasound, or in some cases we might have an ovarian cyst with premature ovarian insufficiency. Physical stigmata of Turner syndrome or other genetic syndrome should be looked at, like short stature, webbed neck, low position of the ears, low position hairline, cubitus valgus, shield chest, etc. And also signs of autoimmune diseases like Addison disease or hypothyroidism. What are the tests that we have to perform to deal with premature ovarian insufficiency? Actually, there are 4 groups of tests. The first is the test used to establish the diagnosis of premature ovarian insufficiency. Second, tests used to help clarifying the etiology. Third, screening tests for other diseases commonly in association with premature ovarian insufficiency. And lastly, tests to establish the effect of premature ovarian insufficiency on other systems of the body. What we need to diagnose premature ovarian insufficiency? Actually, many hormones had been used to diagnose premature ovarian insufficiency, included elevated FSH, low estradiol, elevated LH, decreased AMH, and of course, we should not forget pregnancy test to exclude pregnancy. According to the ICSI guidelines, the diagnosis of premature ovarian insufficiency is based on the presence of menstrual disturbance and biological confirmation. Menstrual disturbance in the form of amenorrhea or amenorrhea at least for 4 months, and biochemical tests in the form of elevated FSH more than 25 international units per liter on 2 occasions 4 weeks apart. Again, just elevated FSH more than 25 international units twice separated by 4 weeks without the use of estrogen in the preceding 6 weeks. So other tests like the level of estradiol, LH, anti-malarial hormones are not required by the ICSI to make or to confirm the diagnosis of premature ovarian insufficiency. Only symptoms in the form of oligo or amenorrhea for 4 months and biochemistry in the form of elevated FSH more than 25 international units per liter twice separated by 4 weeks. The second group of tests is that we do to help clarifying the etiology. Most of the cases of premature ovarian insufficiency are idiopathic with unknown etiology. However, we might do some tests to try to get an idea about the possible etiologies, like screening for hydroxylase 21 deficiency, or alternatively adrenocortical antibodies if there is cortical function dysfunction. Also screening for thyroid antibodies if there are thyroid dysfunction. There is insufficient evidence to recommend routinely screening women for diabetes. There is no indication for infection screening in women with premature ovarian insufficiency. So if you have a reason, you can check for adrenocortical antibodies and thyroid antibodies to find a clue to the etiology of premature ovarian insufficiency. But there is no need to check for diabetes or check for infection etiology for premature ovarian insufficiency. What is the effect of premature ovarian insufficiency on the body systems, on the other functions of it? Usually it affects fertility, bone health, cardiovascular health, life expectancy, and the relatives. What is the impact of premature ovarian insufficiency on fertility? Actually, when premature ovarian insufficiency is diagnosed, the chance of fertility for the patient is completely lost. And IVF with donor egg is the only proven effective fertility treatment for these patients. Of course, donor egg is not allowed in many countries. Although it's said that around 5% of women with premature ovarian insufficiency will become pregnant spontaneously, but this should not be awaited as a method of treatment. What fertility interventions are effective? We have to inform women with premature ovarian insufficiency that there are no interventions that have been shown to increase ovarian activity and natural conception rates. And this is very important and very strong recommendation. Oocyte donation is an established option for fertility in women with premature ovarian insufficiency when culture and medical laws allow. In women with established premature ovarian insufficiency, the opportunity for fertility preservation, of course, is missed once the diagnosis is made. What about the role of stem cells in reproductive medicine for the patient with premature ovarian insufficiency? Actually, to say it sharp, there are no proven stem cell-based means to improve reproductive function, either by producing functional gametes in vitro or stimulating the residual stem cells in the ovary to elicit de novo oocyte production. So stem cells has no role to do regarding the treatment of premature ovarian insufficiency. And the doctors who offer this to their patients and cost them a lot of money in trying to help their problem by using the stem cells should not do this. Women with premature ovarian insufficiency should be informed that there is a smaller chance of spontaneous pregnancy. So if the woman is diagnosed to have premature ovarian insufficiency and she does not want to get pregnancy, she needs to use some method of contraception at least 6 months after the diagnosis of premature ovarian insufficiency is made. What about the impact of bone health? Premature ovarian insufficiency is associated with reduced bone mineral density, and reduced bone mineral density is very likely to indicate that premature ovarian insufficiency is associated with an increased risk of fractures later in life, although this has not been adequately demonstrated, and a balanced diet with the recommended intake of calcium and vitamin D should be advised. Estrogen replacement is a very important item in the management. The combined oral contraceptive pills may be appropriate for some women, but effects on body bone mineral density are less favorable. And lastly, other pharmacological treatment, included bisphonates, should only be considered with advice from an osteoporosis specialist. So we just have to advise the patient about exercise, good diet, adequate amount of vitamin C and vitamin D, and then other medication should be left to the specialist. What about the cardiovascular health, and is estrogen replacement cardioprotective? Untreated premature ovarian insufficiency is associated with reduced life expectancy, largely due to cardiovascular disease. Women with premature ovarian insufficiency should be advised on how to reduce cardiovascular risk factors by not smoking, taking regular exercise, and maintaining a healthy weight. Despite lack of longitudinal data, hormone replacement therapy with early initiation is strongly recommended in women with premature ovarian insufficiency to control future risk of cardiovascular disease. It should be continued at least until the age of natural menopause. So, what is the role of hormone replacement therapy in these patients? Women with premature ovarian insufficiency should be informed that HRT has not been found to increase the risk of breast cancer before the age of natural menopause. And if the woman still has a uterus, progesterone should be given in combination with estrogen therapy to protect the endometrium. Girls and women with premature ovarian insufficiency due to Turner syndrome should be offered HRT throughout the normal reproductive lifespan. Among the different manifestations of premature ovarian insufficiency, HRT had been shown to be very effective in vasomotor symptoms, genitourinary symptoms, bone health, cardiovascular health, and sexual functions. Among the other manifestations, like life expectancy is still not completely proven, but if it protects against vasomotor cardiovascular, if it improves the cardiovascular health and reduces the risk of cardiovascular problems, it will definitely increase the life expectancy. So what are the consequences of premature ovarian insufficiency for life expectancy? Untreated premature ovarian insufficiency associated with reduced life expectancy largely due to cardiovascular disease, and women should be advised to modify lifestyle to decrease the risk of cardiovascular disease. A common question usually comes from the relatives of a patient who has premature ovarian insufficiency. What are the implications for relatives of women with premature ovarian insufficiency? Relatives of women with the fragile X pre-mutation should be offered genetic counseling and tests. So only patients with genetic cause of premature ovarian insufficiency, the relatives of whom should have counseling and testing. No proven predictive test to identify women who will develop premature ovarian insufficiency, unless a mutation known to be related to premature ovarian insufficiency was detected. There are no established premature ovarian insufficiency preventing measures. Fertility preservations appears as a promising option, although studies are lacking. And if the potential risk of early menopause is significant, the relatives of women with premature ovarian insufficiency should take into account when planning a family. So, premature ovarian insufficiency, in conclusion, it is defined as a decline in normal function of the ovaries in a woman younger than the age of 40. It has a prevalence of 1 in 100 by the age of 40. The diagnosis is made by clinically oligoamenorrhea or amenorrhea for 4 months, chemically elevated FSH level more than 25 international units per liter on 2 occasions, 4 weeks apart. Treatment, no proven treatment to restore ovarian function once the diagnosis of premature ovarian insufficiency is made. Treatment is mainly symptomatic as HRT for cardiovascular symptoms, promotion of bone health with calcium, vitamin D, and a healthy lifestyle, monitoring for development of hyperplasia or uterine bleeding. Thank you. Okay.
Thank you very much, sir. It's a wonderful presentation and briefing regarding to the ovarian insufficiency. Thank you very much. And I think we have a break for just 10 minutes. Okay. So just 10 minutes and get back, everyone, if you want to pray or have a cup of coffee and get back straight away, because we have lots of presentation which are very, very important with eminent people in the field of infertility. So just 10 minutes from now it's 4 o'clock here in Egypt. So for 10 past 4, we will start our presentation again. Okay. Thank you very much. دكتور حسان اتفضل يا بيه. اتفضل يا بيه. اتفضل يا بيه.
السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, we will go back again to our meeting. I think we will start with Dr. Ahmed Hussein, who is going to talk to us about review of progesterone in PREM ICSI cycle. I will guarantee this lecture that this presentation is going to be very beneficial, and I've seen Professor Ahmed Hussein with his presentation. He's very clear, and I hope he will give you a clear role of progesterone in ICSI cycle. Please, Prof.
اهلا وسهلا بكم في الويبينار الخاص بالاي في اف والريبرودكتيف ميديسن. انا دكتور احمد حسين، استشاري واستاذ مساعد امراض نساء والتوليد في كليه الطب جامعه القاهره، ومحاضرتي ليكم النهارده ان شاء الله عن البروجسترون برايمد اوفيريان ستيميوليشن. البروتوكول دوت موجود بقاله فتره، واعتقد ان ده انسب وقت ان احنا نتكلم فيه، عشان في مشكله في الادويه بتاعه الداون ريجوليشن، سواء كانت الانتاجونست او الاجونست. فهو بروتوكول بديل وجميل ومفيد، ونشوف المعلومات اللي هنقدر نطلع بيها النهارده. هنشوف الافيدنس الموجود عليه حتى الان ايه هي، وهنتكلم حتى عن الطريقه بتاعته، عشان لو حد بعد ما شاف الافيدنس حابب ان هو يطبق البروتوكول بعد كده في الشغل بتاعه. انا هختفي دلوقتي وهيظهر البرزنتيشن. I hope you enjoy and find this presentation as useful as possible. بسم الله الرحمن الرحيم، ونبدأ بالبروجسترون primed ovarian stimulation. The idea behind the use of progesterone as a suppression هي الفكرة كلها ان we want to cancel اي LH surge in order to have complete control on the ovary. عشان كده اسمها controlled ovarian stimulation. وخلينا نشوف مع بعض الدايجرام ديت. لو هنقول ان this is the hypothalamic pituitary ovarian axis, we have the hypothalamus that secretes the gonadotropin releasing hormone that stimulates the anterior pituitary to release the FSH and LH, which in turn stimulates the ovary to produce eggs and to produce estrogen and progesterone. What we have is the estrogen, when it increases with time and with induction, it changes the negative feedback to positive feedback and causes the LH surge. So simply, in IVF we give induction. The problem with induction is that it will increase the serum E2. High serum E2, especially above 200 picograms for more than 50 hours, will change its feedback from negative feedback to positive feedback, and thus the hypothalamus will stimulate the pituitary to cause the LH surge. So we want to cancel the LH surge. What are the tools that we have now in order to cancel this LH surge? Of course طبعا يعني the first drug that we invented was the gonadotropin releasing hormone agonists، اللي هو الانالوج او زي الديكابيبتيل، زي التريبتوفام، زي اليوكرين. We also have the antagonists زي الستروريليكس والجانيريليكس اللي هو الستروتايد والأورجالوتران. And now recently we have also the progesterone. All of them act on the hypothalamus in order to decrease the pulsatility or pulsatile secretion of the gonadotropin releasing hormone, and thus stopping the pituitary and preventing the LH surge. The idea, by the way, is not new. Yani, if you see this paper, randomized trial in fertility from about 12 years, where they used clomiphene citrate in order to stop the LH surge in even people doing IUI, not even IVF, and they succeeded in doing this using the clomiphene citrate. But يعني somehow the clomiphene citrate did not take a lot of fame، ما خدتش شهرة كبيرة في الموضوع. واللي أخد شهرة كبيرة جدا في الموضوع هو كان البروجسترون primed ovarian stimulation. The mechanism of action, according to a recent publication, is that it reduces the GnRH agonist pulsatility from the hypothalamus and thus inhibiting the LH surge that happens with the increasing E2 levels. I want to start with history. يعني الموضوع كله بدأ تقريبا في جولاي 2015 with a very famous publication واحد اسمه كوانج إيتال، وطبعا مع المجموعة اللي عنده he published this paper that is titled Medroxyprogesterone acetate is an effective oral alternative for preventing LH surge for people doing IVF. عايز بس ألفت انتباهكم لكام نقطة. النقطة الأولانية خالص هي إن it was in July 2015. ده في عرف العلوم امبارح. يعني لو هي من 7 سنين فهي في عرف العلوم لسه يعتبر أول امبارح. It's relatively new. It was published in a very prestigious journal, Fertility Sterility. It was a prospective study, control study. Done over, I think, about 300 patients doing IVF, and he did not use dofastone, he did not use utrogestan. أول drug خالص فكر فيه كان الميدروكسي بروجسترون acetate. In his idea, and he started the progesterone on day 3 along with ال HMG. يعني بدأ البروجسترون مع حقن التنشيط، أيا كان هتستخدم HMG أيا كان هتستخدم FSH بس أو ميكس ما بين الاثنين. And he controlled these cycles with the short protocol اللي هو short agonist. يعني هو قارن ما بينهم على اساس ان الاثنين قصيرين. دي كانت بداية خالص الفكرة. بس طبعا لازم مع البروجسترون برايمد اوفيريان ستيميوليشن يو كانوت ترانسفير ان ذا سيم سايكل، عشان البروجسترون زي ما هو هيقفل اهلا وسهلا السيرج هو كمان هيأثر على الاندوميتريوم. It will cause asynchronicity between the dating of the endometrium and the date of the embryo. فهو عمل freeze all to both cycles. And let's see طبعا لازم مع البروجسترون برايمد اوفيريان ستيميوليشن يو كانوت ترانسفير ان ذا سيم سايكل، عشان البروجسترون زي ما هو هيقفل ال LH سيرج هو كمان هيأثر على الاندوميتريوم. It will cause asynchronicity between the dating of the endometrium and the date of the embryo. فهو عمل freeze all to both cycles. And let's see هو لقى ايه في الستادي بتاعته. The results is that the same number of LH surge. يعني هي تقريبا ما فيش LH surge وهنا تقريبا ما فيش LH surge. يعني progesterone was successful in stopping the LH surge. The same number of oocytes retrieved, the same number of embryos transferred, and it has the same implantation rate and pregnancy rate. ومن هنا اتولدت فكرة البروجسترون primed ovarian stimulation. Since then, almost 1,000 publications were done on the progesterone only, progesterone primed ovarian stimulation, including RCTs and meta-analyses. They compared everything. They compared the progesterone primed stimulation to natural cycles, to short protocol, agonist protocol, long agonist protocol. Everything was done. They tested it on poor responders, on normal responders, and high responders such as PCO patients. This is a very nice recent meta-analysis that compared everything in terms of البروجسترون برايمد اوفيريان ستيميوليشن. يعني مثلا دي اول حاجه هنلاحظ ان في البروجسترون when you compare البروجسترون برايمد اوفيريان ستيميوليشن to short protocol او حتى long او long protocol او antagonist protocol, you will find that there is actually less LH surge using البروجسترون برايمد اوفيريان ستيميوليشن عن بقيه البروتوكولز الثانيه. ده كان mainly في البور ريسبوندرز DOR يعني الديكريزد اوفيريان ريزيرف. however in normal ovarian reserve and PCO patients it had the same incidence of LH surge. هنا زي هنا سواء استخدمت long antagonist progesterone short كل واحد. الفرق الوحيد اللي كان ملحوظ ان عدد ال LH surge لو استخدمت البروجسترون بالعكس اقل بكتير من الشورت من البروتوكولز الثانيه especially in poor responders. The clinical pregnancy rate is more or less the same regardless of if your patient is poor responder, normal responder or high responder. The live birth rate and the ongoing pregnancy rate also is the same regardless كانت البيشنت poor responder, normal responder أو high responder زي PCO. And the OHSS, ovarian hyperstimulation syndrome, it was more or less it was more or less the same in normal responders. طبعا كانت almost zero في البور responders, ولكن كمان الميتا اناليسيس لقت ان the incidence of OHSS less when you use the progesterone عن بقيه البروتوكولز. واي ثينك دي برضو ليها تفسير منطقي ان هنا الميتا اناليسيس قارنت بروتوكولز مختلفه، قارنت الشورت، قارنت اللونج، وقارنت الانتاجونست. كلنا عارفين طبعا ان الاو اتش اس اس is much higher في الشورت بروتوكولز واللونج بروتوكولز compared للانتاجونست. فلما تيجي تقارن in one arm البروجسترون برايمد اوفيريان ستيميوليشن ببقيه البروتوكولز it makes sense ان البروجسترون برايمد اوفيريان ستيميوليشن has a lower incidence of OHSS. مش عشان هو في حاجه سبيشال بتخلي ال OHSS اقل، لا عشان الارم الثاني انت عندك مجموعه فيها اللونج بروتوكول والشورت بروتوكول اللي احنا عارفين مسبقا ان هم معاهم الانسيدنس اوف OHSS اعلى. في كمان معلومه مهمه جدا عايز اقولها ان البروجسترون برايمد اوفيريان ستيميوليشن زيه زي الانتاجونست. You can use a trigger of HCG and you can use a trigger agonist. يعني it is very safe زي الانتاجونست when dealing with high responders سواء PCO, young age, low weight, high reserve. It is very safe. You can easily and freely trigger with agonist or trigger with HCG. If you are afraid of OHSS, you can trigger with agonist. If you're not afraid of OHSS, you can go ahead and trigger with Ovitrel. ولكن هنا الفرق الوحيد in using البروجسترون primed ovarian stimulation انت مضطر ان انت تعمل freeze all regardless سواء كان التريجر بتاعك agonist او HCG. الدوز and duration لما نيجي نقارنهم كان في يعني آراء بتقول ان البروجسترون برايمد اوفيريان ستيميوليشن بيحتاج منك دوزز كتيره وديوريشن طويله. انا حاليا بستخدم البروجسترون برايمد اوفيريان ستيميوليشن دلوقتي داخل على حوالي 5 شهور. مش حاسس حتى بيرسونالي باي فرق ما بين الدوز او الديوريشن بين البروجسترون برايمد اوفيريان ستيميوليشن وما بين مثلا الانتاجونست، عشان انا كنت اكتر بروتوكول بستخدمه هو الانتاجونست. وفعلا الميتا اناليسيس it did not show any difference either in dose or duration between البروجسترون برايمد اوفيريان ستيميوليشن وبين اي other بروتوكول سواء كان long او short او antagonist. What about the number of oocytes retrieved؟ هنلاحظ هنا according to this meta analysis in the number of oocytes retrieved في البور ريسبوندرز كانت اكتر لو استخدمت البروجسترون برايمد، اكتر في النورمال ريسبوندر but the same in high responder. So there is a very promising fact in البروجسترون primed ovarian stimulation could be better in patients with poor responders. It could yield more oocytes and more M2 oocytes. هل الموضوع دوت confirmed؟ لا، we will need more studies, we will need more meta-analyses. يمكن نوصل لحد Cochrane review، بس it seems very very promising خصوصا في ال poor responders. Last but not least, we compared the number of embryos and the number of miscarriages حتى ما بين البروجسترون primes وما بين other protocols. It had the same number of embryos. So going back, you will find that the number of oocytes هو الوحيد اللي كان مختلف. ال OHSS كان أقل في ال high responders. وال يعني بايوكيميكالي بقى البريماتيور ال اتش سيرج كان اقل، بس ده كان خاص فقط بالديكريزد اوفيريان ريزيرف او البور ريسبوندرز. طيب ازاي بقى، ازاي اصلا بنستخدم البروجسترون برايمد اوفيريان ستيميوليشن؟ انا ما بحبش اسميه البروجسترون برايمد قوي، بس هو كل البيبرز بتسميه كده، انا بحب اسميه ذا بروجسترون فريز اول بروتوكول. دي طريقتي. حاول افهمكم الرسمه اللي انا كاتبها. هنقول مثلا ان this is day 1 or 2 or 3 of the cycle. البيشنت هتجيلك وهتبدا معاها الجونادوتروبينز وهتبدا معاها البروجسترون. نوع البروجسترون ايه هنتكلم عليه قدام. They both start on the same day. يعني if you start on day 1 or day 2 or day 3 of the cycle, you will start both. الstimulation whether you're using HMG only or FSH only or HMG and FSH مش هتفرق، بس you should start البروجسترون معاه. They go hand in hand لحد ما توصل للسايز اللي انت عايزه الفوليكلز من 17 ملي او اكتر، وبعد كده هتدي التريجر. تنويه برضو في النقطة دي، progesterone primed ovarian stimulation you can use both types of trigger. You could use either HCG or you could use agonist trigger لو انت خايف من OHSS. وكالعادة طبعا كلنا بعد 34 ل 36 ساعة بنعمل oven pickup, but there is no transfer. You have to freeze all. طيب paper كمان مهمة عشان الناس اللي كانت بتسأل does progesterone primed ovarian stimulation has any effect on the neonatal outcome؟ ولو ان في رأيي ان بدري جدا، لان احنا البروتوكول اتولد في 2015 ودي معمولة في 2017. هل لحقوا ان هم يشوفوا النيونيتال outcomes في الفترة دي؟ يعني دي randomized trial كانت اتعملت وبيقولوا ان there is no difference in the neonatal outcome whether you used progesterone primed ovarian stimulation or other protocols, and it has the same neonatal outcome. نيجي بعد كده للنوع. معلش هخش على السلايد اللي بعدها. اول حاجه خالص اتوصفت في البروجسترون برايمد اوفاريان ستيميوليشن ما كانتش يوتريجستان اللي هو موجود في بلدنا في مصر البروجست، وما كانتش الدوفاستون اللي هو مشهور دلوقتي في مصر ان احنا بنستخدمه. كانت الميدروكسي بروجسترون اسيتيت. فالميدروكسي بروجسترون اسيتيت ينفع. يوتريجستان اللي هو البروجست عندنا في مصر ينفع. الدوفاستون كمان ينفع. There is no difference between using any type of progesterone. كلهم بيفوا بنفس الغرض. How about the dose؟ الدوز المعتاده لليوتريجستان كانت 2 pills per day اللي هي 2 pills 100 مللي او 1 pill اللي هو ال 200 مللي جرام. انا كنت بدات شغلي ان انا كنت بستخدم 200 مللي جرامز بير داي. بقالي دلوقتي شهر ونص قللت الجرعه بتاعتي من 200 to 100 مللي جرامز بير داي. مش حاسس باي فرق، ما عنديش اي بيشنت حصل لها اوفيليشن سبونتينيوس. مش حاسس باي فرق في الدوزج ان انا استخدمت دوزج اقل او غيره. استخدمت بروجست، استخدمت دوفاستون، الاثنين ينفعوا، ما فيش اي مشاكل خالص. So the main advantages of such protocol طبعا it is much cheaper. It's cheaper than the long protocol, long agonist, and cheaper than the antagonist protocol. الحاجة التانية طبعا في فترة زي اللي احنا فيها ديت اللي هي بنعاني عشان نلاقي تريبتوفام وديكابيبتيل وستروتايد، هو بديل جيد، هو بديل جيد جدا. الاماونت اوف انجكشنز اقل بكتير. يعني انت لو بتدي نوع واحد بس من الحقن فانت كده بتدي حقنه واحده، قبل كده كان لازم تدي اتليست حقنتين. less complaints from the patient. يعني البيشنت مش هيقول لك يا دكتور الحقن كتيره او غيره او جسمي بيزرق، جسمي بيوجعني. هي ممكن قوي تمشي البروتوكول كله بوان انجكشن. بروجسترون از ريدلي افيلبل في كل حته. انت حقك تستخدم الميدروكسي بروجسترون استيتس، حقك تستخدم اليوتروجستان البروجست، حقك تستخدم الدوفاستون، كلهم ينفعوا، كلهم رخاص وافيلبل افري وير. مفيش العذاب اللي احنا بنشوفه الايام ديت في توفير العلاج. وفي زي ما قلنا potential advantage ان هو it might yield more oocytes، ولكن احنا هنا الاخص فين البور responders. However the main disadvantage هو الفريز اول، لان المشكله هنا دلوقتي ان في بعض البيشنتس بيبقوا جايين مثلا البلد عشان هو يدوب شهر واحد، وهم عايزين فقط في الشهر دوت يعملوا البروسيس كلها، يعملوا الاندكشن والاوفن بيك اب والامبريو ترانسفير. فطبعا اتس نوت فيزبل ان احنا نديهم لونج بروتوكول، اند اتس نوت فيزبل ان احنا نديهم بروجسترون برايمد بروتوكول. ما قدامناش غير 2 اوبشنز، هو الشورت بروتوكول والانتاجونست بروتوكول. وطبعا شتان ما بين الاثنين. البريجنسي ريت في الانتاجونست كومبيرد للشورت بروتوكول از ماتش بيتر. دي كانت باختصار، وحبيت المحاضرة تبقى خفيفة وسريعة ما يبقاش فيها أي مشاكل، وهرجع لكم تاني بس عشان أقول لكم بعض الملاحظات اللي عندي. أنا حاليا بستخدم البروجسترون برايم بروتوكولز بقالي تقريبا 5 شهور دلوقتي. استخدمته في كل أنواع البيشنتس زي اللي شفتوه كده في الميتا أناليسيس. استخدمته في البور ريسبوندر، نورمال ريسبوندر، والهاي ريسبوندر. تو بي اونست انا مش حاسس بفرق كبير ما بينه وما بين الانتاجونست بروتوكول، لان انا كنت انتاجونست بيرسون. انا كان اغلب يعني 99% of my protocols is antagonist. بستخدمه في الهاي والنورمال والبور ريسبوندرز، فانا دايما بقارن البروجسترون بالانتاجونست. مش حاسس بفرق خالص فعلا ما بين الديوريشن ولا الدوزج ولا النمبر اوف اوسايتس ولا البريجننسي ريت. في ملحوظة تانية عندي أنا هقولها ومعرفش هل هي مرتبطة بالبروجسترون ولا لأ. أنا عندي 2 patients في نفس الأسبوع لقيت عندهم مونو كوريونيك، واحدة داي أمنيوتيك، واحدة مونو أمنيوتيك. 2 patients عامل لهم IVF. يشتركوا ال 2 patients إن هم PCO، يشتركوا ال 2 patients ان هم اخدوا البروجسترون، اخدوا نفس نوع ال HMG، تقريبا نفس الديوريشن، الاثنين كان نفس الدكتور، والاثنين كانوا نفس المعمل، والاثنين نقلوا نفس عدد الاجنه، والاثنين كانوا في day 5. دي نقل لها 2 بلاستوسيست ودي نقل لها 2 بلاستوسيست. فالاثنين مع المتابعه لقيتهم مونو، يعني توينز، والتوينز ديت كيس منهم ساك منهم مونو كوريونيك، بس واحده كانت مونو كوريونيك مونو امنيوتيك، والثانيه مونو كوريونيك داي امنيوتيك. في شغلي كله في الحقن المجهري انا ما شفتش مثلا غير يمكن 5-6 على مدار 10 سنين. فان انا اشوف 2 في اسبوع واحد، هل دوت صدفه؟ ميبي. هل ليها علاقه بالبروجسترون؟ ميبي. بس حبيت بس اقولها للتاريخ ان لو ثبت في السنين اللي جايه ان البروجسترون برايمد بروتوكول بيزود الانسيدنس اوف مونوكوريونيك توينز، يبقى احمد حسين قالها في مره. لو ما بيزودش فاديني بشارككم الاكسبيرينس بتاعتي. اتمنى يكون بس المحاضره اقنعتكم ان في حاجه مهمه ويوسفول جدا وفيري ايزي تو يوز وكونفينينت للبيشنت اسمها البروجسترون برايم اوفيريان ستيميوليشن. بديل جيد في الفتره اللي احنا فيها ديت، لان احنا فتره صعبه جدا الصراحه. I hope that the evidence is enough to convince you, and وأتمنى أكون أنا شرحته. هو سهل جدا وبسيط جدا. وشكرا جزيلا، وآسف إن أنا طولت عليكم. أنا عديت خلاص 20 دقيقة. شكرا.
Thank you very much. It's wonderful presentation and very simple and it's easy. I think I agree with you completely of what you said. The use of progesterone nowadays, I used instead of the antagonist protocol, I started long time ago using progesterone because of what you said, shortage and lack of medication here in Egypt. So I used to use stronate just 1 tablet after breakfast and 2 tablets after dinner. Because why 2 tablets after dinner? Because it might cause some sort of sleepiness. That's why I would prefer this is from the 1st to 2nd day of menstruation and start HMG afterwards. Thank you, Ahmed, very much. It's nice. But
You're welcome,
maybe I disagree with you regarding to not disagree, but I don't think there is a definite relation between twinning and whatever the type of twin and the progesterone. But anyway, let's go and see what's going on. But anyway, progesterone is nothing except to stop LH surge, and that's it. So it will keep the LH surge and prevent premature luteinization and premature ovulation. This is, but anyway, we shall see anyway. Waiting from you to conduct or to collect data from your cases and from your friends, and I'm going to add my cases to you and see if this progesterone might be associated with increased incidence of multiple pregnancy or not. Thank you very much. It's wonderful, to be honest. As Professor Dr. Abdul Gabbar said, you are direct to the point and straightforward as well. Professor Dr. Abdul Gabbar, are you there? Dr. Abdul Gabbar.
دكتور حسان اعتقد موجود.
I am here. They are not giving me.
Okay,
that is why you can't hear me. Very interesting, actually. It was a very interesting presentation, and I think there is a lot of people that will benefit out of this nice, very clear presentation. And be careful, Ahmed. A lot of people, they are going to use your protocol. The next meeting, you will have a lot of people. They are competing with you. Maybe they give you more twins there and there. Anyway, I think should we continue or let's stop for questions? Sure. Would you mind to introduce the coming speaker, please, Dr. Hassan? Professor Hatim, Professor Hatim Al-Jamal. He's going to talk about Hatim Al-Jamal. Is he ready, Professor Hatim? Yes, he's ready. He's. Would you introduce him, please? Yeah, Professor Hatim is going to go through a very interesting thing in IVF ICSI cycles. We always have a debate and whether it's better to transfer an embryo which is fresh or frozen. There's so many articles and there's so many evidence to tell you which is better. I'm not gonna burn the lecture, but I will wait for Professor Hatim to tell us what is the best way of embryo transfer. Please, Professor Hatim. Okay, Professor Hatim is the head of obstetrics and gynecology, the head of the IVF Center in Shams University, and is one of my colleagues. He is professional in assisted reproduction, and I'm very happy with his participation. Shall we start the presentation, please?
Good evening, doctors. I am Professor Hatim Gamal, Professor of Obstetrics and Gynecology and Reproductive Endocrinology in Shams University, and I am the head of the Assisted Reproductive Technique Unit in Shams University. Today we will discuss a specialized subject in our specialty, which is the IVF. We will discuss the fresh versus frozen embryo transfer. Every day in our specialty there is advance. Since the delivery of the first baby, now she is not a baby, first baby was Louise Brown in 1978, and she is now 44 years old. Since the delivery of Louise Brown, there is a continuous advance in our field. starting from the introduction of the gonadotrophins, which was human menopausal gonadotrophins, till the recombinant gonadotrophins, and the change from the IVF to the intracytoplasmic sperm injection, then the freezing of the embryos, and starting by freezing, and then there is advancing freezing, which was the vitrification. And according to this advance, we have the chance to use the frozen embryos instead of the fresh embryo transfer. But is frozen embryo transfer magic that it will solve the problems of our specialty regarding the failure? Is it a magic? No, it is not. It is. So this paper was published in 2021. And when should we freeze embryos? These current data from the randomized trials for fresh and the frozen embryo transfer replacement in the IVF cycles. And it is stated that to date, it is reasonable only to perform frozen embryo transfer in cases with clear indication for the benefits of such a strategy, including impending ovarian hyperstimulation syndrome, which is our nightmare in our specialty, or the pre-implantation genetic testing for the aneuploidy or the BGTA. However, this strategy does not fit for all. That's to say, it is not like some units in the world use the frozen embryo transfer in all patients. It is not our advance, it is not our advice to use the frozen embryo transfer for all patients. Only we need the frozen embryo transfer in ovarian hyperstimulation in those patients who will develop ovarian hyperstimulation, or if we wanted to perform pre-implantation genetic testing for the aneuploidy. And these are the indications according to the randomized controlled trials. This paper was done in 2016 according to fresh versus frozen embryos for infertility in patients with polycystic ovarian syndrome. And accordingly, in polycystic ovarian syndrome, and please diagnose the polycystic ovarian syndrome according to Rotterdam criteria, which is 2 out of 3. 3 was infertility and oligomenorrhea and menstrual disturbances. The second will be androgenic manifestations, both biochemical or clinical. And the third will be the ultrasound finding nucleus appearance of the ovary, the subcortical area of the ovary. And there are several malpresentation. دايما احنا بنشخص البي سي او كتير قوي وهو ما بيكونش حقيقه بي سي او. يعني ما فيش عندنا حاجه اسمها مجرد ان انا احط السونار على بطن العيانه والاقي مالتيبل فوليكلز اللي هي الانترال فوليكلز واقول ان دي عيانه عندها بي سي او. لازم البوليسيستيك اوفري يتشخص according to Rotterdam criteria. وبليز برضو البي سي او ان ادوليسنت، يعني حتى ان ادوليسنت دلوقتي ما بقيناش نعتمد على الالترا ساوند خالص. مش كل عيانه عندها dysfunctional او بنت عندها dysfunctional triangle bleeding نحط السونار على بطنها نلاقي multiple follicles ونقول لهم دي عندها polycystic ovary. Polycystic ovary is only diagnosed according to the Rotterdam criteria. ما فيش حاجه برضو ان انا الاقي ال اتش عالي شويه عن الاف اس اتش اقول ده ريفرس ريشيو يبقى دي بي سي او. ال اتش مهم في الفايندنجز بتاعتنا لكنه it is not a diagnostic of the polycystic ovary. In case of the polycystic, what is about the fresh versus the frozen embryo? The finding of this study, it was found that a primary outcome, which is the live birth rate, in case of the frozen embryo transfer, عدد العيانين the number was 746, and the fresh embryo transfer was 762. Primary outcome was the live birth rate. The result was in frozen embryo transfer, there is percentage of 49% success live birth rate. And in fresh embryo transfer, the result was 42, and this was a significant difference. So there is the fresh embryo transfer is very suitable. The frozen embryo transfer is suitable to the patients with polycystic ovary, as the live birth rate outcome is better in frozen embryo transfer than the fresh embryo transfer. The second outcome is the pregnancy loss. The pregnancy loss. Among the clinical pregnancy loss in those patients with the frozen embryo transfer, there is about 14%, only 14% loss. However, in the fresh embryo transfer, it was 25% with highly significant difference. So again, the frozen embryo transfer is very suitable, or more suitable, for those patients with polycystic ovarian syndrome. Number 2, transfer of the fresh versus frozen embryo in ovulatory women. Those women does not suffer from doing IVF for another cause, for male factor, for example, for tubal factor, for example, for unexplained infertility, for example. It is not for polycystic ovary. The result is the live birth rate. There was no significant difference between. It was in the frozen embryo transfer was 48. We said this, the first two, ovarian hyperstimulation syndrome, is absolute indication according to the randomized control trials. Pregnant pre-genetic implantation testing for the aneuploidy is another indication according to the randomized control trials, and we have other indications we can do. For example, raise the progesterone on the day of trigger of the trigger injection. As we all know, that increase the level of the progesterone will affect the success rate of the our IVF. So this part is still debatable. We can do freeze, so we individualize in those patients. Some patients we can freeze, and some patients we can transfer. In case of recurrent implantation failure, again, this is debatable. If it is those patients with recurrent implantation failures with the fresh embryo transfer, we can do for them frozen embryo transfer. Uterine abnormality, regarding the uterine abnormality, it should be solved before the IVF cycle. For example, in those patients with the fibroid, previously we told about the fibroid, we said that no interference with the fibroid, especially the intramural fibroid. Of course, with the subserous fibroid, we don't interfere with the subserous fibroid, unless it was a very large and it will affect the pregnancy. Submucous fibroid, we must interfere before the IVF. However, the intramural fibroid, in the past, we don't interfere with this type of the fibroid, but nowadays it was found that if it is better to remove the fibroid before the IVF cycle, and we said about the ideal removal of the fibroid, not the removal that will result in the opening of the cavity and complicated by the Usher-Mann syndrome. So we said about the ideal removal of the fibroid. So the uterine abnormality must be treated before the IVF cycle. Again, the septum. The septum, if it is more than 1 centimeter, 10 millimeter long, we should remove the septum by hysteroscope before the IVF cycle. Regarding the polypi before the IVF cycle, we must remove the polyp before the IVF cycle. But here, uterine abnormality, by in this point, we mean that those polypi which develop during the process of the stimulation. If the polyp less than 10 millimeter, we can do embryo transfer. But if there is multiple polypi and it is more than 15 millimeter, so we must freeze the embryos and transfer in another cycle. So the indications, as we said, ovarian hyperstimulation, BGTA, raised the progesterone on the day of the trigger, recurrent implantation failure for fresh, uterine abnormality, by which we mean the development of the polypi during the process of the stimulation. Again, the transfer on the day 6 plus 2 cyst, usually day 6 plus 2 cyst is not suitable for the transfer. And this we may results if we do for those patients BGT and there is delay in the results, and so we reach the day 6. So in those patients we must transfer on. We must do the freeze the embryos and retransfer. Sometimes we do random start stimulation, start ovarian stimulation, especially in those oncogenic patients or those patients who will need to do rapid ovum pickup and freeze the embryos till they end their treatment for the malignancy. Again, if there is complication occurs during the cycle of the IVF, during the egg collection, for example, if there is bleeding that may occur during bleeding, if there is injury to some viscous, so we must do freeze all strategy for those patients till we treat the complications. And sometimes in social factors and those who will travel and those there is problem socially, and they need to freeze, not to transfer these cycles. These are the actual indications for the freeze hold strategy. According to the randomized control trials, well, can we do freeze for all patients? No, this is not accepted at all. Only for those indications or what we said. Risk of hyperstimulation, of course, this is according to the randomized control trials. Based on the ovarian response, again, that she will develop the ovarian hyperstimulation, this is again approved. The progesterone levels at the day of trigger debatable. Some transfer and some didn't transfer. If there is implantation failure, debatable, but we approve to do those for those who have recurrent implantation failure with the frozen. In BGT or BGTA plus 2 cyst, this is approved according to the randomized control trials. If the slower developing plus 2 cyst, that is to say it develop on the day 6, so it is important. Again, this is we can do frozen embryo transfer. Endometriosis, it is debatable to do that, but some prefer to do frozen embryo in case of endometriosis. To improve the obstetric outcome or the perinatal outcome, this is not approved at all. That's to say, those patients who with recurrent missed abortions, those patients with recurrent intrauterine fetal death, all this is to do for those patients IVF. This is not accepted at all. It is very important to do frozen embryo transfer to know what is the time of window of implantation. So it is generally accepted that for successful human pregnancy to occur, the embryo and the endometrium must be in great synchrony. That's to say يعني أنا لازم أوصل للوقت، يعني أنا يكون عندي الكابابيلتي إن أنا to prepare the endometrium، إن أنا أوصل في الويندو اللي هيقبل الاندوميتريوم الامبرو for the transplantation for الامبرو في هذا الوقت. فده very important. This is what's called the window of implantation. According to this, we have different strategies to prepare the endometrium for the frozen embryo transfer. We have the natural cycle. We can use the natural cycle. Use natural cycle, true natural cycle، يعني احنا ما بنعملش حاجه خالص. natural cycle الدوره بتيجي بنعمل folliculometry ونشوف الاندوميتريوم وننقل at the time when there is trilaminar endometrium واضح قدامنا، trilaminar واضح اكثر من 8 مللي we can do to transfer in this time. With this transfer using the progesterone support or without using the progesterone support. Actually, we don't, some centers, we don't use the natural cycle actually for the, in our unit at least, in Shams University, in our practice nearly in Egypt, we don't use the natural cycle for the transfer, but some units in the world use the natural cycles, but we don't advise to use the natural cycles. We usually always use the modified natural or mainly the artificial cycles for the transfer of the embryos. So the natural cycle, we just follow up the patients up from the second day of the cycle till they're following mainly the endometrium till it reaches the trilaminar layer. So then we transfer the embryos whether we support it with the progesterone or without support with progesterone as it is natural. A modified natural cycle, this is the, we can use, we use modifications in these cycles. In these modifications, we can do some stimulation using the, using something like the clomiphene or the letrozole, and then better we prefer to use the letrozole because not to affect the endometrium, or they don't, or only follow up and then doing trigger and transfer the embryo after 3 days if we are frozen at the day 3, or after 5 days if we are frozen on the day day 5 here. After 5 days from the trigger, or after 3 days from the trigger, then we do support with progesterone or without progesterone. This is the modified natural cycle. Again, we don't prefer the modified natural cycles, but actually we do the artificial cycle. Artificial cycle preparation, this is either we can use the GnRH or with suppression or without the GnRH suppression. This figure represents the frozen embryo transfer using the artificial cycle. In this only we prepare the endometrium starting from using the estradiol valerate. The estradiol valerate, as we all know, in our country, especially in Egypt, that's to say, we don't have the estrogen valerate, so we can use the estrogen in the cycle progenova. So we use the estrogen in the cycle with 2 tablets per day, starting from the day 2 of the cycle for about 12 days. And we measure in this time the by the ultrasound. This time we measure by the ultrasound the thickness of the endometrium till it reaches the thickness of the endometrium above 8 millimeter till 12 millimeter. At this time, we starting the progesterone, whether we use the progesterone injection or the progesterone suppositories, and we transfer according to the embryo dating. If we're starting when 3 days, after 3 days of the start of the progesterone, if we are freezing at the day 3, we can transfer. And if we are freezing for at the day 5. So after 5 days from the starting of the progesterone, we can transfer, and then after 2 weeks we do the HCG testing to prove the occurrence of pregnancy. This is the frozen embryo transfer occur in most of our centers, but in another centers we can use using suppression again with the GnRH. That's to say, starting from the day 20 or the day 21 of the preceding cycle, we use the decapeptyl 0.1 or the or tryptophan 0.1 every daily till the occurrence of the cycle. At the cycle, we do some tests to prove that the complete suppression occurs. We measure the progesterone must be less than 80 or less than 50, and we measure the LH, it must be less than 5, and the endometrium is less than 5 millimeters. At this time, we start the preparation of the endometrium. We then started the preparation of the endometrium using the estradiol valerate for 10 days, continuous with this, the suppression with the use of the decapeptyl suppression. Then we do the same after when we reach the endometrium about 8 to 12 millimeter, we start to do the progesterone and to give them the progesterone whether intramuscular or give the progesterone suppositories, and then we transfer the baby out and transfer the embryo at the day 3 of the progesterone if we are freezing at day 3, or at the day 5 if we are freezing embryos at the day 5. And we stop at this time the suppression using the decapeptyl, and we continue till we do the pregnancy test. And if the pregnancy test is positive, and so we will continue using the progesterone and using the estradiol valerate till the end of the first trimester. So accordingly, the artificial frozen embryo protocols use suppression of the natural menstrual cycle with the use of GnRH agonist and require exogenous estrogen and the progesterone replacement to achieve adequate proliferative and secretory changes in the endometrium in preparation for implantation and the early pregnancy support. Various estrogen and progesterone preparations. Oral, we have nowadays, we have oral, we can use the dydrogesterone. We don't use usually the natural progesterone orally because of the first pass metabolism and it will be destroyed at the stomach. But the dydrogesterone, we can use the dydrogesterone orally, and there is a study called the Lotus study comparing the dydrogesterone with the various forms of the natural progesterone and the micronized progesterone, and it was found that the results was the same. In our units, we usually we don't use the injectable because the injectable intramuscular, we have of course the subcutaneous progesterone, but it is expensive. And the intramuscular, usually it is oily solution and it will result in multiple abscesses at the site of the injection. So usually we prefer the vaginally, and nowadays we have the oral. In our units, we use the combination between the oral and the vaginal progesterone have been used successively in the program, the frozen embryo transfer cycles. Regarding the current data, regarding the live birth rate, as we said, live birth rate was the same regarding the frozen and the fresh embryo transfer. If we have good indication for this results, if we have the capabilities of good preparation of the endometrium, and if we have good freezing and good vitrification in our program, prenatal outcomes was the same, obstetrical outcomes again with the same, other outcomes there is no difference regarding the frozen and the fresh transfer, regarding the, for example, the malformations, for example, about the frozen embryo transfer. I think this is all about the frozen embryo transfer, and we must stress that we need the frozen embryo transfer in cases or in some indications, as we said before. Again, ovarian hyperstimulation, pre-implantation genetic testing, raise the progesterone on the day of the trigger, the current implantation of ovarian, uterine abnormality developed during the stimulation, as cases of the uterine polypi, day 6 plus to cyst, random start stimulation of the ovarian, complications that may occur during the egg collection, and in some social indications. Thank you very much.
Thank you very much, Professor. I think this is really a dilemma for patients for doctors who are using IVF, and sometimes even patients ask whether frozen is better than fresh or fresh is better than frozen. And but today you have outlined a good presentation to show why actually we're doing frozen embryos. Sometimes you know that frozen embryos are we are forced to do it. We're forced to do it. We have embryos, extra embryos, so we freeze it and then we put it again. So patient will usually ask, I didn't get pregnant in fresh cycle. How could I get pregnant in the frozen cycle? But with your presentation, I think we could have an answer to this question. We're still in embryo transfer, and we're still in preparing the endometrium. I think we're going to have now another presentation about preparing the endometrium for frozen embryos. Professor Ashraf Abu Ali, who's a consultant OBGYN IVF professor, he's going to present how can we optimally prepare the endometrium for frozen embryo transfer. Prof. Ashraf, are you ready?
Okay. We're going to start straight away, sir.
No, sir.
Start.
Yes. No, sir.
Frozen embryo transfer. Me, I am Dr. Ashraf Abu Ali, consultant of reproductive medicine and director of Medina Fertility Center, and EFRI treasurer and the founder. I'll address today the subject of frozen embryo transfer. The incidence is increasing. There is an increasing number of cases of presenting all over the world. 77% of embryo transfer in 2020 in USA were frozen embryo transfer, thawed embryo transfer. Slower but steady increase in the rest of the world, and the era of freeze-all make it a very important issue. There are a lot of indications for embryo cryopreservation, storage of surplus embryos, freeze-all cycles, the fear of ovarian hyperstimulation syndrome, and so now we can have many ovarian hyperstimulation syndrome free clinics, and poor implantation potentials, and patients for fertility preservation for whatever the issue, and the BGTA patients. We all know this very important systematic review in 2019 by Matheus Racchio in Brazil about the importance of the freeze-all policy and its effect on the live birth rate. And he concluded that although the use of elective frozen embryo transfer has steadily increased in recent years, a significant increase in live birth rate with elective frozen embryo transfer solely noted in hyper-responder patients and in patients undergoing BGTA. And concerning the safety of elective frozen embryo transfer, significantly decreased the risk of moderate and severe hyperstimulation syndrome, and this was the issue that expanded the use of freezing all over the world. This is another very interesting study from the start by Suhail Maashar, and it showed the importance of freeze-all policy, especially in the category of high responder patients with 15 oocytes or more. However, in intermediate or low responders, the clinical pregnancy rate and live birth rate were higher after fresh embryo transfer. And so now it is agreed that in high responder, it will be beneficial for freeze-all. But we know that many centers all over the world are working with the policy of freeze-all for all. And so whatever the indications, there is a great debate about the methods we are using to prepare the endometrium and to prepare our patients for thawed embryo transfer. We have the natural cycle. It is either a true natural cycle or modified natural cycle. True natural cycle with or without luteal phase support, this is a question. Modified natural cycle with or without luteal phase support, this is another question. And we have mild ovarian stimulation protocol, and it is a raising protocol nowadays. And we have the most widely spreading used protocol, which is the artificial cycle. And also, again, it could be used with or without separation. As regards the natural cycle frozen embryo transfer, it is the most physiological protocol, and it requires patients with regular cycles, and the least flexible protocol and timing of a spontaneous ovulation needs to be precisely identified in this natural cycle protocol. How can we do the natural cycle or the true natural cycle protocol? So as we mentioned, we have the true natural cycle protocol and the modified natural cycle protocol. The true natural cycle protocol will do basic ultrasound to exclude any cyst remaining from the previous cycle. And then we will have frequent ultrasound and hormonal testing performed starting from around day 8 or 9, when the follicles are exposed to be around and expected to be around 15 millimeters or more. And we can use serial measurements of LH, of progesterone, or E2 to help us. How can we identify the LH surge? Multiple definitions of LH surge. Either you'll find a rise of 80% above the previous reading with continued rise afterward, or you will find the LH more than 10 international units per liter, or you will find the LH more than 17 international units per liter with more than 30% drop in the E2 on the following day, which is mimic the natural physiology, as we will see in the next slide, or the highest level of LH. This is considered the LH surge. Ovulation usually occurs 24 hours after the LH surge, up to 56 hours. Leavage stage embryos transferred LH plus 6. As we see in these slides, where is the LH surge, and as we see the level of estrogen, this is in blue, and how it is starting to decrease 1 day after the LH surge, and we are trying to mimic this or to utilize these curves or to utilize this hormonal profile to transfer the embryos in a natural cycle with corpus luteum. The important issue or question is that luteal phase support in the natural cycle. If we use natural cycle to transfer your embryos, will you use progesterone or HCG or not? The rationale for fear of suboptimal luteal phase progesterone or LOF syndrome, randomized control trials showed the progesterone for luteal phase support significantly increased the live birth rate if we use 400 milligram micronized vaginal progesterone twice daily. And another randomized control trial showed comparable ongoing pregnancy rate with or without HCG. In the natural cycle, on the true natural cycle, too early start of luteal phase support might lead to asynchrony between the embryo and the endometrium. Thus, luteal phase support, if we start luteal phase support in the natural cycle, should be started at least 72 hours after LH surge. The modified natural cycle frozen embryo transfer, again done in women with regular menstrual cycles. And the modified natural cycle requires less monitoring than true natural cycles, as it is more patient-friendly. Initial evaluation is the same like the natural cycle protocol. And when the dominant follicle reaches 16 to 20 millimeter, HCG trigger is administered. And so here it is timed. And hormonal evaluation here is query or debatable, no need for it. And in the modified natural cycle, after we trigger with HCG, ovulation will occur 36 hours or more after HCG administration. And so frozen embryo transfer in the modified natural cycle will be after HCG with +5 days in the cleavage stage or +7 days in the blastocyst stage. The luteal phase support, HCG, is given to trigger ovulation and work as a luteal phase support in the same time. هنا انت هتبقى مدي HCG فبالتالي هيبقى فيه luteal phase support وفيه corpus luteum, since it is long acting and with a lutetropic effect, it seems reasonable not to administrate or not to administer added luteal phase support in these cases. The true natural cycle, either similar to or better than modified natural cycle. Important modification, modifying variables are adjusted frozen embryo transfer time, lack of luteal phase support, shift to true natural cycle frozen embryo transfer in case of modified natural cycle with impending spontaneous LS surge. Recently, meta-analysis showed no difference in live birth rate between both natural and modified natural cycle embryo transfer. What about the mild ovarian stimulation? Actually, in recent years, the mild ovarian stimulation take over a very important steps. بدل ما نستخدم natural or true natural, we can use mild ovarian stimulation. بكده هيبقى عندنا we will have corpus luteum, وبكده هيبقى عندنا good chance to have corpus luteum with a moderate support without a lot of estrogen, with the disadvantages of estrogen, and we can have a good outcome. The mild ovarian stimulation will be used in a non-regularly cycling woman. If the woman is not regularly menstruating, we can use this protocol instead of the other protocols, and it is easy to use and it suits them. Regularly cycling woman to improve folliculogenesis, better corpus luteum, and corpus luteum function, better endometrial potential. Stimulation will start on day 2 to 3 of the cycle. Type of stimulation نقدر نستخدم aromatase inhibitors زي الفيمارا لتريزول 2.5 to 5 milligram per day. نقدر نستخدم clomiphene citrate from 50 to 100 milligram per day. نقدر نستخدم FSH ampule and FSH only 75 to 150 international unit per day. Very soft protocol, very few days of gonadotropin, and then we can have corpus luteum. We can have no problem with the long luteal phase support of estrogen اللي احنا بنستخدمه في artificial cycle. Advantages of FSH over and letrozole over the clomiphene citrate. لو استخدمنا FSH أو letrozole, we will have intact hormonal axis and we will have lack of anti-estrogenic effect to the endometrium. نقدر نتجنب الانتي-estrogenic effect اللي موجود من الكلوميفين citrate. What are the criteria of triggering of HCG triggering? لو الانdometrium more than 7 millimeter, leading follicles more than 17 millimeter, one or more follicles. مش لازم نطلع عدد follicles كتير، احنا غرضنا الانdometrium فمش لازم يطلع follicles كتير. Estrogen more than 150 picogram per milli. The timing of frozen embryo transfer, again, HCG +5 للcleavage stage embryo and HCG +7 للblastocyst embryo. يعني البلاستوسيست بتاع ساتردي هيرجع ساتردي لو احنا ادينا الاس جي ساتردي. Mild ovarian stimulation using gonadotropin or letrozole yields a higher live birth rate than mild ovarian stimulation using clomiphene citrate. Luteal phase support is commonly used in mild ovarian stimulation for the embryo transfer. However, no available randomized control trials comparing luteal phase support with no luteal phase support. بيتاخد luteal phase support في حالات المايلد ستيميليشن بس ما اتعملتش ستاديز وشاف فرق الحمل ما بين الاثنين. Lastly, the most widespreading method that we are using is the hormone replacement therapy. Endometrial priming as well as secretory changes are induced using exogenous hormones. We are using estrogen and progesterone to induce exogenous effect. Estrogen administration, estrogen treatment should be started early, cycle day 1, 2, or 3 in order to suppress spontaneous folliculogenesis. Multiple routes are available, yet the oral route is the most commonly used one. Natural as well as synthetic estradiol can be used. Estrogen administration will start by a dose of 6 to 8 milligram per day. هنستخدم either step up or fixed protocols yielded comparable live birth rate. Duration of estrogen administration is flexible, but usually not less than 10 days. لو استخدمنا less than 10 days, we will have higher miscarriage rate with estrogen less than 10 days. Estrogen treatment can be continued up to 36 days in some reports. Estrogen administration after sufficient number of days, vaginal ultrasound is performed to ensure absence of dominant follicle and endometrial thickness more or equal to 7 millimeters. After fulfilling the above criteria, progesterone administration is started and frozen embryo transfer day is decided. Estrogen administration is continued after the start of progesterone. Pituitary suppression can be performed using agonists or antagonists with similar ongoing pregnancy rate. And the HRT with suppression decreases the cycle cancellation rates, and HRT without suppression is more patient-friendly and has similar clinical pregnancy rate and miscarriage rate as seen with the Cochrane database in 2020. Progesterone administration. The use and dosage and the duration of progesterone administration are important consideration points in preparing and synchronizing the endometrium to achieve the proper window of implantation for the best possible productive outcome. How we administer progesterone? We can use vaginal progesterone with the first past uterine effect. We can use intramuscular progesterone, subcutaneous, oral, or rectal, or combination. The dosage is variable. Variable doses has been suggested in literature according to the 100 milligram suppository, 90 to 180 bioadhesive gel, known, and we can use 600 milligram vaginal capsules. We can use 50 milligram intramuscular, or more commonly 400 to 800 vaginal ovule. Plus 50 to 100 milligram intramuscular, or 400 to 800 milligram vaginal ovule plus 25 milligram subcutaneous. But we should notice that the subcutaneous has a short half-life time. So if you use subcutaneous and you need good serum level, so you should use twice daily at least. Progesterone level rather than the dosage, individualized. Progesterone administration, higher biochemical loss and miscarriage rate with vaginal only route, higher live birth rate with intramuscular or vaginal plus intramuscular, comparable ongoing pregnancy rate between vaginal versus vaginal plus intramuscular. Progesterone administration, duration of progesterone administration before frozen embryo transfer. Few randomized control trials have addressed the duration of progesterone exposure before frozen embryo transfer, whether cleavage stage embryos or blastocysts. Limited evidence suggests transfer of day 3 embryos on the 3rd or 4th day of progesterone administration, whereas day 5 or 6 blastocysts should be transferred on the 5th or 6th days of progesterone administration. A recent retrospective study suggested that delaying the transfer of day 6 vitrified blastocysts to the 7th day of progesterone administration yielded higher live birth rate. Progesterone administration, serum progesterone level, Individualized medicine approach in HRT, frozen embryo transfer, the serum progesterone level shows marked variations between individuals receiving progesterone in the same dose and through the same route. And this can be explained by the difference in the drug pharmacokinetics altered by the differences in age, BMI, associated medical condition, etc. Progesterone administration, multiple studies have shown that better outcome were achieved with progesterone level above the criterion threshold, starting from 8.75, and another very interesting research by Laparta et al. Points to 9.2 nanogram as the cutoff limit. The ceiling effect to high progesterone levels are associated with poor or poorer outcomes. Progesterone administration, no significant ceiling effect was reported by multiple researchers. And about the late proliferative serum estradiol level, no association between the proliferative serum estradiol levels in live birth rate and HRT frozen embryo transfer cycles. We can use cycle rescue. What we mean by cycle rescue, we can rescue the cycle, administration of added progesterone, usually parenteral, to elevate the B4 if we find it low. The initial levels about the rescue dose, it is too late, and we will have lower live birth rate. But more recently, comparable ongoing pregnancy rate and live birth rate, respectively, if we rescue the dose. This is the summary of the all methods that we can transfer, that we can prepare the endometrium. The fresh embryo transfer, as we know, this is a protocol, but we have another, the three protocols for preparation for frozen embryo transfer. If we use HRT, if we use true natural cycle, and if we use modified natural cycle, and lastly, if we use stimulated cycle with mild stimulation. An important issue is the thin endometrium that we can face after. Endometrial thickness of 7 millimeters is considered to be the cutoff limit below which the endometrium is defined as thin. Both clinical pregnancy rate, live birth rate decreases significantly with endometrium less than 7 millimeters, and 7 millimeters is also associated with poorer obstetric outcome and perinatal outcomes with a higher risk of preterm labor and low birth weight. What are the management options? Nowadays, the BRP or plasma-rich platelets is a raging issue. Definitely, there is no sufficient evidence, there is no sufficient even research or publication to support its use, but there is a raising issue, and in many aspects of medicine, it started to be used, and I think in the endometrium, it have its own results. It could be used for example, at day 10 and then 3 days after. We can also use granulocyte colony stimulating factor, and in the last issue, you have a lot of presentations and publications about it. And vasodilators at sildenafil, low dose aspirin, pelvic floor neuromuscular stimulation, estrogen modification for the duration, dose, route, and type. This is a very important summary in such publication about increased risk of maternal and neonatal complications, and it studied also comparison between the methods of preparation. And so if we see the stimulation versus HRT, we will find that the clinical pregnancy rate is increased in this meta-analysis, and the live birth rate change is uncertain, and miscarriage rate is not different between stimulated and HRT. Natural cycle versus HRT, cancellation rate actually is reduced by using HRT, and clinical pregnancy rate and live birth rate is uncertain. There is no difference between them. The GnRH agonist versus control, live birth rate are linked to be increased in such patients. The important complications that alarms the clinicians and led them to use another protocols rather than HRT are the maternal and obstetric outcome. Compared with natural cycle, HRT cycles have a higher risk of hypertensive disorders in pregnancy, postpartum hemorrhage, cesarean section, macrotomy, and small for gestational age in some debatable reports. Obstetric outcome, preterm delivery, very preterm delivery, and premature ovarian and prom. Dear colleagues and chairman, we will end by the very recent EFRI statements by our group. This is issued in August 2022 about the frozen embryo transfer. The fact number one, or the statement number one, that the HRT protocol has been the standard protocol for the preparation of endometrium for the transfer of vitrified wormed embryos, and the main advantage have been the easy scheduling and the convenience for both the doctor and the patient with good outcome. There has been a concern of increased early pregnancy rate and early pregnancy loss rate with HRT. However, recent modifications in the modalities and follow-up of resurface support have significantly eradicated this concern. Admittedly, there has been a non-stop improvement and optimization of the outcome of HRT cycles. The non-HRT protocols are more difficult in monitoring and timing, more costly as mild stimulation, and needs more evidence. Natural cycle, true natural cycle, and modified natural cycles are now reported to be superior to HRT regarding the live birth rate. However, the quality of the available evidence is low. Although HRT and the natural cycle are the most commonly used protocols, recent emerging evidence suggests that mild stimulation also may be an available option for frozen embryo transfer that could be considered. In HRT cycles, caution is warranted since recent evidence indicates an increased risk of hypertension and hypertensive disorders in pregnancy due to absence of corpus luteum. Because safety always comes first, natural or modified natural frozen embryo transfer are currently reported to be safer than HRT regarding maternal and fetal outcome. Well-designed randomized controlled trials comparing different protocols to prime the endometrium for frozen embryo transfer cycles are required and should be focused not only on live birth rate, but also on maternal, obstetrical, and neonatal outcome. And population-specific based studies are optimally needed. Thank you.
Thank you very much. Today we have a very nice, that last two presentation was very good about embryo transfer and how can we prepare, whether frozen is better from fresh cycle. And I think there will be a lot of question after the discussion. I will leave now Professor Yasser to Professor Yasser.
Much for Professor Dr. Ashraf Abu Ali for his wonderful presentation regarding to preparation of the endometrium and freezing, and we might have a discussion later on. So may I introduce my very, very close friend, and I don't know how to introduce him, but because he's a very nice guy and I like him very much because he's very simple and nice and very nice, wonderful communication. So it gives me a great pleasure to introduce my colleague in the American Association back in Saudi Arabia. It's Professor Dr. Hassan Abdul Jabbar. He's the president of the Arab Federation of Obstetric and Gynecology Society and professor of Obstetric and Gynecology, Faculty of Medicine, King Faisal University. He is going to address us regarding a very critical, important subject which is related to loss of fertility completely after malignancy. So the point is, are we going to do just medication which might end up by loss of fertility capability of the lady if she has a sort of malignancy while she's young, or we might have another options to preserve the fertility. Professor Dr. Hassan Abdel Gabbar is going to address us regarding to fertility preservation. Okay, Dr. Hassan, okay, would you start? Dr. Hassan, share screen.
Okay. Bismillah walhamdulillah wassalatu wassalamu ala rasulillah. Today we are going to talk about something called fertility preservation, but it's not the usual fertility preservation. It's something different. And at the end of my talk, you will realize that it's a unique type of preservation. For people who do not know me, I just put one slide here that I'm the president of Arab Federation of OBGYN Societies, and I'm one of the members of the American Association of Medical Education, and I'm the chairman of the Department of Obstetric Gynecology IVF in Irfan Hospital in Jeddah. They share me this small project. Dr. Huwaida Hashim was an embryologist. Dr. Haneen Abdel Jabbar, she's my daughter. She's a consultant IVF, OBGYN. Dr. Mahmoud Jihad, Dr. Hussein Sabban, Dr. Ghada Gura, and Dr. Nancy. I would like to thank the American Association for giving me the opportunity to present something maybe new for some people, and we will have benefit of a lot of things during my talk. So I said fertility preservation, and fertility preservation here is different, as I mentioned. And let me just introduce the subject. The subject is malignant disease. They usually have to have radiotherapy or chemotherapy in women, and that impairs their fertility by damaging their ovary and subsequently damaging the oocyte. So if they have the malignant disease and they have the radio or chemotherapy, maybe they will not have babies afterward, especially if they are young and they are looking for to have a family later in life. In the past, fertility preservation has been limited to freezing the embryos. Embryo is very easy to freeze. It's easier than oocyte to freeze. But this was how we preserve fertility. If somebody has an embryo, we freeze it, and after she takes the medications, we return it back to the uterus, hoping that they will be pregnant. This is now the new thing is freezing and fertilizing, which I know from my colleague in embryology, it's much harder and difficult than freezing an embryo. But this is now is standard, and we can do a lot of freezing of eggs. That's with the affording female patient with fertility preservation. Not all patients, by the way, not all patients can be elected to undergo oocyte retrieval and freezing. Oocyte preservation is a technique used to preserve women's oocytes and enable them to have a family and pregnancy later in date. Why do you do that? Why somebody want to postpone their first reason? For medical reason. If they have cancer and they have to be treated for the cancer, maybe the treatment, as we mentioned, would destroy their ovary and oocyte. In some countries, they do it for social reasons. somebody has a nice job and she doesn't want to get married now, and she doesn't want to get pregnant, and she wants to postpone the having family later in life. Or if she's preparing for her master degree or PhD, she doesn't want to get pregnant at that time. Maybe she doesn't want to get married as well. So she would go and say, please freeze my eggs for social reason. So these are the two important way of freezing eggs. What about frozen eggs? Frozen eggs has been stored for 14 to 20 years right now. And babies born from these frozen eggs had no increase in genetic defect, which is important, no congenital disabilities. Moreover, pregnancy from frozen egg is completely normal, without any complication after the egg freezing. So it will be, I'm telling you that freezing eggs, it's exactly like fresh eggs. They will give you a nice baby like this. Okay, freezing one or more unfertilized oocytes to save them for future is known as fertility preservation. It's a unique fertility preservation, oocyte cryopreservation. And this technique used for fertility preservation in patients, as we mentioned, with cancer who are receiving chemotherapy or radiotherapy. There are many studies, and this is very interesting. There are many studies comparing ultrasound transurethral oocyte retrieval with laparoscopic guided oocyte retrieval. And these two methods been used from 1987 in IVF, in a regular IVF. You don't want to do a laparoscopic guide oocyte, you can do transurethral oocyte retrieval. And very interesting, all what you have to do is to have a Foley's catheter, put it in the bladder, and you insert your needle, this needle, you insert it in the catheter, so it will not injure the urethra and goes up to the fundus of the bladder. And then you can have the ultrasound abdominally. You can have an ultrasound abdominally, but the needle will be transurethral going to the bladder. It will be like this. Huh? You might even you will rupture the bladder. You will injure the bladder, but it's okay. Bladder will heal very quickly. In trans-abdominal, it's different. You go through the abdomen with abdominal probe. And I will show you how we do it. This is again transurethral. You can see the urethra here. This is the vagina. This is the urethra. You putting your needle in the urethra to the bladder, to the ovary, and you try to suck or aspirate the follicles. What we will talk about today is trans-abdominal follicular aspiration for oocyte retrieval. When one or more ovaries could not be retrieved via the standard transvaginal aspiration, then we go trans-abdominally. And I'll show you here that transvaginal approach for oocyte retrieval and fertility preservation is not considered in patients who are single, unmarried women for some cultural reason. Because of virginity, for example, because of intact hymen membranes considered very important. So if I have a 16-year-old lady, girl, and she has cancer and she's going to receive chemo and radiotherapy, and she wants to preserve her ovary, you don't have to have a problem with her intact membrane, hymen membrane or virginity. You can go through the abdomen because they think that it has more complications. This is a probe. use to guide. We guide the needle through this. You put the ultrasound abdominally, you put the needle in the guide, and you will aspirate the fluid. This is how it looks. The needle is in the abdomen with the guide, the probe, and your monitor in front, and you can see the follicle, and you can see your needle going through the abdominal wall to the ovary to aspirate the follicles. So transabdominal or egg retrieval provide an alternative transvaginal in some cases that aid access to the ovary for oocyte retrieval is difficult. And we will see what is the objective of our project is to report and publish our experience, our limited experience of the oocyte cryopreservation in single unmarried virgin patients who unfortunately have cancer, and we will retrieve her oocyte through the abdomen using ultrasound aspiration. So it's mainly in a single woman, young patient. Of course, this it looks like an experimental where ethical approval has to be taken. Ethical approval are taken from the ABGH 001022021. We have explained the concept to the patient, and we obtain written consent for all patients participate in our study to describe after describing the nature. So we have a consent, we have approval, ethical approval. Very interesting that from January to February 21, we have 950, almost 1,000 cycles. All of them, they are, and the total number of oocyte retrieved from the 950 was 10,325. Only 10 patients were eligible on the following inclusion and exclusion. What is the unmarried woman version? Patient diagnosed with cancer require chemo or radiotherapy, or patient require chemotherapy for bone marrow transplantation, like a patient with sickle cell disease. We exclude all married women because you can go through the vagina. If transvaginal oocyte pickup is accessible and possible, then we exclude. So mainly we have single unmarried women, and I show you now the number of patients we have. We have 10 cases. We started them in control hyperstimulation with the antagonist protocol. And the patient started with the FSH on day 3, and antagonist will started on day 6. I'll show you a diagram how we do that. This is called the GnRH antagonist protocol, multiple dose, not a single dose. There is single dose and there's multiple dose. So we start from day 2, 3 with the stimulation, and then day 6 we give the antagonist and monitor the ultrasound abdominally and E2 until we found that we have enough follicles. Then we will give trigger with the HCG, and we do the OBU about 34 to 36 after the HCG. Very nice. Monitoring of the follicular development is only by transabdominal ultrasound. So we can easily monitor the ovary transabdominally if the patient have full bladder. And we do serum estradiol level. This is the only two monitoring we doing. When multiple follicle detected, then we will give human chorionic gonadotropin to trigger ovulation. We do the transabdominal oocyte retrieval. Usually it's in the OR under general anesthesia in a supine position, and the patient is clean and drop the regular way of normal fashion for procedure, abdominal procedure. We use the ICSI abdominal probe, that the one I show you, with the guide for the needle, and always visualized an OBU needle was introduced into the guide and then into the abdomen. So you pass the abdominal wall and then you go to the ovary. Follicular aspiration was performed under optimal pressure, 100 to 200. We do flushing. Normally, sometimes people, they don't do flushing of the ovary. They just aspirate flushing because we want to have increase the number of oocytes. For each aspirate, inclusion was checked by the embryologist in the IVF lab for the presence of oocyte. So we try to be very slow, very meticulous, and try to aspirate as much as possible of all the follicles. And then after the needle was removed and the abdomen was clean, and patients usually transfer to recovery room. In the recovery room, you have to observe for complication. It's not like the transvaginal. Once the patient is okay, she can go home. But here we maybe observe them for 2-3 hours just to make sure that they are okay from the post transabdominal ovum retrieval. We'll talk about it in a minute. Oocyte verification and thawing transfer to cleavage media, and they will make sure that the oocyte is mature and good enough before. Let's see our result. We have 10 patients. They are single. They have 10 patients. They are single, nulliparous, or were eligible. They have a diagnosis of cancer. They are planned to have either chemo or radiotherapy. And their age is from 16 years to 35. The mean is about 23.1 plus or minus 6.2. So we have young generation, young patients who have cancer and they want to preserve their fertility. Look at the result of the malignancy that we had. We have 2 patients with ovarian cancer. We have 4 patients with breast cancer. We have 1 Hodgkin lymphoma. We have 1 osteosarcoma and 2 sickle cell anemia. The 2 sickle cell anemia, they have severe anemia that necessitate bone marrow transplantation, and they have to take chemotherapy to suppress their bone marrow before they do the bone marrow transplant. We retrieved about 148 oocytes, only 112 mature enough to be stored and freezed. The mean number per patient was 11.2 plus or minus 8. So about each patient will have 11 eggs retrieved. The body mass index is very small. The mean is 1.9 plus or minus 1.8. The weight of patient is between 52 and 60. They are clean patients, so it's usually a procedure. The operative time is ranged from 45 minutes to 120. The mean is about 68.9 plus or minus 2.8.
The time is about an hour, and the BMI is about 52 to 60. The weight is about 52 to 60, and the mean body mass index is 21.9. None of these patients had complication of postpartum procedure, post-over procedure. And here, I don't want you to go through all this, but I'm sure you wanted to know the average age. The average age of our patient is about 23 years old. Their BMI is about 21.9. Mature egg about 11.2 from per patient. Let's say the first successful test tube baby, I don't know, maybe I remember that, but I don't know if you remember. Some people maybe remember. In 1978, when John Brown, she had a baby by AR assisted reproduction by step 2 and Edwards. And the number after that pregnancy, the number of couples seeking treatment has increased dramatically, mainly because of improvement in patients' awareness and accessibility of assisted human reproduction and fertility treatment. We are, as Arab country, were not behind. In 1980-82, Egypt, Saudi Arabia, Jordan, all have very nice centers, and you know that there are a lot of centers now in Egypt, in Jordan, in Lebanon, Saudi Arabia, Gulf area. All they have a very good centers with good results. We mentioned that sperm freezing has been used for a long time. This is the first way of fertility preservation. It's easy to freeze the sperm. But the art of freezing and thawing an embryo has recently become very popular. And people now, they freeze all. There is a freeze all. When you have a patient with a lot of oocyte and you're worried about hyperstimulation, you freeze all and you give them 2 or 3 months, and then you do the embryo transfer. Egg freezing has become one of the new modalities used in IVF. Now we are using oocyte treatment, the oocyte cryopreservation. The technique are used for fertility preservation and in patients with cancer who have intended to receive chemotherapy or radiotherapy. This is just to remind you that we are talking about transabdominal oocyte retrieval. Transabdominal oocyte aspiration is a method of retrieving egg for IVF and women who are not candidate for vaginal retrieval. Who are not candidate for, not only a single mother, single unmarried patient, this is number 1. Number 2, patient who desire to maintain virginity, patient who was born without vagina, like Meyer-Rokitansky Osterhaus syndrome. Maybe she wanted to have her ovary, and then she will have a surrogate mother, or especially in European country. In patients who have their ovaries located outside the pelvis due to adhesion or cesareans or multiple surgery or so. This procedure is technically more challenging and it's more difficult than transvaginal oocyte aspiration. If you do transvaginal ultrasound, it's easy for you to learn how to do transvaginal oocyte aspiration. The learning curve is very, very short. Therefore, patient selection is critical. A successful procedure. So the procedure of transabdominal is more difficult. Similar to transvaginal oocyte aspiration, transabdominal oocyte retrieval usually performed under general anesthesia in a setting like an OR setting using abdominal ultrasound probe. I show you that. And a long needle is passed through the surface of the abdomen into the follicle. The fluid from the follicle is aspirated and scanned to check the presence of the eggs. Although severe post-ovum retrieval complication is rare, but you have to be aware of it, which is called intra-abdominal excessive bleeding. Your needle goes to a different area and starts bleeding, requiring hemostasis and sometimes requiring blood transfusion. Unfortunately, sometimes infection can occur like any other surgical procedure, and recurring of hospital admission are very rare. Why we saying that? Was just to a clinician to be aware of their occurrence, so you can make an accurate diagnosis and early intervention. It's very rare, but you have to keep it in mind. I put this slide tilted because I want to remind people that trans-abdominal approach is an alternative option that would increase the total number of oocytes retrieved with no statistical difference in the complication and pregnancy rate. Patients not do abdominally, please, you can learn how to do it abdominally. The next, in cases with difficulty, difficult transvaginal approach, patient with history of repeated cesarean and scarring, patient with a very high BMI, may be difficult to do ultrasound transvaginally. Or if ultrasound findings suggest that it's difficult, then transvaginal access. The access vaginally is very difficult. Maybe you can use the abdominal approach. The fear of freezing of oocyte has been done investigation in 2015. In the American Society of Reproductive Medicine approved it, and the American Obstetrician and Gynecology approved it in 2014. Canadian, I have to mention Canadian because I was trained in Canada. The Canadian Fertility Society adopted the procedure in 2015. So it's not something very old. It's a new methods to be used for reproduction. They demonstrate two important things. Number one, trans-abdominal ultrasound guided aspiration is possible, and it is safe and efficacious with no or rarely they have complication. This can be confirmed, especially now in young patients who are virgin and in women with malignant disease, who desire to retain their intact membrane for cultural reasons, and especially in our society. We have a lot of young patients who have cancer and they receive medication. This conclusion, I shouldn't give it only to the obstetrician, but I also should give it to medical oncologists and radiotherapists, because they are one who be the referral doctor to the IVF center for freezing the egg. I hope this is an important message I give you with a good conclusion, and I'm very thankful for you to being patient and listening to me. And if you have any question, I'm willing to answer. If we cannot get that because of the time, you can send it to me, and I will answer all your questions. And thank you very much for the American Association of Continuous Medical Education for their inviting me to be part of this one-day course of IVF. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Actually, this is, I think has an important message that patients who are young, especially in our society, and they have cancer, and they're planning to have babies, so you can retain their virginity, you can take their eggs, they can freeze it, treatment of her cancer completely, and then if she get married, she can get pregnant. And this is part of our job, is to help people to get pregnant. And I think adopting this abdominal approach, maybe it will be possible, maybe it will be important in our society. Maybe in Western society, it doesn't matter. But I think fertility preservation in this aspect is important. And I have seen a lot of questions about fertility preservation. If you allow me, Yasser, just to answer some of those questions.
Sure.
One of the audience says, what is preservation, fertility preservation? We do fertility preservation for cancer patients, and usually we use the normal protocol for having them going for IVF is exactly the same. And I mentioned that we use antagonist protocol because we want to control hyperstimulation better. But you can use long protocol, you can use short protocol, you can use antagonist protocol. And in the past, we used to take the oocyte, and if the lady is married, we fertilize the egg, and then we preserve the embryos rather than the oocyte. Now with the technology getting better, oocyte can be freeze. So even if this patient is not married, or if she's divorced, or you still can have her ovary preserved. I can tell you that in 2006, I said that ovarian preservation, ovarian freezing is possible. And people, they were saying it will be extremely difficult. And I actually wrote it in one of the newspapers in Saudi Arabia here. And hoping that this ovaries, one day it will be utilized for future pregnancy. And this is exactly what's happening now. A lot of people, even if they are not married, even if they're reaching the age of 35 or 36 or 40, and they wanted to preserve their ovary for social reason, there is a lot of people who get stimulated, have their ovaries, have their oocyte taken out and freezed, and they are going to use it in the future. So freezing eggs is another modality of fertility preservation.
That's fine, Dr. Abdul Gabbar. I can see here one of the questions which had been raised. It's what if we have cancer ovary?
Yeah, we had two patients with cancer ovary. One of them has unilateral disease which destroy completely her ovary, too huge, but we managed to stimulate her and get the oocyte from the other ovary. And the other patient, she had ovarian oophorectomy by a general gynecology and turned to be borderline malignant disease. And then the next, when they wanted to do more further investigation for her, they found that it's not borderline, actually it's cancer ovary. But the other ovary was completely normal. So we retrieved the oocyte from the other ovary. So it's possible if you have a unilateral disease.
That's fine. May I add just one thing? Because unlikely to have mucinous and serous cancer ovary at young age, the age of that between 40, 45 up to 60. So it's usually germ cell tumor, and the only management of the germ cell tumor, it's excision and follow up. That's why you might excise and allow the patient to become pregnant. That's why if you have a sort of malignancy, the other ovary will do good, and we can stimulate it and aspirate it and do whatever we're going to do. I agree with you completely. That's right, 100%.
Yeah, the other thing, we are not talking about only cancer ovary, but we are talking about a lot of lymphoma, leukemias, sarcomas, extra-abdominal tumors sometimes. So your ovary is completely normal. So you just stimulate it, have the oocyte, freeze it, and use it for future. Well, the thing, why I'm presenting this in American Association in Egypt, in Arab country, because I think it's important for us as a Muslim doctors to, socially, that young 16 years old, you don't want her to lose her virginity, to have cancer, and you can at least preserve her ovary or preserve her oocytes and preserve her virginity and treat her cancer.
That's good. So here in Egypt, we try to do into two ways, bad way and good way. The bad way is transvaginally and give a consent and give her a letter that we have done that. But what we try to do now, it's transrectal, where we put that on the anus. So it's not introduction in the rectum itself. So if you put the tip of the ultrasound on the anus and push it a little bit, it will appear. However, I don't know, after cleaning and everything, I don't know what will be the effect of that on the sphincter of the anus on long-term effect. Because just putting in the anus, it will be crystal clear and it will be very close. And you can go through the anus and the lower part of the rectum and to collect the ovum. We have done that many times, but I don't know what will happen afterwards because no long-term effect.
Like the transurethral, the one I talked about, it used to be the method for IVF in 1980s, 78 and 80s. I remember when I was in training, they used to do this, the needle will go through the catheter, the Foley's catheter, and with abdominal probe. So you really do not touch the vagina. Again, it has the same complication and problem with transabdominal, but maybe it will be easier accessible of the needle to the ovary itself when you put it through the bladder. And there is in the literature, there is so many literatures comparing transurethral with laparoscopic. I remember also we used to do laparoscopic ovarian retrieval, and it was more hectic than transvaginal. We used to do it as an emergency because we didn't have antagonists at that time or agonists. So whenever there is a late surge, we book the patient at 3 o'clock in the morning to have a laparoscopy and to have a oocyte retrieval. Time changing and technical things coming better, and I think making doctors more relaxed than before.
Thank you very much. It's a wonderful presentation and wonderful idea. You raised a very important issue because I haven't got the chance to do it trans-abdominally before that. But I will ask if it's possible to get the probe, the abdominal one, and the machine through which you can go through the needle. I will try to do that because I haven't. I'm waiting for you just to join us for trans-abdominal collection, just to have an experience from you. It will be good in Egypt.
I will.
Thank you very much. Thank you very much. And you can go for Salat al-Maghrib. I'm waiting for you afterwards. And now we are going to present Professor Dr. Hassan Morsi from England. Professor Dr. Hassan Morsi is a fellow of the Royal College of Obstetricians and Gynecologists and consultant of obstetric and gynecology and endometriosis surgery in England. He is as well a professor of obstetric and gynecology back in Chelsea University. However, he's in England now over the last 15 years. He's professional in endoscopic surgery And the subspecialty is endoscopy in extensive cases of endometriosis. He is going to address us regarding to a very critical subject. It's laparoscopic surgical treatment of endometriosis associated infertility, perinatal, ovarian, and deep endometriosis. Let's go for the presentation.
صباح الخير. أنا اسمي دكتور حسن مرسي، أستاذ مساعد أمراض النساء والتوليد كلية الطب جامعة عين شمس, and the founder and director of the BSGE accredited endometriosis center in Dudley in England. I've recently received certification in neuropelviology level 1, which is the very new science dealing with understanding pelvic pain and its relationship to pelvic nerves. And الحقيقة I've dedicated the last 20 years of my life to learn and teach techniques for laparoscopic surgical management of endometriosis. And I'm very, very thankful to my dear friend and colleague, Professor Yasser Abu Talib, for giving me this wonderful opportunity. And also to the American Association Gynecological Hub for allowing me to talk about this very interesting topic. This is the center where I work in England, and this is the certification certificate from the BSGE for the accredited endometriosis center and the certificate for level 1 in neuropelviology. Talking about endometriosis surgery in an infertility meeting certainly seems like a mission impossible or a very, very difficult task. But I will do my best to convince my mentors, teachers, and colleagues that there are definite benefits when it comes to endometriosis surgery within the management of infertility. If we talk about endometriosis, we all know that there's 3 kinds of endometriosis, namely superficial endometriosis, endometriomas on the ovaries, or deep endometriosis that can infiltrate into the vagina, ureters, bowels, and sometimes the nerves. In day-to-day practice, most endometriosis patients will present with either pain or infertility or both. The dilemma starts to happen when it is both, and fertility will always be the priority if patients present with pain and fertility issues. I will focus during my talk on deep infiltrating endometriosis, especially of the bowel, because the bowel is the most common site for deep infiltrating endometriosis, and it usually presents with a single nodule invading into the muscularis layer of the rectum or the rectosigmoid, and it is found in 5 to 12% of endometriosis cases, and the rectum and the sigmoid are the most common sites affected with deep endometriosis within the gastrointestinal areas. We have to remember associations of deep infiltrating endometriosis of the bowel. They're rarely isolated, and they're usually accompanied with adenomyosis in 70% of the cases, endometriomas in nearly 50% of the cases, and they usually are associated with retrocervical lesions in 85%, or lesions of the torus uterinus area, which is the area between the back of the cervix and the front of the bowel. So you have a patient presenting to you in the clinic, a young patient who's recently come off the contraceptive pill or recently got married, and she wishes to get pregnant, and she had some investigations which revealed deep endometriosis. What would you do? This is a very common scenario in day-to-day practice. So you have 2 options. You can either advise her to have IVF, but you have to think, is she really infertile? Or you can offer surgery. Now, remember that most of those patients will have dyspareunia, so they cannot get pregnant without having intercourse, because intercourse is extremely painful, especially with deep endometriosis. And you have to also remember that patients with deep endometriosis usually have large endometriomas, and they can have other important symptoms which we must bear in mind. For example, if they have dysuria, that means that the endometriosis has reached down into the pelvic nerves, particularly the splanchnic nerves, and that causes pain during passage of urine. bloating, which could be a sign of subocclusion within the bowel, or deep pain within the sciatic or sacral area. And very importantly, we must never forget loin pain. And unfortunately, some cases can have silent loss of kidney function if deep endometriosis of the ureter is not detected and managed appropriately. So the first question we have to ask ourselves, does deep endometriosis affect fertility? Yes, we know that because it can significantly impair fertility as seen in the study when colorectal resection was not done. The monthly fecundity rate was significantly lower compared to the group that had colorectal resection. And we know from the literature that the chance of natural conception with deep endometriosis is no more than 10%. So then you counsel the patient about going for IVF straight away. This was an interesting study done by Ballister in 2012, where they looked at a cohort, prospectively, a cohort of 75 patients with deep endometriosis of the colorectal area. All of them were having IVF, and none of them had surgery for deep endometriosis. And they looked at the success rate of IVF in those patients without surgery and with deep endometriosis. And they found that 43% of them conceived, and the cumulative pregnancy rate improved to 68% after 3 cycles. Another interesting study done by the group of Professor Horace Roman, which showed high post-operative fertility rates following surgical management of colorectal endometriosis, where they achieved 81% rate of pregnancy or conception, 59% of them were natural, and they calculated that the pregnancy probability increased with time, and it could reach as high as 87 or 86.8% by 4 years. And you can see on the right-hand side, the Kaplan-Meier curve shows that women who are advised to have a natural conception straight after surgery got pregnant a lot faster than those referred for ART, and there was a significant difference. Further evidence comparing IVF alone versus surgery followed by IVF, we can see here that there was significantly higher IVF pregnancy rates in the group that had surgery followed by IVF, with the odds ratio of getting pregnant 2.45-fold higher than the group that had IVF straight away. So this is more evidence that extensive laparoscopic excision of deep endometriosis can significantly improve IVF pregnancy rates in women with infertility-associated deep endometriosis. What about natural conception rates after deep endometriosis surgery without IVF? This study looked at the role of surgery in endometriosis-associated subfertility, and they found that natural conception after deep endometriosis surgery without any assisted reproductive techniques is only 24%. This is an improvement from the background chance of pregnancy in deep endometriosis, which is quoted at 8 to 10%. This is further evidence that first-line surgical therapy, as opposed to first-line IVF therapy, first-line surgical therapy followed by ART can achieve higher cumulative pregnancy rates after the 3rd cycle of 70% compared to ART alone. This was a retrospective matched cohort study looking at 110 women with colorectal endometriosis. Group 1 had surgery followed by IVF, and Group 2 had IVF only, and you can see that the cumulative live birth rate significantly improved in Group 1, with particularly good prognosis in women with good fertility factors, age less than 35, AMH higher than 2 nanograms per milliliter, and no adenomyosis. The authors concluded that first-line surgery may be a good option for women with colorectal endometriosis-associated infertility. What about patients who have repeated IVF failures with severe endometriosis? This was a retrospective study recruiting 78 women with stage 3 to 4 endometriosis. All of them had had failed IVF, and they found that 42% of them delivered and 9% had natural conception. And the women who delivered were more likely to be young, with a less likely diagnosis of reduced ovarian reserve and no adenomyosis. And they found that simultaneous self-injectomy also improved the delivery rates of 70% compared to 51% when self-injectomy was not performed. So the conclusion was that symptomatic women with severe endometriosis and repeated IVF failures could benefit from extensive laparoscopic excision of endometriosis when done by an experienced team, and that salpingectomy improves the delivery rates. Further evidence that surgery after repeated IVF ICSI failures in women with severe endometriosis achieves pregnancy rates of about 43 or 44% after a mean interval of 11 months, and multivariate analysis showed that women aged above 35 years with stage 2 endometriosis and who needed concomitant endometrioma surgery, that affected the probability of conception. Therefore, they concluded that women who have repeated IVF ICSI failures should be referred for surgery, as they have a reasonable post-operative pregnancy rate of about 44%, usually within the first year, especially if there's no concomitant or simultaneous endometrioma surgery. Deep endometriosis surgery, particularly the approach to a frozen pelvis, is a very, very important topic. And the approach to frozen pelvis requires a roadmap. You must stick to this roadmap and follow the principles of safe dissection at all times to achieve safe surgery. First step is a survey of the pelvis, identification of the distorted anatomy, and then you must teach yourself and learn how to approach the retroperitoneum, because the retroperitoneum is your friend. And once you identify the entry points into the retroperitoneum, which could be the round ligaments or at the pelvic brim after reflection of the physiological adhesions between the sigmoid colon and the lateral pelvic wall, first step should always be identification of the ureters, and you always start by identifying the left ureter and follow the spider web and try to maintain hemostasis as much as possible, allowing for mild bleeding at times. The aim is to identify the ureters at the pelvic brim, lateralize the ureters. If you can't identify the ureters, the best piece of advice is that you should go higher up, and the higher up you go, the easier it will be to identify the ureter crossing the bifurcation of the common iliac on the right side or over the common iliac vein on the left side. You have to be prepared to use traction and counter traction and avoid approaching the disease directly, and always start from normal tissue and work your way towards abnormal tissue. Remember that both pararectal spaces must be entered to maintain hemostasis all time. Develop the spaces and extend the dissection beyond the nodule into the healthy rectovaginal space. And the bowel is often associated with endometriosis, and that can only be assessed at the time of surgery. The first approach should be shaving, followed by disc excision if required. Multiple nodules are usually managed by segmental bowel resection. Following excision of all of the diseased areas, you should always finish off by undertaking a leak test to make sure that there is no holes in the rectum or the rectosigmoid. So what are the recommendations or the take-home messages in women with deep endometriosis surgery and infertility? These are the figures you should present to your patients. You should tell them that up to 81% will get pregnant. 59% of that will be a natural pregnancy versus 43 to 68% in the approach of IVF alone before surgery. The other benefit is that these patients will have pain, they will have significant pain. So the benefit of the primary approach of surgery is that you will improve the pregnancy rates in addition to removal of the deep endometriosis and improvement of the pain. However, this must be balanced against the risks of such surgery. These risks can be reduced when it is performed by an experienced endometriosis surgeon within a multidisciplinary team, because the complication rates can be within the range of 10%, and the most serious complications could be leakage from the bowel, which in the literature is reported as less than 2%, rectovaginal fistula 2.5 to 7%, and urethral fistula in 0 to 10%. So looking at the ESHRE guidelines on endometriosis published in February 2022, they acknowledge that there is limited evidence and there is no randomized controlled trials to address fertility outcomes of surgery. The main studies that are available mainly address pain, and therefore they're not applicable to fertility outcomes. And this presents a clinical dilemma, and an RCT is needed. So they recommended that each case should be discussed on a case by case, and the treatment should be tailored according to the patient's age, preferences, presence of pain, surgical history, previous failed treatments, the endometriosis fertility index, the ovarian reserve, and other fertility factors. And actually, the endometriosis fertility index could be used as a triaging tool, as it is a validated and tested score to identify women who would benefit from ART referral following surgery. The recommendation of the ESHRI guideline was that the decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient preferences, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. However, I have shown you ample evidence in the previous slides that within expert hands, reproductive outcomes can be improved significantly compared to the approach of primary IVF treatment without surgery. The question of lack of RCTs has been addressed by this group who designed the study called EFFORT study, which is comparing the impact of primary operation versus primary assisted reproductive technologies on fertility for women with deep infiltrating endometriosis. It is a multi-center power group randomized trial looking at rectosigmoid deep endometriosis in young women wishing to get pregnant and have been trying for at least 6 months. They will recruit 350 women in the age group 18 to 38, and they will randomize them on a one-to-one basis for primary surgery or primary IVF. And the primary outcome will be the cumulative pregnancy rate and the live birth rate in the first 18 months. And the surgical group will be advised to attempt pregnancy naturally or IVF according to the endometriosis fertility index. And I'm sure once the results of the study are out, it will answer the long living debate of whether to approach deep endometriosis surgery patients with infertility with either primary surgical approach or primary IVF approach. We will all await the outcomes of the study eagerly. We then talk about endometriomas. They're found in 17 to 44% of endometriosis patients. They can impair fertility either through anatomical distortion, through inflammation, through iron excessive levels, reactive oxygen series, or oxidative stress, and changes in the follicular fluid whereby there's increased inflammatory cytokines. Further research is needed in this area. We know that endometriosis do not respond well to medical therapy, and surgery can help, but it does reduce the ovarian reserve. So this is another clinical and contentious challenge in management of endometriosis. We know that the effect of endometriomas without surgery on ovarian reserve is actually unknown because there's conflicting evidence in the literature. We know that endometriomas can have a detrimental effect on ovarian reserve when comparing AMH levels with those of other benign cysts. This was looked at in a meta-analysis of 17 studies with 968 women with endometriomas versus 1,800 without endometriomas, and they found a significant reduction in the AMH levels compared to with endometriomas compared to other benign cysts and to patients with healthy ovaries. This is another study of 1,199 cycles in 240 women with mean endometriomas measuring 5 centimeters. And they found that ovarian endometriomas do not impair spontaneous ovulation, and the impact on fertility of surgical excision of ovarian endometriomas should be further investigated. And this study, they achieved a spontaneous conception rate of about 43%, with the affected ovary ovulating in 50% of cases, and that was still true for endometriomas above 4 and above 6 centimeters in size. Another prospective study looked at 78 bilateral and 157 unilateral endometriomas, and they found that unilateral ovarian endometriomas do not have a significant effect on AMH levels. However, the ovarian reserve was significantly reduced when you have bilateral endometriomas. Endometriomas less than 3 centimeters in diameter do not have a damaging effect on ovarian reserve and ICSI cycles. What about surgery versus conservative management of endometriomas in subfertile women? The evidence so far from this review article shows that the available evidence is of very low quality, with no difference in the odds ratio of live birth rate between women who had surgery for endometrioma before IVF compared to conservative management. And therefore, they recommended that conservative option should be the preferred option if the only indication is subfertility. In other words, if there is pain, then surgical approach would be recommended. So, the current evidence does not support postponement of infertility treatment in favor of surgery, except in cases with severe pain, or if you have large complex adnexal masses, or to improve accessibility to follicles, or if the patient has severe pain or severe symptoms. We have to remember that endometrioma surgery can reduce the ovarian reserve and therefore reduce ovarian response to controlled ovarian stimulation. However, endometrial receptivity, aneuploidy rates, and fertility outcomes are similar to healthy controls. And therefore, surgery for ovarian endometrioma provides no benefit in ART treatment. However, it is indicated if there is pain or if there's any concern about the appearance or the size of the cysts. And we have to remember that endometriomas are rarely isolated, and they're usually associated with other forms of pelvic endometriosis. They're only isolated in 15% of cases. So what should you do when you're faced with a patient with endometrioma? You have to ask yourself, is surgery before ART necessary? What are the pros of that approach? These patients will usually have pain and progressive symptoms with endometriomas. Endometriomas are rarely isolated. They're a feature of pelvic endometriosis, especially in the bowel. If you're concerned about malignancy, then the only way is the surgical approach. You would have to consider surgery if there's a large cyst or to improve accessibility of the follicles. And we know that stripping or cystectomy has been shown to reduce the risk of recurrence of endometriomas and improve pain symptoms and improve endometriosis-associated symptoms. But it has to be done by an expert surgeon in endometriosis and fertility, and you have to give consideration to cryopreservation or oocyte freezing prior to the procedure, especially in recurrent cases. What are the disadvantages of the surgical approach for endometriomas? We've just seen that it does not improve the outcomes. It can affect ovarian reserve, especially in bilateral cases or recurrent cases. It does increase the risks of the surgery, and there's increased costs, and it increases time for fertility reasons, so it delays the occurrence of pregnancy. And we have to remember that normal ovarian tissue can be removed, and there is an effect of the surgery and the bipolar diathermy on the blood supply of the ovary or surgery-associated inflammation. All of these things can impact ovarian function. The ICSI guidelines has answered that question, showing that there's a weak recommendation that clinicians may consider operative laparoscopy for treatment of endometrioma-associated infertility, as it may increase the chance of natural pregnancy, although no data from comparative studies exist. And it is not recommended to routinely perform surgery for ovarian endometriomas before ART to improve live birth rates, as the evidence shows no benefit and surgery is likely to impact the ovarian reserve. It is only indicated if there's endometriosis-associated pain or to improve accessibility of the follicles, and this was a good practice point. This video shows the concept of endometrioma stripping, and you can see here that in this case there's huge endometriomas, a very massive endometrioma on the right side and a smaller one on the left side, and the typical appearance of a frozen pelvis. This goes to show that endometriomas are rarely isolated, and I struggle to see how the follicles can be accessed through an IVF approach, primarily in such a distorted pelvis with significant distortion of pelvic anatomy. So the steps always start the same way. You have to spend some time to dissect the structures, expose the pelvis, improve visibility, and identify the anatomy. Once the endometrioma is drained, then you release it off the pelvic sidewall with blunt dissection, as you've just seen. And this often leads to the site of invagination to create the pseudocyst of the endometrioma. Meticulous technique is needed to identify the correct plane. And we often use agents like dilute vasopressin to identify the plane between the normal ovarian cortex and the endometrioma capsule. to minimize bleeding, but also to help identify the correct plane and minimize the inadvertent damage of the healthy ovarian tissue. You have to use bipolar diathermy very carefully, and it's preferable to use spot diathermy and use the stripping technique, as you can see here in the video, to remove the capsule of the endometrioma while trying to preserve the healthy ovarian tissue. It is often a time-consuming process, particularly with bilateral and large endometriomas, as you have to do that at the beginning of surgery to improve the access and visibility to the rest of the pelvis. It has to be done in a step-by-step manner, paying attention to careful hemostasis and trying to preserve as much of the healthy ovarian tissue as possible with minimal use of diathermy if possible. And then you continue to work your way medially until you get to the hilum. And this is the area where there's usually the maximum blood supply to the ovary, and every attempt should be made to preserve this area to reduce any compromise of the ovarian blood flow. Further stripping is achieved, and it's a combination of traction, counter traction, and using cold scissors and minimal use of bipolar diathermy when indicated. As you can see here, the bleeding is minimal because the use of vasopressin is extremely useful to identify the plane and ease dissection between the two layers, which can sometimes be quite difficult to identify, especially in patients who receive Zoladex or GnRH therapy. That makes identification of the endometrioma capsule extremely difficult. Using further vasopressin to release the last parts of the endometrioma capsule from the area of the ovarian hilum. And with prior notification to the anesthetist that you're using vasopressin so that they're aware of any cardiovascular side effects at the time of use. And then in some areas you can use laser, CO2 laser, and this helps to minimize the damage of the ovarian follicles, particularly at the area of the hilum and the rich blood supply. It also helps in hemostasis with a very low tissue penetration, which helps to preserve the ovarian cortex and minimize damage to healthy ovarian tissue. Once this is completed, you can see here the final view. All of the deep endometriosis, which wasn't shown in this video, has been excised. The anatomy has been restored, and you can see there's a good portion of the right ovary still left inside. And this is obviously a very, very good result for this patient. Simply accessing the follicles for egg retrieval without correction of this anatomy and without surgery can cause a pelvic abscess. It can injure surrounding organs, and you have no histological diagnosis to confirm this is actually an endometrioma, plus the fact that the deep endometriosis, which is often associated with bilateral endometriomas, is still left behind. And therefore, surgery to me seems like a very sensible option to improve spontaneous and assisted pregnancy rates, but also at the same time to remove the deep endometriosis and improve this patient's symptoms. Because if we just approach the fertility side of things with an IVF-only approach or primary approach of IVF, then yes, we will achieve a pregnancy. However, the patient will still have significant symptoms and pain affecting the quality of her life. Finally, we finish off with superficial endometriosis, and the evidence from the ESHRI guidelines is clear. Operative laparoscopy should be offered as a treatment option for endometriosis associated infertility in stage 1, stage 2 endometriosis, as it almost doubles and improves the ongoing pregnancy rates. These are videos showing excision of superficial endometriosis, and you can see here that Identification of the lesions shows superficial endometriosis on the right pelvic wall in the top left-hand screen. It starts by identification of the ureter at the pelvic brim and then excising the area after lateralizing the ureter. The same in this photo here, video, which shows deep endometriosis in the pouch of Douglas, and this patient will have peritoneectomy of the pouch of Douglas, removing all of those superficial deposits. The same on this video here, identification of the right ureter and excision of the pelvic peritoneum with a wide resection margin to try and remove as much of the endometriosis as possible. Here you can see there's bilateral uterosacral involvement, and often this area needs to be completely excised, which is called the butterfly area of the posterior pelvis. And we know that the posterior pelvis or the posterior compartment is the most commonly affected site with endometriosis. Endometrial surgery is very repetitive. It is a sequence of identified steps that you keep repeating over and over again. And this gives you a very safe approach with identification of the important structures. And once you enter the retroperitoneum and identify both ureters, the surgery becomes very, very easy and very, very safe. You have to pay attention to the hot blade of the harmonic and keep it as far as possible from the ureter, avoiding touching any of the bowel or the ureter with the hot blade of the harmonic. The use of a rectal probe, which you can see here, is vital to endometriosis surgery because it helps identification of the borders of the rectum. This is the butterfly area completely excised here, as shown earlier. You have to enter in the pararectal fossa on both sides and excise all of the areas of endometriosis from around the rectum and from around the posterior vagina. And you can see here, this area has been completely excised, both pelvic side walls. And here, the peritoneum with the endometriosis is being peeled off the surface of the rectum and off the pouch of Douglas with the rectal probe in situ here, which helps greatly in identification of the borders of the rectum and allows the surgery to proceed safely. A combination of traction and counter-traction and blunt dissection to release the abnormal peritoneum off the pouch of Douglas and the surface of the rectum. Remember that once you enter the peritoneal reflection at the back, there is no peritoneal covering below the peritoneal reflection at the back, and therefore you're straight onto the muscle layer of the rectum below the peritoneal reflection. You can see here excision of the entire pouch of Douglas peritoneum and both pelvic walls, and this is the final step of release of the abnormal tissue, and this is the end result of excision of the entire area from the back of the pelvis. I finish off with the take-home message that surgery has to be tailored. You have to be radical towards the disease, conservative towards the function. You have to respect the patient's wishes, and this is fertility preserving surgery, so we have to be very, very careful and meticulous with ovarian blood supply and tubal function.
Professor Hassan Morsi, hi, how are you doing? Okay, do you hear me? Can you hear me well? Okay, unmute, please. Unmute. Okay. Share. Share, unmute. Okay, Hassan, do you hear me?
I can hear you.
Share, try to
unmute Dr. Hassan.
Yes. Please unmute Hassan. دكتور حسن مرسي كان معانا حالا دلوقتي في العربية Dr. Hassan Morsi was in theater maybe half an hour ago because of an emergency case with miscarriage and dropping of her hemoglobin. Then I asked him if it's possible to join us to ask him some question regarding to his presentation. So I saw him. Yeah, yes, that's good. Okay, welcome abroad.
Thank you.
Okay, Hassan, how are you? Oh, missing you very much back in Egypt. I remember last days when we used to work together. It was wonderful days, and hope to see you soon in Egypt anyway. Thank you very much.
Thank you very much for inviting Professor Yasser. It's a great honor to be here. Thank you very much.
Okay, so it's wonderful, to be honest, to be a founder for new techniques and to do, because I used to follow your operative intervention. It's wonderful, wonderful, wonderful. But I'm dead sure that not everyone can do what you are doing. You are highly expert, and it's very good. The point is, if you have an endometrioma, or if you have a deep endometriosis, and you said that effort study is still going on. From your prospects, what do you prefer to do? Are you going to ask them to go straight away for IVF, or would you prefer to have operative intervention because it might increase the success rate of IVF?
That question is mainly about shared decision-making with the patient. So it depends on the patient's primary symptom and the patient's objective. If there is asymptomatic endometriosis, then surgery is not an option, unless there is compromise of the bowel or the ureters. The only two absolute indications for endometriosis surgery is hydroureter or subocclusion of the bowel. Otherwise, surgery for endometriosis is purely based on the patient's wishes, and it is a shared decision-making process. If the primary aim is to get pregnant, then we have to evaluate those patients as we would with any other infertility patient by assessing sperm function, tubal function, and then if there's other factors causing infertility, then according to the ICSI guideline, we would recommend assisted reproductive technology. However, you have to remember that most of those patients will have pain. They will have pain.
Yes.
So, and if a patient has deep dyspareunia, then she won't be able to have intercourse.
I agree with you completely. But
if she has bloating, painful bowel movements every month, passage of blood through the rectum every month with her periods, significant bloating, all of these symptoms, these are very easy symptoms to recognize by simple history taking.
That's fine. So I observed from your presentation as well something which might be strange a little bit for me, and I don't know if you agree with me or not, and Dr. Abdul Gabbar as well. So you said that there is a study that proved that just unilateral cystectomy, endometrioma cystectomy, has no effect on AMH or the antral follicular count. So does it mean that if you have just unilateral cyst or unilateral endometrioma, you can go safely and remove it or not?
That study you're referring to, Professor Yasser, is actually describing unilateral endometriomas without surgery compared to bilateral endometriomas. So what they found is that patients who have unilateral endometriomas, the other ovary, if it's healthy, it tends to compensate. It tends to provide enough ovarian reserve to achieve fertility, and it doesn't have a significant effect on the AMH. However, if you have bilateral endometriomas, then that can cause a significant reduction in AMH. So, just like if you have, when you have two kidneys, if there's poor function in one kidney, the other kidney will compensate.
So you recommend removal of endometrioma if it's unilateral and cause a sort of pain. Meanwhile, if there is any pain, let her just in peace.
According to the size of the end, if it's less than 4 centimeters, then I would not recommend cystectomy. If it's above 4 centimeters and if it's associated with pain, then yes, I would recommend removing it.
But,
thank you very much.
Yes. If you leave the endometrioma, maybe if you leave the endometrioma, it will get bigger and then it will jeopardizing the ovarian tissue that there. I just wanna really, I don't know what to say, but I congratulate you for your very nice technique, very nice skills, and I think I always admire those people who do this type of surgery because it is time consuming. It needs a lot of effort. It needs a lot of concentration. You have to remove unhealthy and keep healthy. I remember one of my gynae oncologists, he said, the worst cases I do is the cases where we find that it is endometrioma, not cancer. Because if it's cancer, he wants to remove everything and deep bulk. But in endometriosis, you want to remove the unhealthy and you want to keep the healthy because for the future fertility. So I really admire you for your surgery. I'm sure you had a lot of training, and I'm sure people who are under your department, they will learn a lot from your technique and your skills. Thank you very much for the nice presentation.
Thank you very much. I really appreciate your feedback. And just to add to your comment, I completely agree. Endometriosis surgery is very demanding. It's very difficult because, as you said, we have to remove the unhealthy tissue from the healthy tissue, and we're dealing with young patients who have a benign condition. Yes. And they want to get pregnant, and unfortunately, it is high-risk surgery. So you try and do your best to be as meticulous and as safe as possible, and most importantly, preserve the function. And nowadays, there's a lot of talk about nerves, function of the nerves, and how to preserve pelvic nerves, because surgery in itself can cause a lot of damage to pelvic nerves, which we never used to realize in the past. But now there's a lot of talk about surgery-induced pelvic pain. For example, after hysterectomies, if you develop a neuroma on the uterosacral ligaments, this can cause persistent pain for patients. So it's another dimension that's developing, how to identify and preserve nerves during this difficult surgery.
Thank you very much. A personal question. As a surgeon, do you use medical treatment for treatment of endometriosis?
No.
I think, to be honest, the patients that are referred to the service, to the center, have already been
tried everything.
Because they come from they come from colleagues, so they've already tried the GnRH, they've already tried the contraceptive pill, they've already tried Mirena, and there's no point in trying the same stuff again. So they're coming for surgical treatment.
So it's considered a third degree or
how subspecialty will tell you in a small tunnel, and you have to go in that tunnel. You cannot go from that tunnel outside. And this is why I said subspecialty is usually, it's good for patients, but it's not good for the doctor, because the doctor will have a very narrow vision after a while. After 10, 15 years, we will not remember the medical treatment for the disease.
Anyway, thank you, Hassan, very much. And I'm waiting for you here in Egypt. So when are you going back to Egypt? Are you coming this year or not?
Inshallah, very soon. Inshallah, very soon.
Okay, please, once you are here, let me know, just to gather together and to have some fun. Please don't forget.
Thank you very much for the.
Have a nice night. Thank you very much. Thank you very much. Bye. Okay, let's go. Let's go through the
some questions, or
let's have a presentation from Sam Zaki and open the question afterwards. Okay. So may I introduce Professor Dr. Hussam Zaki. He's a unique person in the field of IVF and ICSI, and he's a member of the Royal College of Obstetrics and Gynecology back in the United Kingdom, and a member of European Fertility Society in the United States of America. And he is the founder and the owner of one of the biggest IVF center in Egypt. It's Ghanin Center. So he is going to address us regarding to a very critical subject. It's repeated pregnancy loss, more light into the black box. Let's have this presentation, please.
everybody. Let me introduce myself. I am Dr. Hussam Zaki, the Medical Scientific Director of Ghanaian Infertility Center. And what I would like to share with you today, an update on recurrent implantation failure. Shed more light in the black box of why do we need to define repeated implantation failures? أريح من حاجة لأن المفروض إن الشير سكرين full search. Hi, everybody. Let me introduce myself. I am Dr. Hussam Zaki, the Medical and Scientific Director of Ghanaian Fertility Center here in Cairo, Egypt. And what I would like to talk about today is an update on recurrent implantation failure. We need to shed more light into the black box. Why do we need to define repeated implantation failure? Because it has a prognostic information. Rather than saying to the patients, it's a bad luck, we have to counsel them according to the latest scientific research available. Because repeated implantation failure should prompt further testing to unreveal the causes of endometrial, embryonic, and maternal causes. I know that we already screen for polyps, fibroids, sometimes for aneuploidy, but we don't give our patient full report about what is in there that caused their failure. Again, that would prompt that we be able to compare between research findings that we find. Now, if I would like to ask what is the most common prevalent cause for repeated implantation failure, it is with no doubt, it is aneuploidy. And what I would like to share today, latest researches that has been published in Fertility Sterility, which actually is a pivotal information to share with our patient. This is a non-selective study carried out in a center in New Jersey in the United States. And what they have done a very interesting way, they have taken biopsies from 414 embryos and they returned them back single embryo transfer, and they did not test, they did not reveal the result unless after the pregnancy test. And they have found that they have transferred back 312 euploidy embryos. What they have found, that after transferring these euploidy embryos, 82% have implanted, while 73% have carried to the gestational sacs with 65% live birth. That would give us 18 to 27% implantation failure. While if they transferred back aneuploidy embryos, which has happened in 102 cases, they have 40% that have implanted, yet only 24% have produced gestational sacs and 0% live births. And there was 24% clinical loss, which give us an implantation failure anything between 60 to 76%. That has been taken further to redefine what is really implantation failure according to the euploidy or the ploidy status of the embryos. And with the different researches from 2012 until 2020, we have found that it is always consistent that aneuploidy rate increases with maternal age. Whatever study you look at, you will find
finding an euploidy embryos is anything between 55% to 60%, and that's go down when the woman gets to the age of 37, again to the age of 40, 41, and beyond. So by this, if we return back blastocysts that have not been tested in the age of 35, we would need close to 8 embryos to define that this lady had repeated implantation failure. Of course, if you go to the age of 42, it's an endless number. And we, again, 24 is not really the good number of embryos. So we will always prefer to return back euploidy embryos. If we put back euploidy embryos, the average number is 3 embryos, so that we can define after this that this lady has a repeated implantation failure. But come on, let's go to the real world. These figures are in studies. So they have proper pre-cycle assessment with full endocrine, proper 3D, and everything else. So this is not the routine clinical practice. PGTA is quite an invasive procedure, and I would consider it with others that this is a surgery. And if it's not done properly, it will be harmful more than beneficial. Yet again, there is an age concern. Fertility potential is age limited. So for an aged female, how long before you can say, I've done everything possible, ma'am, so that we do not waste your time? Again, there are financial implications to what we advise our patients. So it is important to realize also that not all cycles have been done in the same IVF center. So that is real world. And some even claim that that by doing PGTA, you have maybe losing competent embryos by doing PGTA. But look into the results. This is the TIGS study in 2021, which have shown that if you have an euploidy embryo return back, your sustained pregnancy rate is 64%. But what is it if it's an euploidy embryo? You have not lost. You have not found any of the aneuploidy embryos have produced a viable pregnancy. Again, there is another study by Bertia, and that has defined that they've done 4,400 cases. They've returned back first attempt, 1 euploidy embryos, 60%, 69% have succeeded, 30% did not. And with those who have not, they've returned the second attempt, done nothing in the cycle except returning back another embryo. Again, 60% success rate with no implantation, and 40%. Again, for those, they've returned a third one. And what they have found? What they have found that the success of sex is increasing with recurrent euploidy transfer, reaching up to 95% success rate. That is really very encouraging. But the rate of recurrent implantation failure increases every single time the lady does not get pregnant. Yet the numbers were not significant, but it's shown clearly that there's a trend of increasing the rate. And with this, transferring back 3 successive euploidy embryos, we have a chance of success 95%. But others have shown in a randomized, multicentric clinical trial that morphology actually was better than doing euploidy embryos, which is known by the study of Monet, that he wanted to show the advantage of PGTA, yet the results came to the opposite side. But is this study a real conclusive final study? Let's look at it. There was 650 cases done PGTA with very sick platform, 9 genetic laboratories, 34 clinical sites, and well, they haven't shown any advantage of any advantage of transferring euploidy embryos back, not even finding better miscarriage rate, which was very strange because we know that the #1 cause of miscarriage is aneuploidy. So what were the drawbacks of this STAR trial? That in the PGTA arm, almost 13% of the cases had no euploidy embryos. So they were excluded from the study. Yet they should have been included because it has diagnosed that these cases has no euploidy embryos. The mosaic levels between different centers were very, very different, and which is a very odd thing. And again, going back to what I've said that trophoectodermal biopsy is a surgery, and if it's not done properly, might harm the embryo rather than assessing it. 85% of the contributing center are inexperienced, and they were taught how to do PGTA. So will we depend on such inexperienced centers to give our conclusion? The last thing what I would like to put here, that PGTA is not only the one answer to assess the embryo. They have selected either PGTA or morphology, while in practice we select the PGTA euploidy embryo that has the best morphology, and that was not considered. Let's go to real-time data, which we get it from the SART. So we're getting it from the HIFA of United Kingdom. And that has been looking into all cases that between 2016 and 2018. They have done over 190,000 cycles. Out from these, there was 2,464. And the conclusion of this study, strong evidence for the benefits of PGTA in terms of live birth. As you see here, the number of embryos were exactly the same in between ages, while those of non-PGTA cycles had increasing numbers, yet success rate was exponentially very high in the PGTA group versus the non-PGTA group. And in fact, we can see here that the drop in success rate not using PGTA, while it's a sustained high success rate across the board in between all ages, which actually I can simplify it that all of the embryos that we can see now, 8 of these embryos are type 1 morphology blastocysts. Which one are the euploidy and which one the aneuploidy? You cannot differentiate only by morphology. Yet the new coming of morphokinetics, which shows the cell division, and with cell division, we would know the rate of division of these cells and the pattern of division, and we can see by timings and recording these, adding up to the value of selecting the embryos according to their morphology, the euploidy status, ploidy status, and their morphokinetics. Now, so returning back to the cause of implantation failure, we have embryonic causes that we've just discussed. We have maternal causes and the syncrasy. Going back to the maternal causes, as a routine way of studying inflammatory structure, endometrial thickness, endometriosis, and unexplained. Let's go to the inflammatory factors. I'm talking here about there is no doubt multiple RCTs have shown that self-injectomy in cases of hydrosalpingo increases the success by twice, increasing success rate rather than not removing the hydrosalpinx. Chronic endometritis, no doubt that treating it would improve success rate, and the presence of clinical endometritis would have threefold decrease in the implantation rate. Structural factors, no doubt about submucous fibroids, endometrial polyps. I'm just enumerating here. Non-submucous, there was always a debate about it. Some would say it is affecting on the cytokines level. Others saying no, it's only a mechanical factor. Endometrial thickness is one of those factors that has been looked at, but we have to differentiate it between cases of fresh embryo transfer, which endometrial thickness have shown to be detrimental, while we haven't found that in frozen embryo transfer. I'm just trying to run here, not to lose anything. Now, what about poor endometrial thickness? This study has looked into thin endometrium defined by less than 6 millimeters versus normal endometrium, which is above 8 millimeters. And they have found increasing inflammation and lymphocyte staining, decreased estrogen receptor alpha, and increasing estrogen receptor beta signaling, with a decreased proliferation and angiogenesis. And these findings suggest a mechanism of inflammation which might cause the endometrium to reduce its response to estrogen, which we call estrogen resistance, that would generate later on progesterone resistance. And the presence of increased level of ER beta, estrogen receptor beta, and increased inflammation are very much found in those cases of endometriosis. So are we talking about adenomyosis that was apparent? And with the new research that we can take an endometrial biopsy and do BCL6 immunohistochemical staining, is a very sensitive marker if we use the H score of 1.4, meaning that we would stain, we'd examine under the microscope. There is what we call H scoring, and if the H scoring is above 1.4, having very good specificity and sensitivity. And this just to elaborate it. Now, how about immunological role in repeated implantation failure? Well, I have to say that pregnancy is a traditional model for immunology of implantation. And we found that dysfunction that might happen would lead to repeated implantation failure in the form of natural killer cells, which we have to define either peripheral or uterine, finding imbalance of Th1, Th2, the role of antibodies, and antiphospholipid syndrome. But we have to realize there are different types, which means different treatment, and definitely there is no role of an empirical treatment. This is just a raw model of traditional model. And I don't want you to just get by heart all these kind of cells that are involved. But look at these cells. Most of them are immunological cells, which definitely are there for a reason, and it would affect implantation. Just want to highlight in here the difference between peripheral NK cells, which has been found to have poor sensitivity and poor specificity, versus that of uterine natural killer cells, because uterine natural killer cells have different IFN gamma receptors, TNFR production, and TNF beta production, which affect remodeling of spinal arteries and prevent of embryonal infection. Invasion had an effect of the invasion of the trophoblast and interaction of MHSC between the paternal and maternal part, which leads to immunomodulation. And this study that was published in 2017 by Shen et al. Has found that excessive uterine natural killer cells in both cases of repeated miscarriage and repeated implantation failure in comparison to the controls. Th1, Th2, I don't want to go thoroughly behind it. T helper 1 is a pro-inflammatory cells that produce TNF alpha, IFN gamma, and if they're imbalanced with Th2, which is anti-inflammatory, that would lead to increase of failure of the embryos to implant. When it comes to autoantibodies, to abbreviate it and to get the conclusion, significance is really unclear. From what I've said, I just want to highlight in that IVF or ICSI is different. Back in 1992, where success rate were less than 10%, and we went to 2022 when success rate increased just by maybe 10 to 15%, while it's now in 2022 exceeding 60 to 70%. Repeated implantation failure has definitely causes. We have to look at them, define them, test for them, and treat them properly so we can get rid of this failure. Thank you very much.
Okay, so I think Dr. Hussam Zaki has a different school in management of XC cases. He used to do fully comprehensive investigation just to check the chromosomal status of all the embryos before implantation or before doing embryo transfer. And according to his results, he mentioned in his report that the incidence of pregnancy raised from 20 up to 66. Anyway, some of you might have a sort of objection. Some of you may agree with him. But again, I agree with Hussam Zaki is aneuploidy is very important for implantation, and aneuploidy unlikely to be implanted. But anyway, I think the point is, I agree with him completely that it's very effective. However, the cost of each embryo, one embryo, to do a fully comprehensive checking for the chromosomal defect might cost about 6,000 Egyptian pound per embryo, provided that we are going to check 5 or 6 embryos. So it means that just to check the chromosomal status of the embryos might cost about 30 to 40,000 pounds. Adding to that the cost of the IVF cycle, so it means that it approaches 100,000 pounds. But anyway, it's good if you have the chance to reduce this cost, to do chromosomal study and to reduce this cost instead of being 6,000 to 1,000, I think that would be good. What's about your opinion, Dr. Abdul Gabbar?
This is, of course, maybe in his center and in his hand, yes. But definitely the success rate all over the world without BGDs and BGS, so I think it is less than that. I do agree that if we have a good study or a good center to study the chromosomal genes for all the embryos with a reasonable price, definitely that will increase the success rate. But it was a very nice presentation, and it shows you how we actually do something sometimes blindly. We do it blindly, thinking that, oh, I have a very nice blastocyst, and maybe this nice blastocyst is not nice. And by looking at it, you said this is beautiful, and then they tend to be abnormal from a genetic point of view. Nice, very nice, interesting. Yes.
You know, Dr. Gabbar, last sterility just this month, yeah. Under publication of an article discussing the effect of transferring of looking not good embryo. If we transfer it and pregnancy occurs, does it have any effect on that pregnancy? And the conclusion was that no, not at all. Yes, not at all. So if you transfer grade 2 or grade 3 embryos and she become pregnant, pregnancy will be the same like if you transfer grade 1. So no difference at all. Once pregnancy occur, thank you, pregnancy occur. But anyway, it's good anyway. So thank you, Dr. Hussam, very much. I don't think that Hussam Zaki is there, but do you know, here in Egypt, we are 2 schools. Hussam has his own school, which is highly respected, with the high success rate in his center, and he has his own vision for that. Thank you very much for his presentation and for sharing us. And we have two left presentation. So let's have, I think I have presentation and Professor Dr. Abu Bakr Nashar. So let's go for Abu Bakr Nashar. And regarding to me, because of squeezing of time, so I will present the conclusion. So let me just to present the conclusion, because I was expecting to have a presentation of evidence-based in infertility. And instead of going to whole presentation, I will go through the conclusion. And this is just data collection from all the evidence over the last 10 years. Use and don't use, use and don't use. And instead of spending about 30 minutes for this presentation, so I will go straight away for the conclusion, which will be just direct points for what use and what not use. And afterwards, this is the old things and the classic things. Afterwards, we will have Abu Bakr Nashar presentation, which is the new items related to infertility in last issue. Okay, so let's go straight away for my conclusion. It will be just 1 minute or 2 minutes, and afterwards will be Abu Bakr Nashar, and we'll finish quickly to have discussion, me and Dr. Abdul Gabbar, for try to answer many questions of you. I think this will be so خليها تاني اطلب من presentation actually just actually تبدأ يبقى هي presentation. Conclusion. Conclusion is that. That's fine. So let's start my presentation by conclusion straight away to short the time, because I know we spent about 8 hours discussing and overloading you with the information. From the evidence, we can conclude that if you have an overweight lady coming to you with a body mass index more than 30, don't start IVF or ICSI, but try to reduce her body mass index to be less than 30. Because if she has a body mass index more than 30, the living pregnancy and the pregnancy rate and the cumulative pregnancy rate will be markedly reduced. That's number one. So before starting induction or doing IVF, dieting the patient. That's number one. For investigation, thyroid problem are very important. Keep thyroid stimulating hormone at the level of 2.5 milli international unit per liter. Even if it's 4, which is normal, never ever to start, except if the TSH is 2.5. And how can you manage that? Give the lady straight away 50 international unit Eltroxin or Etherox daily, early in the morning before any food. Number 3, start your basic investigation for assessment of the uterine causes and the tubal causes as well by doing 3D ultrasound straight away. Never ever to start with hysteroscope. If you have a normal finding of 3D ultrasound scan saying that the endometrial cavity is completely healthy and the uterine wall is completely normal and no distending tubes, never ever to do a hysteroscope. The value of the ultrasound scan to detect 3 abnormalities: abnormality in the endometrium, abnormality in the tubes, and abnormality in the ovary. So if you have an endometrioma, don't remove it. If you have interstitial fibroid with repeated implantation failure and you offer to the patient ICSI, try to remove it, because there is significant difference comparing interstitial fibroid of 3 centimeters or multiple interstitial fibroid with absence of fibroid, and they found that there is a significant difference in success rate between both of them. So if you offer to the patient IVF and ICSI in the presence of interstitial fibroid 3 centimeters and no pregnancy occur, try to remove it. What type of gonadotrophin you use? Use whatever you want. The cheapest one will be the best, but it's recommended to use human menopausal gonadotrophin for poor responders, not purified one, because they might have depletion of the LH in their body. So it's recommended now to use human menopausal gonadotrophin rather than purified one in poor responder or old age. What's about the dose of human menopausal gonadotrophin or purified, whatever you are going to do, between 150 and 300 international units. So if you have one vial of 75, you might start by 2 and maximum 4. If you have response with 4, that's fine. If no response with 4 vials, cancel and restart with the same dose. Extra amount of human menopausal gonadotrophin does not have an extra response. For luteal phase support, the best thing to use dydrogesterone, which is called Duvastol, 30 milligram a day. So it will be about 2 tablets 3 times a day. And stay using progesterone support till 8 to 9 weeks of pregnancy. This is a vulgar recommendation based on a very big meta-analysis and evidence-based. Use his meta-analysis. Which type of progesterone? Any type of progesterone are equal. When to start progesterone? Day of HCG, day of oocyte collection, day of embryo transfer. All of them are the same results, no difference. So do whatever you want. Me, myself, I would prefer to use the progesterone from the day of HCG. الايه؟
الصفحه فريز. الصفحه واقفه. خلاص اوكي.
Okay. So when to stop? As we said, that if you have pregnancy of 8 weeks, are you going to transfer +2 cysts or transfer 8 cell stage? A comparative study between 8 cell stage and the +2 cyst showed that both of them are equal in live birth rate and pregnancy. And they found that the evidence that +2 cyst is better than 8 cell stage is the weak evidence. So you might transfer 8 cell stage or +2 cyst. However, they found with analysis or retrospective analysis that +2 cyst transfer might be associated with obstetric complication in the form of premature labor, premature rupture membrane, increase the blood pressure, diabetes, and multiple and pregnancy loss. So they recommend transfer of 8 cell stage, except if you have 4 embryos, very good quality with 8 cell stage, you might give them the chance to go through development till they reach the +2 cyst stage. don't use combined oral contraceptive pills at all to synchronize the follicle for IVF. However, to avoid asynchronized follicle, in poor responder, you might use sequential estrogen progesterone. So you might use estrogen followed by progesterone, or use the progesterone alone. But don't use combined oral contraceptive pills because continuation of pregnancy of occur is low. Don't use antibiotic, corticosteroid, aspirin, or heparin. The use of Dahlia and CoQ10 have nothing to do with improve the poor anti-Mullerian hormone. However, growth hormone might be effective. In view of the expenses or high expenses of the growth hormone everywhere, the British Society of Infertility recommend not use it. As we said, if you have endometrioma, don't use it. Don't operate upon it. The standard protocol for IVF is the long agonist protocol. However, the antagonist protocol will be very effective in two cases: poor responder and polycystic ovarian syndrome. Lapse does not add any advantages. The incubator whose lapse with continuous visualization of the dividing of the cells has nothing to do. It's expensive and useless, doesn't affect the live pregnancy rate or the ongoing pregnancy. And lastly, thank you. This is the recommendation. I tried to gather as much as I can from all the evidence all over the last 20 years. Okay, so in conclusion, be very simple, very easy. Use whatever you are going to use of HMG or purified one. It doesn't make a difference. You might have a trigger and the labs has nothing to do. Okay, so let's have Dr. Abu Bakr al-Nashar presentation regarding to the new in ISHRI, because of what I said and this recommendation between the Green Top Guideline and the old ISHRI and ASRM. So let's go through the presentation of Dr. Abu Bakr al-Nashar to see what's up to date. I think most of you know what I said. مؤتمر ايه؟ So we're going to go through Abu Bakr al-Nashar, Professor of Obstetrics and Gynecology, Faculty of Medicine, Banha University, and he's one of the greatest reviewers. He's going to address us regarding to what's new in ISHRI Conference 2022. Afterwards, we are going to start, me and Dr. Abdul Gabbar, answer some question of what you sent. Okay?
بسم الله الرحمن الرحيم. I would like to thank the American Association for inviting me for this very important conference. And today I will discuss with you what's new in the ISHRI 2022 conference. As you know, this conference was held in Milan, Italy, from 3 to 6 July. It is the 38th annual meeting. Includes 97 sessions and more than 300 oral presentations. In ISHRI, we have 3 types of session. We have the keynote session, we have the plenary session, and communication session. In this year, there was a particular and specific session on ART in times of war in Ukraine. We classified the subject of this 317 oral presentation into the following: COVID, male factor, endometriosis, fibroid, controlled ovarian stimulation, embryo transfer, poor ovarian responders, recurrent pregnancy loss, microbiome, and others. Let us start with the keynote lecture. It was on the semen impairment and the occurrence of coronavirus in semen after recovery. And it was found that the virus can be detected in the saliva, in the urine, in the semen, and a very good percentage of men who recovered from COVID-19. About 25% of men who recovered from COVID demonstrated oligocryptoazoospermia. And it was found that there is a negative correlation between the interleukin and the numer necrosis factor and the sperm number. Genital tract inflammatory condition persist, and this is very important for management of the men after corona. Genital tract inflammatory condition persists at least 3 months after COVID-19 recovery. There was another talk about what's the treatment of this. It was by Sharma et al. And he found that there is oxidative stress created by the inflammatory cytokine storm by the COVID might interact with the spermatozoa, leading to changes in the semen analysis. What is the treatment in this condition? The treatment is to give antioxidant. Again, on the relation between the COVID and the pregnancy. And it was found that pregnant women with COVID don't appear to be at risk of miscarriage. This was as regards the COVID and male infertility and pregnancy. It was a plenary session on the male infertility. What is the new horizon? What is the new ideas? What is the new research? And the author raised there is a limitation of the current semen analysis. What we are doing and what we are asking this routine semen analysis has a lot of limitation. And we should have an alternative diagnostic test that can predict the fertility. Novel tests are available, and the most important than the new test is the new horizon and the new ideas and the new research in assessment of male fertility. The author raised a lot of sperm function tests, but the most important of all of these he suggested was the reactive oxygen species test. He raised the new recommendation of the European Association of Urology in 2021 when to ask for sperm DNA fragmentation testing. sperm DNA fragmentation testing according to the guidelines should be performed in recurrent pregnancy loss, and also it is indicated in men with unexplained infertility. What is the definition of unexplained male infertility? When we have normal semen parameters and we don't know what is the cause. Also, another indication of the sperm DNA fragmentation testing is the varicocele. And the varicocele may be considered in men with raised sperm DNA fragmentation, and also if there is a recurrent implantation failure or recurrent pregnancy loss. In this preliminary lecture, the author described new monogenic causes of male infertility, which can be detected by the next generation sequencing. But what is meant by the monogenic causes of male infertility? The monogenic, that's to say it is regulated by one gene or one of pair of allelic genes. And this is just a hint about the sperm DNA fragmentation and how it can be detected by what is called the halo sperm. And this is the how to detect the semen ROS, reactive oxygen species. What is the predictive value of the seminal oxidation reduction potential? Again, one of the new tests for assessment of the male infertility is the sperm ROS. And we have many methods. One of these methods is what's called the oxidation reduction potential. And according to this, he found that both sperm DNA fragmentation and the seminal ORB have a strong prognostic value in predicting fertilization, blastocyst development, clinical pregnancy rate, and live birth rate. There was a research about the relation between reduction in weight and improvement in the semen count. And they found that an 8-week low-calorie diet induced weight loss, and reduction in the weight will be associated with improvement of the sperm count. This is very good. And this improvement in the sperm count was maintained after 1 year in men who maintained weight loss. So we should encourage our obese patient, to reduce their weight, because this will be reflected in improvement of the sperm count. The third item to be discussed about endometriosis. What is new? The pathophysiology of endometriosis. According to our traditional teaching, endometriosis is defined as a chronic disease characterized by endometrial-like tissue present outside the uterus, and it is thought to arise from retrograde menstruation, the most important theory for the pathogenesis of endometriosis. However, this definition is outdated and no longer reflect the true scope and manifestation of endometriosis. Endometriosis is now considered a systemic disease, not a chronic pelvic disease. And endometriosis affects the metabolism in the liver. Endometriosis affects the adipose tissue. Endometriosis leads to systemic inflammation, altering the gene expression in the brain. And we have central nervous manifestation of endometriosis, although it is not present in the CNS. And this is very important in the pathogenesis of the pain associated with endometriosis, the pain sensitization. And this is explained the central nervous system associated with endometriosis. Alteration in the brain structure, alteration in the brain function. Again, in this preliminary lecture, the recognition of the full scope of the disease will facilitate the diagnosis and will allow more comprehensive treatment of endometriosis. So we should understand the true pathogenesis of endometriosis. In the same lecture, it was about the use of the progestogen and low-dose combined oral contraceptive pills. And the use of this is unsuccessful, not effective in 1/3 of women because what's called progesterone resistance. And the oral antagonist, which is effective alternative when the first line medication failed. And this oral antagonist is associated with fewer side effects. And this will optimize and individualize the treatment of endometriosis. Another about the endometriosis and its impact on the oocyte. We don't know what is the mechanism of infertility associated with endometriosis. Is it attributed to the impairment of the endometrial receptivity, or it is attributed to changes in the quality of the oocyte? And according to this author, it is controversial, but he maintained that studies support the conclusion that oocyte quality in endometriosis is the main factor in decreasing the implantation rate in endometriosis. And this conclusion is consistent with the documented elevation of the inflammatory cytokines, the reactive oxygen species, and the angiogenic factors in the follicular fluid and in the peritoneal fluid. Again, about endometrioma and what is new. The new treatment of endometrioma is fertility preservation. But how can we do this fertility preservation? It was addressed by Jacques Donnet, a well-known figure, and fertility preservation is a major challenge when therapeutic approaches of ovarian endometrioma are planned. How to preserve fertility in women at risk of premature ovarian insufficiency due to severe or recurrent ovarian endometrioma? We have two main methods. The first is controlled ovarian stimulation, ovum pickup, vitrification of oocyte. And this method was associated with a high cumulative live birth rate when done before the age of 35. And this raised the importance of asking the woman with endometrioma to do a fertility preservation in younger age, that's to say, not after 35 years. Another method for fertility preservation in endometrioma, which is called orthotopic, auto-transplantation of cryopreserved ovarian cortex. And nowadays we have more than 200 live births by adopting this method. This method is could be proposed to maintain the follicular pool. But what's meant by orthotopic? Orthotopic means grafting of tissue in a natural position. The natural position, which is the ovulatory fossa. Again, in the endometriosis, and this was, what is the evidence-based management of endometriosis? What is new? What is it changed? First, and this was the ICSI guidelines. I have the honor to be one of the reviewer of this guidelines. Very important. Laparoscopy is no longer the gold standard for diagnosis of endometriosis. And we have, as we know, we have 3 types of endometriosis. The endometrioma and the deep infiltrating endometriosis. Transvaginal ultrasound and MRI can be equally effective in identification of ovarian endometrioma and deep infiltrating endometrioma. But for the peritoneal endometrioma, laparoscopy is still the golden standard for diagnosis. Also, what's new in the treatment of endometriosis? The ultra-long protocol, which was recommended before in the past, is not recommended nowadays. And the antagonist seem to be effective in treatment of the endometriosis-associated pain. And it could be considered as a second-line treatment. In this guidelines, there is specific chapters on the endometriosis in adolescent and endometriosis in menopause and the association between endometriosis and cancer. What is new in fibroid? A very important question: to remove or not to remove the intramural fibroid. But before going to this, we should maintain that the size and the distance from fibroid are the most important factors for determining the effect of intramural fibroid on fertility. And it was found that a transforming growth factor is increased when the size increases. So there is a correlation between the size of the fibroid and this factor. And this factor, the transforming growth factor, will impair the endometrial receptivity. And fibroid causing menorrhagia, this is a very important clinical point. Fibroid causing menorrhagia are likely to affect the endometrial receptivity. And the myomectomy on intramural fibroid should be individualized. And if you are going to do ART, you should remove the intramural fibroid if there is decrease in the ovarian reserve, if the maternal age is advanced, if there is a history of recurrent pregnancy loss or recurrent implantation failure. What is the effect of presence of intramural fibroid with a diameter less than 6 centimeters on the reproductive outcome? It was a systematic and meta-analysis. And as we know, we have 10 types of fibroid according to the FIGO classification. And it was found that according to this systematic review, the fibroid with the intramural fibroid with a diameter less than 6 centimeters have a significant adverse effect on the reproductive outcome in IVF. What is about the body mass index and its relation to the ovarian response? All of us know that there is a negative correlation. That's to say, when the body mass index is increased, the ovarian response decreases. But this is a very large study, including about more than 4,000 IVF cycles, and found that body mass index doesn't seem to be associated with the ovarian response to gonadotropin. It is new. What is the impact of adding letrozole on the ovarian stimulation? According to this study, letrozole has no effect. Adding letrozole is associated with similar oocyte yield, similar embryo development, and similar live birth rate after transfer in fresh cycle. What is about the luteal phase support, oral, vaginal, intramuscular, and which is the best? According to this study, and it was a randomized controlled study, found that the optimal luteal phase support in the programmed, this paper addressing luteal phase support in the hormone replacement cycle on the programmed frozen embryo transfer cycle, using the third blastocyst, and he found that there is no difference. The reproductive outcome in programmed frozen embryo transfer cycles are similar, using dydrogesterone 40 milligram per day, 180 milligram per day progesterone vaginal gel, 100 milligram per day intramuscular progesterone oil, all of these are equal in the reproductive outcome as luteal phase support in the programmed frozen embryo transfer cycle. This paper is very important and raise a red flag. What's the relation between the frozen thawed embryo transfer and the cancer in children? Children born after frozen embryo transfer have a higher risk of childhood cancer than children born after fresh embryo transfer and spontaneous conception. This is a very large study, including more than 170,000 children. And it was done in Denmark, Finland, Norway, Sweden, where the registration records are very strict. And let us see the result of this very important study. The incidence rate of any cancer before 18 years of age per 100,000 person after spontaneous conception is 16. After ART is 19. After fresh embryo transfer is 18. And after frozen embryo transfer is 30. But may one ask, what are the types of cancer which are increased in the childhood when we are transferring frozen embryos? The epithelial tumors and the melanoma after ART and the leukemia after frozen embryo transfer. The next item to be discussed, what is new in the poor ovarian responders with diminished ovarian reserve. Can we use the intra-ovarian injection of platelet-rich plasma? According to this study, yes, it is beneficial, and it was found that injection of platelet-rich plasma is associated with increase in the AMH and the anti-follicle count. But this study is criticized. Our objective should be the live birth rate and not the AMH or the anti-follicle count. Another study, it is called the BISTEM study, addressing the poor ovarian responder. Are we going to do for them what is called DOW stimulation or double stimulation? And this study compared the double stimulation in the same cycle with the two conventional ovarian stimulation. And they found that there is no benefit of the double stimulation versus two consecutive antagonist cycle. This is very important, and a new study comparing between the double stimulation in the same cycle and the two consecutive antagonist cycle. What is new in the recurrent pregnancy loss? One of the causes of recurrent pregnancy loss is subclinical hypothyroidism. And what is the, this lecture was a plenary lecture, and found that the untreated mild to moderate subclinical hypothyroidism, which was defined if it is from above 4, is associated with early pregnancy loss and repeated pregnancy loss. And it is recommended to give eltroxin because eltroxin improves the pregnancy and the live birth rate. And also it's recommended to do routine preconceptional TSH and free T4 for all the women suffering from recurrent pregnancy loss or who women undergoing ART. So please, TSH is a mandatory test for all patients going to do ART, and also if there is a recurrent pregnancy loss. Once the pregnancy, we should increase the dose of the eltroxin. And according to this study, empirical dose increase by doubling the dose in the on 2 days per week. And also during pregnancy, we should ask for regular TSH measurement from 7-week gestation. How can we manage if we have euthyroid? The thyroid function are normal, but there is a positive thyroid peroxidase antibodies. Are we going to give L-tyroxine? No, there is no benefit from L-tyroxine in this condition. But it's recommended to do a thyroid function monitoring during pregnancy because this patient is high risk to develop subclinical hypothyroidism during pregnancy. And according to this plenary lecture, further studies are required to determine the role of selenium or steroids in improving pregnancy outcome. Some claims that the selenium is effective in this condition, the condition of normal thyroid function with positive thyroid peroxidase antibodies. What is new about the microbiome? About the microbiome, what is the effect of an endometrial microbiota on pregnancy? But before going to this, we should define what is the microbiota. The microbiota is the microbial taxa revealed using the molecular techniques. We have two methods for detecting the microorganism. The culture, which is can detect special types of the microbes, and the new method, which is the molecular technique, which will detect a lot of the microbes. What is microbiome? The microbiome is the habitat, is the whole, including the host and the microbial genome and the environmental condition. What is meant by dysbiosis? Dysbiosis is it changes qualitative and quantitative in the metabolic activity and the local distribution. It was found, according to this plenary session, that lactobacillus had a high abundance in the microbiota of endometrial fluid in patients with successful pregnancy after frozen embryo transfer treatment. As we will discuss, we have now commercial tests for determining the condition is lactobacillus dominant or non-lactobacillus dominant. And with the dominance of the lactobacillus, it is associated with a successful pregnancy after frozen embryo transfer treatment. And this is the available commercial test. The ERA, which is endometrial receptivity analysis, the EMA, which is endometrial microbiome metagenomic analysis, and ALICE, which is analysis of infectious chronic endometritis. Again, in the what is the importance of the ERA in the recurrent implantation failure? This study found that ERA and EMA improve. He is asking, are ERA and the EMA and the ALICE to improve the implantation rate and the clinical pregnancy rate? And the answer of this study, ERA significantly improves the clinical pregnancy rate in women with recurrent implantation failure. But there is no difference was observed in EMA or ALICE in improvement of the outcome in case of recurrent implantation failure. Lastly, the others, does advanced paternal age influence the live birth rate? This was a very large study, including about 18,000 of fresh IVF ICSI cycles, and found that the live birth rate declined with paternal age 40 years, but not when the female partner is less than 35 years. That's to say, if we have an old husband married to a young female, the live birth rate will not be affected. But an old one, that's to say, his age is above 40, married to a female old, that's to say, above 35 or above 40, this will be reflected on the live birth rates. Live birth will decline. Another study on what's called the subtle distal fallopian tube abnormalities. What is meant by subtle distal fallopian tube abnormalities? The fimbrial agglutination, the accessory ostium, the fimbrial phimosis, the accessory fallopian tube. And according to this study, management of this with laparoscopy was associated with a natural pregnancy rate 46%. Another study which is new and which is astonishing study, how to manage the niche. And the niche manifested with post-menstrual spotting can be managed with medical treatment or can be managed with hysteroscope. And this study compared the use of the Mirena and hysteroscopy for treatment of this condition. And he found that at 6 months after treatment, the median total bleeding days after Mirena was only 4 days, shorter than 13 days after hysteroscopic niche resection. And this study recommended the use of Mirena in treatment of niche and not to use hysteroscopic resection in treatment of niche manifested with post-menstrual spotting. This was the end. I would like to again to thank the American Association for inviting me for this important online conference. See you and thanks a lot. Bye-bye.
I think Professor Nashar is with us online, am I right?
Yes.
Professor Nashar, are you there? Professor Abubakar?
Yes.
Okay,
Good
hi, how are
evening,
you?
Dr. Yasser.
Okay, so it's my pleasure actually to be here with you, and I'm happy to see you. It's very difficult to see you. Dr. Abubakar Nashar is my neighbor actually, but it's hard to see him every maybe 6 months. I might see him just come and go to the garden, and it's very difficult to see him. He's busy all the time. It's wonderful, wonderful what you have done. I don't think that anyone can do what you have done, and going through history and debriefing it like that in no time. It's wonderful. But I have 2 questions. So if you allow.
Thanks a lot, Professor Yasser, and it's my pleasure to meet you all the time.
Thank you very much. So you raised 3 points. All what you raised are wonderful, but let me to go through what you said regarding to lactobacillus. So if you have a lactobacilli, this is the basis of what you said regarding to endometrial receptivity and frozen embryo. So does it mean that if you have lactobacilli in the endometrium, the receptivity will be higher if we transfer cryopreserved embryo than others?
The answer yes.
If it's set, what's the mechanism? Because lactobacilli might be associated with a change in the pH. So the pH will be changed from acidic to alkaline media, which sounds very strange. And what the mechanism of action in increasing the implantation, which sounds very, and if it's set, does it mean that giving to the patient, for example, yogurt in the vagina after embryo transfer, especially for cryopreserved one, will be helpful, and why it's cryopreserved, not fresh one?
It is applied not only for the cryopreserved, but also for the fresh. And I have a review published in the MIFS journal about the microbiome and fertility and IVF. Still, there is a research and there is no solid
information about this. And as I mentioned, even the available commercial tests are doubtful. But according to the studies now available in the market, a test which can differentiate this endometrium is lactobacillus dominant or non-lactobacillus dominant. And it was found that the lactobacillus dominant is associated with increase in the success. And as you mentioned, there is some studies to increase this, but by using the probiotic, right? And to treat and to make the endometrial cavity to be lactobacillus dominant.
So what's the mechanism again? So as you know,
the mechanism is very complicated through the lactobacillus, how it will increase the markers of the endometrial receptivity, the interleukins, and other markers.
That's fine. So let's go for the second. What's ERA? I can't understand. What's ERA?
ERA is endometrial receptivity array. It is a genetic test depending on 137 genes. It was invented by Simon in Barcelona, and it was propagated. But according to the evidence, it is not effective in differentiating between the receptive endometrium and the non-receptive endometrium.
So
all the studies came from this center of Simon in Barcelona, and according to the evidence, it is not effective in differentiating between the receptive endometrium and the non-receptive. He invented this test to individualize the time of embryo transfer, right? But it was found to be not effective in this.
But you commented that ERA might be acceptable, because I remember that
yes, this is according to we presented what is new or what is mentioned in the conference, but this not mean we are in agreement with this.
That's right. So
in my review in the MEFS journal, I criticized all of this, and still the endometrial pattern is a better predictive of endometrial receptivity than the ERA test.
Correct me if I'm wrong. Maybe 3 years or 4 years ago, this array started to appear, and I remember that ISHRI itself was criticizing this era of array and said that it's just commercial and we are not in need to that.
I quite agree with you. It is commercial, and it was propagated in many countries, especially in the Gulf area, but of no value. And I want to mention what's mentioned by Kaspar. He mentioned that the endometrial pattern is more sensitive than the ERA test in predicting the endometrial receptivity.
That's fine. Let me go through the bomb that you said it at the end of your presentation, which is surprising for everyone. The comparative study between Marina Coyle and
yes, it was surprising for me also, Dr. Yasser.
Really very strange.
Very strange. And that's why attending the conference, it is not Quran Kareem, right? Yes. But we should mention what is meant honestly and not changing. It was surprising for me, and according to the best of my knowledge, the hysteroscope is more effective in treatment of the niche. This is my opinion.
I agree with you. Theoretically speaking, if you are going to insert Mirena coil, it will cause some sort of atrophy of the endometrium, so bleeding will decrease. And as well, the secretion coming from the cervix will be hardened or thickened, so it will decrease. But if we remove it, do you think pregnancy will occur? I think miscarriage will occur again and again and again.
You are, Doctor, the last study was addressing the patient to not want to conceive only she is suffering from post-menstrual bleeding, right?
Because it's just spotting from the bucket, yes.
Yes, and the as you know, the treatment of niche presented with bleeding, we should start first with medical treatment, right? And the medical treatment may be in the form of progestogen. According to this study, the Mirena is effective, but it may be, if you go to the details of this study, the long term, as you know, the first 3 months after application of Mirena, it may be breakthrough bleeding, but after that there will be amenorrhea, and maybe the explanation of why the Mirena with the long term is more effective than the hysteroscopic treatment of niche.
So what do you recommend?
No, it was surprising for me, and that's why I brought it. And please, we are not discussing a fact or an evidence-based, but we are discussing what is presented in the most important conference in the OB-GYN, maybe in the world.
Thank you very much. It's wonderful, to be honest, what you said, and we might spend the whole night just to discuss, because I like very much to discuss the aspects what you said with you and to compare it with ASIM, Rich Journal of Obstetrics, blah 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 blah. But it's wonderful. Thank you very much, Professor Dr. Abdul Gabbar. If you wanted to ask Professor Abu Bakr Nashar anything regarding to what's up to date in ISHRI, or to have any comment or to ask question regarding to his presentation. شاهر
معاك يا دكتور.
unmute Professor Hassan Abdul Gabbar. Hassan Abdul Gabbar, unmute.
Professor Abu Bakr, thank you very much for this is very interesting.
ومنور يا دكتور حسان.
الله يسلمك, الله يبارك فيك.
الله يخليك يا حبيبي.
But I don't want to ask a question, but I want to admire you for what you present, because I was in Milan and I attended the ISHRI, and 90% of what you said I didn't hear about it. It was really nice that you could summarize it for me. Now I could say that I was in Milan in ISHRI and this is what I got. Actually, it was because it was packed with a lot of lecture and a lot of presentations. It would be extremely difficult to jump from one room to another.
97 session and more than 300 oral presentation.
It was very difficult, but definitely we
it was
benefit
difficult for me also to summarize all of this.
Yeah. The last one, Bardo, we will go to the Mirena. I think the outcome in that patient is to improve their symptoms only, to improve their abnormal bleeding, and this is why it succeeded. We know that if we put a Mirena for somebody who has a small, for example, small polyp, they might get better and they might have no bleeding. Right. So it's the same. Maybe it's the same mechanism.
Yes.
But I don't know about long term. Yes. But definitely there will be no improvement in pregnancy. We're not talking about pregnancy.
Sure. For contraception also.
Yeah, for contraception also. Yes.
Yes.
Thank you very much for your presentation.
You're welcome. I am very happy to see you, Dr. Hassan. Extend my regards to all in Saudi Arabia.
Thank you. I will, inshallah.
Thank you. I think Professor Abu Bakr Nashar, it's wonderful. Thank you very much. But if you don't mind, stay with us, because we are going to start. Do you know, Professor Abu Bakr, me and Dr. Hassan spent about 9 hours. Dr. Hassan took from his time 9 hours sitting that in his place. Okay, and me as well. But as you know, he's dressed up in greenery. So he used to do operative intervention and pray and get back. That's why. However,
no, it's
enjoying.
just easier.
Yes, yes, it's wonderful, to be honest. So stay with us.
Thank you.
We are going to.
I have Dr. Yasser. I have another lecture at 9 o'clock, inshallah.
9 o'clock.
Yes.
Okay. So I don't waste your time, but if you can stay with us.
Sure, I am very happy to stay with you, Dr. Yasser and Dr. Hassan.
It's good.
Thank you.
Just for maybe 20 minutes, we received lots of questions and queries. So Professor Dr. Hassan is going to go through the first paper, and I will go through the second, and we are going to share the third. So if you don't mind, share us in answering.
Dr. Yasser, I received these questions. There are a lot of questions. I think it will take a very long time. A very long time to answer this.
We are not going to answer all the questions, but Dr. Hassan selected a few of them.
The relevant question, though. The one we need to answer. Yeah,
we'll answer the third one.
Yeah, I think we should start. Like, for example, the first question, somebody wants to know about ovulation of induction. And I usually say that ovulation induction, if you understand the physiology, it will be easy to understand how to induce. And knowing clomiphene citrate is the best treatment for induction of ovulation, knowing that it has to be given in the day 5 of the cycle, so it will give you monofollicular induction. It's better than giving it on the day 2 or 3. Definitely, people, they wanted to have more induction, so they will give it on day 2 or the day 3, so they will see more follicles. That doesn't mean having more follicles. That doesn't mean that pregnancy rate will be increasing. But definitely, if you understand that clomiphene citrate work by the dominant follicle, and then selecting the dominant follicle at day 5 and make it bigger, and this is the induction. Definitely, in the last few years, there was a debate about letrozole versus the clomiphene. People, they used to use the first line of treatment as clomiphene, and then they say the second line of treatment is letrozole. But I think they are changing that letrozole can be used in concomitant with clomiphene. It is exactly like clomiphene, giving the same result. But this is maybe answering for the ovulation induction. What is the treatment of low AMH? I think it was gone through very, very nicely, and we had a very nice presentation about the AMH treatment of AMH. Progesterone used for BRIM ovarian stimulation protocol. And this is something not new, as mentioned. It was like started in 2015, and it's usually given progesterone instead of the agonist and antagonist, and that would make maybe patients more comfortable having oral tablets instead of having an injection every day. Till now, until 2022. The results are promising, and I think with evidence that it is going to be maybe one of the new protocol of induction of ovulation to bring the ovarian stimulation. Again, what is the difference between long and short protocol ovulation induction in IVF cycle? Of course, when we talk about induction in IVF, I think there is so many protocols. The long protocol, which you use the antagonist the month before you induce the patients. The short protocol, you started the induction in the same month. There is something used to be called the ultra short protocol, where they give the antagonist only for a few days. And now we have the antagonist protocol, which is either a single shot antagonist or multiple shot or multiple doses antagonist. At the end of the day, all the aim is to prevent LH. Each one of those have different advantage and disadvantage, but I think people who are in IVF, once they started to accommodate and adopt one of the protocol, you will find them hardly choose different type unless there is an indication for that. This is regarding the short and long protocol. What about induction of somebody who has an ovarian cyst? This is also debatable, very debatable. People, they say, if you have an ovarian cyst less than 4 centimeters, you can induce your patient. And at the time of the IVF, you can aspirate the cyst and then aspirate the oocyte, or aspirate the oocyte and then aspirate the cyst. Other people, they say you have to remove it. There's no good evidence that removing it will improve the pregnancy rate unless it is more than 5 or 6 centimeters. And that was discussed with Dr. Hassan when he was doing ovarian cystectomy.
But by the way, for
yes.
ovarian cyst, I used it to measure this ovarian cyst at the basal level, first, second, or third day. If we have an ovarian cyst, I do something a little bit different. I measure the estradiol level. If the estradiol level is basal, so it's not functional ovarian cyst. So I used to start induction straight away, because from my point of view, that if it's functional ovarian cyst, so high estrogen level will be there, so there will be a discrepancy between the age of the endometrium and the follicular burst afterwards. Meanwhile, if we have an ovarian cyst and the estradiol level is low, it's 50 or less, we can induce straight away. This is from my point of view.
I think it's reasonable. Yeah, it's very reasonable. And the next question was the role of ovarian oocyte preservation. And I mentioned in my presentation about oocyte. Oocyte is I would say it's a new way of preserving the fertility. We could use it in fertility preservation. Until now, there is oocyte preserved for the last 10 or 14 years. There is pregnancy out of the frozen embryos, the frozen oocyte. So maybe it will get improved in the next few years, but definitely it has a role in IVF cycles, and it might be a new technology that it will help us in the future. Method of fertility preservation, I presented that either by either the sperm or the embryo or the oocyte. And I remember in the past we used to have patients for example, they have leukemia or lymphoma, and they come and freeze their sperm for the future. They wanted, if they after they get the treatment and they get married, they can utilize the sperm if the sperm if they don't have sperm at the time of the IVF after getting married. طبعا of course embryos, this is well known, and especially done for patients who are married. They will have embryo freeze, and once they get the treatment, they had the embryo transfer, and it's very well known. The ovarian oocyte is new, but even now there is something called ovarian tissue preservation. And I've seen a lot of people, they do it through the scope, and they take a strip of the ovary and they freeze it. And after patients get the chemotherapy or radiotherapy or whatever, they return it back into the ovary. Or if they wanted to have it just for hormonal replacement therapy, they can put it anywhere in the omentum or under the skin. So ovarian tissue freezing, I think it will have more in the future, and it will be an easy and maybe easier than oocyte retrieval if we have evidence that it's good. How to overcome premature ovarian failure. We talked about it. The ovum pickup technique. Ovum pickup technique. The standard ovum pickup technique is by transvaginal route. This is in 2022. Nobody will do other than transvaginal. But definitely, as mentioned before, that if there is an obstruction to the transvaginal, then you could use the transabdominal, and I went into detail about this method. How to deal with the unexplained infertility? This is a very interesting and difficult question to ask, and very difficult to answer. Unexplained infertility, if the husband and wife, they are completely normal, and those contribute to maybe 15 to 20% of the population, of the infertility population, they have no reason for them not to get pregnant. And we, as an infertility doctor, what we say, okay, let's induce her ovulation. We induce her ovulation, and then nothing happened. Then we induce ovulation again, nothing happens. Then we tell them, oh, go and come back maybe another few months, and they come back. And then time will go, and then when you reach 3 years or 10, then you said, oh, let's do some assistant. And then we change the type of induction, and maybe we do IUI. And that was the standard of treatment. And if they don't succeed after 3 successful IUI, or if they pass more than 4 years, then we offer them IVF. And believe it or not, but I don't have a statistic, but I know that there is evidence that those who are considered to be infertile because idiopathic infertility, they will be having a problem even in IVF, and maybe they will have some genetic problem or some fertilization problem, or they usually, we call it idiopathic, but there is definitely there is a cause, but maybe we don't know about the cause. What is the reason for them? But definitely all the infertility doctors, what they do induction, then IUI, and finally they do IVF. And if IVF failed, they might ask them for genetic testing. The best treatment for secondary infertility due to fallopian or cervical factors. Fallopian tube, if you have a problem with fallopian tube, the best thing is to go for IVF. Cervical factor, because cervical factor is not considered to be a good reason for infertility, but we do usually put cervical factor. And if there is a true cervical factor, I think IUI will solve that problem. Again, because we rarely find somebody who has a cervical factor or infertility for cervical factor. But if we do, and we are convinced, then I think IUI will help those category of patients. Case of infertility without cause, had idiopathic, we just mentioned it. Unexplained infertility, what is the percentage? Definitely all the percentage of causes of infertility is increasing, especially idiopathic infertility. It used to be 15%. Now I went through it last week. It was reaching up to 20-25%. Ovulation, for example, ovulation is increasing. Male factor is increasing. The other factors, the immunological and cervical and whatever, these are the one which is actually decreasing. But definitely it is increasing. Update infertility, ovarian reserve. This one, if you have a problem of ovarian reserve before and after chemotherapy, usually before chemotherapy, you have to induce to make sure. But if she has the ovarian, if she had the chemotherapy or radiotherapy, it will be very extremely difficult to stimulate an ovary which receive radio or chemotherapy. But you have to try patient who had already had the chemo radiotherapy. You have to try again with them. This is remind me with a case who was she had a leukemia, and then she received chemotherapy, radiotherapy, and everything. And after 4 or 5 years, they got married, and then she came to have a to be pregnant. She wanted to be pregnant, and unfortunately, her FSH was very high, and her ovarian reserve was very low. And during the discussion, she said, "I want to sue the doctor who gave me the chemotherapy, who treated me." I said, "Why?" She said, "He did not tell me that I could preserve my my eggs and oocyte for cryopreservation." So people, they become aware of this. But again, if you remember in my conclusion, I said the conclusion and the message is not only for OBGYN doctor, but also for medical oncologists, so they can refer the young patient to the center where they can preserve their oocyte. I think I will stop here and leave the other half of the question to Professor Yasser, and maybe he has to choose, because there are so many, some of the relevant questions, because I think we are late. We kept people very late, but hopefully we will finish soon. Professor.
Okay, thank you, Professor Hassan. So it will be just spotlights. So what is the role of metformin and anti-prolactin in induction of ovulation? Metformin might be used in just one case: if you have high fasting insulin, in cases of polycystic ovarian syndrome. If you have normal fasting insulin, don't use. Anti-prolactin might be used if you have high prolactin level. Management of unexplained infertility, straightforward. Intrauterine insemination with super ovulation for 2 to 4 times. If failed, so it will be straight away ICSI. In cases of down regulation, when drugs are unavailable, what types of down regulation that you can do? Progesterone, which type? Steronate Nor, 5 milligram, 1 tablet 3 times a day, starting from the first, second day of menstruation, and keep using it, and start induction of ovulation from the 3rd day. And keep using the progesterone till the day of egg collection. Afterwards, stop, and never ever to transfer. Cryopreservation, and let the patient have menstruation. How can I manage bicornuate uterus? Cerclage. but don't do McDonald's circulation. Do modified circulation to be high and competent. What's the maximum time for ovulation induction? It's between 4 and 6 times. Why? Because the normal pregnancy rate following the induction of ovulation or spontaneous ovulation is 20%. So you might have between 5 and 6 times to have induction of ovulation to say, is it effective or not? Treatment of hypoplastic uterus, I mentioned it before. IVF with elevated E2 with normal FSH and 40 years. If you have basal high estrogen level more than 50, say 80 or something like that, it means that 2 things. The quality of eggs not that good. Besides, there is discrepancy between the endometrium and the follicular growth. For monofollicular induction, the only medication to induce ovulation with high estrogen level is letrozole, because it will cause growth of follicle with low production of estrogen. So you will correct the high estrogen level so as to reach to a normal level of estrogen at the time of ovulation. This time to have sex after giving hormone second day, or maybe the first day, because the minimum duration of sperm living is 3 days. Management of an irregular cycle. If she doesn't want to become pregnant, combined oral contraceptive pills. If she wants to become pregnant, a check for the cause, have a hormonal profile, mainly prolactin and TSH and FSH and LH, and induce according to that. How to increase endometrial thickness. This is a big story. Let's say that we have many things, but you might add estrogen. If you have poor endometrium, give estrogen between 2 and 6 tablets a day. However, this estrogen might prevent follicular growth and cause premature luteinization. That's why the only thing to give is to give induction of ovulation using HMG. But if it doesn't work, PRP might be efficient. What's the percentage of gender selection of IUI? IUI had nothing to do with sex selection. If the patient have one blocked tube and she received multiple cycles, if you have one blocked tubes and she received the stimulation, you might use IUI, because the removal of one tube doesn't cause reduction of the pregnancy but to the hub, but removal of one ovary might be associated with that. When is the best time for IUI after trigger of the follicle? It's 40 hours. Give HCG 40 hours and transfer the semen. How can you manage infertility with mild hydrosalpinx? There is nothing called mild hydrosalpinx. If you have closed hydrosalpinx according to ICSI recommendation detected by ultrasound, so disconnection and salpingostomy, both of them, disconnect this tube from the uterus. If it's bilateral, refer to IVF. If it's unilateral, you just disconnect and stimulate, ovarian stimulation. How can deal with azoospermia? Do FSH-LH. If FSH and LH is low, start to use human menopausal gonadotrophin. If it's high or normal, do testicular biopsy. Rule of aspirin in ICSI cycle had nothing to do. ICSI had nothing to do with aspirin, metformin, dopamine antagonist, dexazone, vibramycin. It's not evidence-based. Thank you very much. If you want any question, so you might send it for the American Association, and we'll be more than happy to answer this question. Lastly, thank you very much for everyone attending this meeting. And thank you, Professor Dr. Abdel Al-Gabbar, for staying with us for long time. Hope we have a successful meeting that might be fruitful for everyone. And sorry to keep using English language, because we discovered that we have lots of people from America, from England, and they are from India as well. They cannot speak Arabic well. That's why we try to speak in English all the time. Thank you very much, and hope to see you soon. If you have any comment, I will be more than happy to say.
Thank you, Prof. Yasser, but I want to say something very important. I thank the American Association and I thank them again, but I really want to thank the speaker. The speaker, they were selected, they were very good. They had from basic science to clinical to evidence-based presentation. And I'm very sorry for the audience because they stay for us with us 8 or 9 hours, but I'm sure it is fruitful and there is a lot of knowledge and information. And I would thank you all. Thank you, Yasser. Thank you, Dr. Najwa. And I leave the microphone for Najwa to say something.
Thank you very much.
Thank you all, and I hope you enjoy with us, all doctors, and thanks for all professors who support and do this program. في ايكو، فانا بشكركم جدا جدا جدا، وشكرا جدا جدا للمجهود اللي اتعمل في الاونلاين كونفرنس او الاونلاين هاب، and اتمنى ان شاء الله باذن الله كلكم تكونوا موفقين. ميرسي جدا دكتور ياسر، ميرسي جدا دكتور حسان، انتوا تعبتوا بجد في البريباريشن. دكتور ياسر كان كل يوم الصبح يتصل برضه بالبريباريشن. دكتور حسان ادانا محاضره جميله جدا، والاسئله الاجابه بتاعتها روعه. شكرا لكل الدكاتره اللي شاركت في البروجرام. البروجرام ان شاء الله هيكون موجود على اليوتيوب شانل، علشان اللي ملحقش يحضر من الصبح بدري ان شاء الله باذن الله هيلاقيه بالكامل على اليوتيوب شانل. Thanks so much. تصبحوا على الف خير. خلي شاري، خلي اللينك بس ثواني.